the faculty members and delegates. I welcome you all to the virtual meeting on Innovations in Oncology and Immunology Insightful Learnings from ESCO 2023. Immunotherapy is a broad category of cancer therapies that triggers the body's immune system to fight cancer cells. These cancer cells frequently change or mutate, helping them evade the immune system, which protects the body from disease and infections. Cancer immunotherapy drugs are designed to alert the immune system about these mutated cells so it can locate and destroy them. The meeting will provide the opportunity for oncologists, resident students, clinicians, and scientists to gather and learn about the new advances and to exchange scientific ideas and experiences in a distinctive environment. It will elucidate the recent trends and advancements in the field of oncology and immuno-oncology. The program activity shall be led by experts and distinguished speakers from different leading institutions. I am happy to share that for this virtual meeting, we got over 200 plus registrations. These experts are from over the globe, covering major parts of India like New Delhi, Bangalore, Gujarat, Mumbai, Chennai, and a few names. I'm overwhelmed to share that a few of them are from Sweden, Spain, UK, Pakistan, UAE, and US. With this, I would like to invite our program director, Dr. Dinesh Pendharkar, one of the senior most medical oncologists in the country and is the director of Sarvodaya Cancer Institute, Faridabad. He is also the chairman of National Cancer Society, past president ISO and ISMPO, past chair of the International Affairs Committee of the American Society of Clinical Oncology. Thank you and over to you, sir.
Good evening, everybody. This idea of immuno-oncology came to us because there is probably the largestly, most widely being prescribed drugs. I don't say being used because unfortunately our patients majority cannot afford these drugs, but we are supposed to prescribe them. We are supposed to know them because we don't know who would buy the drug, who would not. So I'm sure our knowledge has to be really very up to date and it's changing on a daily basis. So we thought we could go back to what we learned from the recent big meeting, ASCO, and probably maybe we can do some changes in our practice post the data. So idea of this meeting was to review immuno-oncology per se and basically review it based on the data from ASCO. I am really grateful to all the faculty members from all across the country and especially from Roseville Park who have consented to present in this meeting, to present the data. And I'm sure this meeting would really give us a lot of insight into immuno-oncology. Priyanshi, back to you, and let's start with Dr. Anita.
Thank you so much, sir. Now let us begin with the program. So the first half of the program is on immunotherapy in lung cancer. And our first speaker, Dr. Anita Ramesh, she is the Senior Consultant in Department of Medical and Pediatric Oncology, Kaveri Hospital. And she's going to speak on confirming and reinventing the standard for NSCLC. Thank you and over to you, ma'am.
Yeah, can you see my slides, Priyanshi?
No, ma'am, not yet.
Okay, otherwise you have my slides also, no?
Yes, ma'am. Should I share?
Anything is fine.
Okay, ma'am.
Thank you, Dr. Pendharkar. I hope you can see me and as well as hear me.
Yeah, definitely.
Yes, nice to be here in this meeting. It's a good concept and for starting off with the immuno-oncology session. Yeah, Priyanshi, can I have my slides, please? Yes, I bring warm greetings back home at Chennai. Okay, thank you very much. Yes, now you know what, like how Priyanshi started, the immuno-oncology is picking up all over the globe. Yes, in India, only 5% has access to these. And if you see the recent Globocon data from India, that is the 2022, which I put up, 5.5% of lung cancer are new cases. When you take all the sex and all the ages together, that's as far as India. And it's the fourth common cause of cancer, and tobacco still remains the main etiological factor. And if you come to the mortality and the prevalence, it's ranks fourth and the fourth cause of cancer-related deaths. Next. So that tells us how much is the burden. And that speaks about 80 to 85% or even 90% of non-small cell lung cancer, all globally, all put together. And histology base, these are the subtypes, and still the histology in an immuno-oncology error holds good. So never refrain yourself from doing a histopathology and IHC. These are different types of molecular subtyping, and you have the EGFR, you have the ROS, RET, KRAS, and the number of molecular markers are increasing over a period of time. Next, please. These are mutation-driven treatment of the non-small cell cancer. Biomarker testing has been used to guide treatment decision in these advanced non-small cell cancer, and it's increasing over a period of 10 years. And now it is quite relevant that even in early stage also, as well as it's must in for advanced stage and metastatic and relapsed cancer. What should you do after a CT-guided biopsy of a PET positive area in the lung, or a CT scan showing an SOL in the lung, or any metastatic type? Two-cut biopsy is still the gold standard. If the patient's general condition is not good, please do an FNSC. Run the other immunohistochemical matters like P53, TTF, napsin to differentiate primary, secondary adenoscomas. Whereas if facilities are available, and I'm sure we all hinted at less than 10% of the Indian patients can do afford, we can run the NGS or do a limited panel. That's what I do. I do the panel which is targetable to rule out the targets in these tumors, particularly EGFR. I run the ALK, ROS, RET, beta, PD-L1, and few of the markers, which has a drug against it. And this will also help us to these use for the targeted treatment for these patients and based on the biomarkers. And we have drugs, and precision oncology is the talk of the day. Several guidelines method in the ASCO, NCCN, ESMO, the CAP have developed evidence-based guidelines, and we know what drug to use against these targeted selection of the population. Now, if you see early stage, this was all happening in late stage. Now come to early stage. Yes, if you have an EGFR positive disease in an early stage of cancer who has been operated by the CTVS surgeon, EGFR mutation in this situation is it's treatable. Yes, we have drugs in the adjuvant setting like osimertinib, which will help to improve patients' outcomes. So evidence supports that we can use molecular testing even in early stage, so that molecular oncology is even proceeding to earlier lines, stage 1B, 2A, 2B, 3A, resectable disease. Yes, we have a targeted drug. Next, please. So if you see the guidelines with these targets on the treatment decision as the ASCO, ESMO, NCCN, and the CAP, that is the International Lung Consortium, tells that EGFR, ALK, ROS, PD-L1, beta, NTRK. So NTRK drugs are not available. Yes, MET, exon 14 skipping drugs are available now in India, but the first 5 remains the most important thing. Look at the PD-L1 expression. PD-L1 expression comes by default in all the, whether you do limited panel or whether you run the NGS. And because there are immuno-oncology drugs which are now coming into the upfront in use of these lung cancers. Next, please. So our way to go about this, first find out the actionable biomarkers and which approved therapies. And you have them, and that's the chart where it is present, and try to target them. The following biomarkers have drugs in advanced non-small cell cancer. They have approved therapies. They are approved in the guidelines, and they are changing rapidly, and there are first generation. Now you have a second generation, you have third generation to overcome the resistance. Next, please. So targeted action and targeted therapy is the talk of the day. Yes, prepone it, come to early stage, 1B, 2A, 2B, 3A operable, those cancers, yes, you can use for adjuvant setting. Next, please. Now, if you see the staging cancers, as I told you initially, you prefer to do a CT, MRI, whatever is available. A PET, yes, fine. Brain MRI, don't miss if you're not doing a PET CT. Yeah, either you do a biopsy, a CT guided biopsy, or a EBUS guided biopsy. It's very, very mandatory, or a VATS thoracoscopic biopsy. Next, please, is very important. Pathology and molecular oncologists should be a part of the therapy. And sensitivity and specificity, we know. Next, please. And coming to the next, please, the staging is very, very important. And the stage 1, 2, 3, where you have the targeted therapies and the immunotherapy. And once we have diagnosed as locally advanced, or stage 4, then the immunotherapy and chemotherapy with supportive care. Next, please. So over a period of time, we have seen how we have advanced. The talk of today's was how we have overcome and how the landscape has changed. So 5 years recurrence in stage 1B, 2, and 3 was in the range of 40 to 70%. But then with the advent of the adjuvant cisplatin, radiation, and now with the use of targeted drugs, there is improvement. The overall unmet survival needs, okay, of disease recurrence and death following surgery and adjuvant is come across highly with the molecular testing. Next, please. So these are the surgical things that we do, and definitely a CTVS surgeon should be a part of the multidisciplinary approach. Next, please. Remember, these all tumors needs a tumor board discussion before we proceed. And that's the schema of the standard of care of resectable non-small cell cancer, where surgery with the curative intent, and then you get into adjuvant chemo, radiation, and adjuvant use of the anti-EGFR drug, that is the osimertinib, which is approved. Next, please. Now, if you have in these patients, apart from the EGFR mutation, which you see in 1B, 2, and 3A disease, definitely the two curves are separating when you use the osimertinib. It's highly significant p-value, and it goes up to disease-free survival in both the stages, hovering around 75%. And that's a big figure we have seen in the recent days. Next, please. Coming to the change in practice from here, and next, please. And in patients who have complete tumor resection, it's a remarkable advancement in the treatment of lung cancer. Even in unresectable lung cancers, if you see the tumor, the nodes are involved in advanced stage. Next, please. 3B and 3C. The concurrent chemoradiation in non-small cell lung cancer. Even if you go for a sequential chemoradiation, so these patients, what happened over a period of time, if you see the chart, they relapse, okay? They get the disease back, and 40 to 50% of them fail. So now we have a definitive treatment pattern. In these favorable outcomes, those patients after chemoradiation having a stable disease or achieve partial remission. And these are the patients where you can plan for using an immunotherapy. Next, please. So a definitive CTRT followed by consolidation in locally unresectable non-small cell cancer is the talk of the day, or has become the standard of care in these patients. Next, please. Many drugs has been tried, none of them. Next slide, please. Many drugs has been tried, but not much. Consolidation, chemo, or radiation post-CTRT have demonstrated any benefit. So that was an unmet need. Patients relapsed. We did not know what to do with them. Next. Now, coming to the era, now with the Pacific study, the drug durvalumab, and that's the immuno-oncology sector, for 12 months have improved progression-free survival, overall survival, duration of response, and the response rate. And as I told you, stage 3 advanced cancer, not progress with CTRT, they were the people who are eligible for this study. Next. And that has now become a standard of care, the specific study results. And so the induction chemotherapy prior to study, and then giving the concurrent chemoradiation, and followed by consolidation with the immunotherapy. Next, please. Again, the number of patients receiving this is very less, but definitely the overall 5-year survival has improved to 42.9% with the use of durvalumab maintenance therapy. So that's remarkable. And if you see, the p-value is highly significant, showing that we have done really good in the sector. Though it may not be it may be a 10% benefit, but that's quite big for this type of cancers where we did not have anything to give. Next, please. Now, coming to the first and only approved IO to demonstrate a 42.9% OS at 5 years. And again, that's again a remarkable thing which did happen as far as lung cancer is concerned, which is non-metastatic, non-relapsed. Next, please. So coming over, next please. In the progression-free survival also, the graph separates out and there is almost a 13-14% difference. And again, the first and only approved immunotherapy to sustain and durable progression-free survival. And we get a 33% benefit at the 5 years. Again, with the significant p-value, the graphs are very impressive, giving you a hope. Yes, if there is no logistic issue, durvalumab can be a drug which can be used for these patients. Next, please. And in the Pacific study, any histopathology, any PDL status, you see all the subgroups almost favors durvalumab arm better than the placebo. Next. Coming to the metastatic disease, you know, more than 60%. Next, please, where we only talk about palliation, where we talk about quality of life, disease-free survival, overall response rate. We are, apart from the targeted, once you separate out the non-mutation, we look into the PDL status, whether we are going to do anti-PDL1 or PDL1 or CTCL. Next, please. So immunotherapy, targeted therapy remains the drug of choice. And these are the TKIs, first and third, second, third generation. Next, please. So, and coming to the inhibitions of the EGFR, we have the three lines. Afatinib is famous for its atypical mutation. Osimertinib, yes, you can, is approved in first line. It inhibits the exon 19 and L85R inhibition of T790 mutation, and it's approved for that. And it is quite tolerable and it is expensive. Less people can use it, but it is a drug of choice in this situation. Next, please. Okay, so these TKI become a drug of choice, improved in overall response rate, progression-free survival, and we don't talk about chemo. And many of us have completely switched on to these TKIs. Next, please. And yes, the third and second generation did show an improve in the lung response rate than the first generation, and they have a better CNS penetration, and they have able to overcome the resistance and shows a statistical significant improvement in the median overall survival. And now in lung cancer, with these targeted drugs and all, we can talk in terms of 36 months of overall survival, which we never thought to tell our patients that if we can sequence you properly and do everything, we can give you a just prolongation of life up to 3 years. Next, please. Okay, coming to the other patterns of the drugs, and if you see dacomotinib is also an approved drug, it is all brain mets were excluded, and then this also along with afatinib is also a drug of second line, which had made a lot of difference. Next, please. Okay. Now coming to the head-to-head studies, second and third generation, significantly longer progression-free survival was seen with the higher the generation of the TKIs because of more penetration. Next slide. Now coming to few words upon the PDL1. So if you have a PDL1 less than 1, or yes, don't give the immunotherapy. If you have a PDL receptor about 1 to 49%, yes, platinum pemetrexed is approved with pembrolizumab, platinum, Taxol's bevacizumab, and with atezolizumab, and albumin-mined paclitaxel, carbo with atezolizumab is an approved drug. And if you have a PDL greater than 50, just give pembrolizumab. It's approved, or chemo and pembrolizumab together, where a platinum with pemetrexed per pembrolizumab. Even atezolizumab is also approved, a single agent. So provided your tumor does not have any driver mutation. Yes, next, please. And we have heard how the immunotherapy has improved over a period of time, and more or less immunotherapy is coming. Usually we all talk about targeted drugs, and now we are changing over to the immuno-oncology and bringing immunotherapy. Even pembrolizumab is approved in the adjuvant setting, where we saw osimertinib, and when you do the biopsy, as you do the EGFR, you can also do a PDL1 status. Tells you pembrolizumab is also a valid drug for the adjuvant setting. And coming to metastatic relapse cancer, it is included in the 8 genes panel or in the NGS, or if you do a liquid biopsy, look for the PDL1 status, CPS score, TPS score. High CPS, TPS score with a PDL1 more than 50%, please give single agent immunotherapy, pembrolizumab, atezolizumab. Nivolumab is approved in second line, but it is also moving in first line. And if you have a scoring between 1 to 49%, yes, use it with the chemo combination with platinum or pemetrexed with taxanes and pembrolizumab, atezolizumab. And over a period of time, we have seen that overall survival of non-small cell cancer has changed. When we were talking about 10 to 15%, now we can talk to patients in advanced stage that yes, there is a chance 30, 40% we can improve your life. Stage 3 has improved. Stage 2A, 2A, 1AB, and 3A has also improved with the use of targeted drugs and immunotherapy. Also, as high as 30 to 60% undergoing surgery eventually develop this metastatic disease. The options of neoadjuvant is creeping in, and the adjuvant options have also improved the survival. Yes, adjuvant osimertinib, durvalumab in a localized tumor, and use of pembrolizumab, atezolizumab, nivolumab immunotherapy in advanced cancer also have improved overall survival. And advanced metastatic is managed also by the TKI waste, and not to forget, it's an ALK receptors, though it is 3 to 4%, okay, though it is quite expensive, but starting from crizotinib, ceritinib, and the lorlatinib are the newer drugs, which again has a higher penetration, is also in the armamentarium, is quite available in India, and we have option to use it. RECT and ROS, yes, do we have drug? We also have drugs for the MET 14 exon sequencing. So that's, you go into more of molecular depth. Yes, we do have. Even BRAF treated tumors from Novartis, we have drugs available. So options are more. But yes, don't forget about the financial things. People say in a scientific talking, you should not talk about finance, but I say I will always speak because it's a part of, if I can't give it to the patient, it remains in the books. But we try to do what best, requesting companies to have generics, which will help us to write for many people. Thank you very much.
Thank you so much, ma'am, for such an
Thank you.
informative talk.
Thank you, Dr. Anita. It was really a great talk. I really enjoyed. And I would really like to borrow your slides because they are really very good for the students. They can actually learn because everything is so well summarized. We would like to move
Thank
to
you,
the
sir.
next. Thank you very much. So we would like to move
Thank
to
you, sir.
Next presentation by Dr. Krishna Prasad. Priyanshi, please introduce.
Yes. So now I would like to invite our second speaker, Dr. Krishna Prasad. He's consultant in Department of Medical Oncology from Mangalore Institute of Oncology, Mangalore, and he's going to speak on pre-OP, post-OP, or both, immunotherapy for locally advanced NSCLC. Thank you, and over to you, sir.
Thank you, Dinesh sir, for this invitation. It's an honor for me to present this talk. So my topic is preoperative, postoperative, or both, the role of immunotherapy in locally advanced non-small cell lung cancer. So we know that adjuvant platinum-based chemotherapy changed the standard of care for resected NSCLC around 15 years back. It showed a 6% improvement in disease-free survival at 5 years and a 5% improvement in overall survival across all patients. Now, with this background, the EDURA trial came into the picture, which also showed that when you give adjuvant osimertinib for patients with EGFR mutation, there was a significant benefit, not only in terms of disease-free survival, but also in terms of overall survival. So in an early stage disease, you have good benefit from adjuvant chemotherapy as well as targeted therapy. So with this background, we can see that recently there have been 2 approvals for adjuvant immunotherapy in early stage non-small cell lung cancer. One is for atezolizumab and the other one is for pembrolizumab. So let's go into both these trials. Now, if you look at the IMpower 010, where patients with stage 1B to 3A non-small cell lung cancer, basically any tumor more than 4 centimeters in size or with lymph node positivity were taken into this study. And post-operatively, they were given adjuvant chemotherapy 1 to 4 cycles. Based on the histology, the patients got either pemetrexed-based chemotherapy or gemcitabine taxane-based chemotherapy. Once they finished the chemotherapy, they were randomized to either just supportive care or 16 cycles of atezolizumab. If you look at the other trial, Keynote 91, where similar patients were taken up for this study, but they were not mandatory to get chemotherapy. So they can get chemotherapy, but many of the patients in this trial just received adjuvant pembrolizumab versus placebo. So you can see this is a very large trial, more than 1,177 patients, and even the IM-Power trial is a large one with 1,280 patients. So if you look at both these trials, both the trials showed similar disease-free survival improvement, significant in terms of 2-year disease-free survival. You can see that the IM-Power improved from 52% to 58%. And in the Keynote, the 1.5-year disease-free survival improved from 64% to 73%. So both the trials were positive in terms of disease-free survival. Interestingly, both were divergent in the sense, in the IM-Power trial, patients who had the PD-L1 status less than 1% did not benefit from immunotherapy, and the maximum benefit was in patients more than 50% PD-L1. Compare that with the Keynote 91 trial, where irrespective of the PD-L1 status, you can see that the benefit seems to be more or less the same. So if you look at the IM-Power in detail, even though the disease-free survival benefit was seen across many subgroups, the primary benefit was seen in patients with stage 2, stage 3A non-small cell lung cancer, with the PD-L1 being more than 1%. So this was the group which was actually approved by the FDA. So if you look at the Keynote 91 trial, there was improvement in the overall population as well as in patients with the PD-L1 being more than 50%. You can see that there is hardly any difference between the two groups. What about overall survival? In both the studies, the overall survival was not significantly different. Of course, the overall survival was not formally tested. What about adverse events? You can see that roughly around 18.2% in the IM-Power trial and around 19.8% in the Keynote trial had adverse events severe enough to lead to treatment discontinuation. So roughly less than 20% of them had treatment discontinuation of the immunotherapy. So apart from these two trials, there are multiple other adjuvant trials which are ongoing, mainly with durvalumab in the CCTG trial as well as Mermaid 1 and 2, and also with the Anvil trial using nivolumab. So there are multiple trials for adjuvant immunotherapy. But at the present moment, based on the two trials which I described in detail, atezolizumab is approved for adjuvant therapy in patients with stage 2, stage 3A non-small cell lung cancer with PD-L1 expression more than 1%, whereas pembrolizumab is approved for anybody more than stage 1B, that is size more than 4 centimeter, as approved by the Keynote 091 trial. But in real life, what happens is, if you look at this study, the adjuvant chemotherapy itself is not given in many patients. In some trials, around 59%, in others, around 48% did not receive adjuvant therapy because of various reasons, starting from patient's refusal, patient's general condition, negative lymph node status, clinician's choice, advanced stage, and disease progression. So in this background, the idea came that why not give neoadjuvant therapy? And neoadjuvant chemotherapy has clearly demonstrated benefit similar to adjuvant chemotherapy. So why not neoadjuvant immunotherapy? Also, when you give neoadjuvant immunotherapy, there seems to be better treatment compliance. And if you required, you can even add postoperatively based on the response. And probably there is better antigen priming because the big tumor is still sitting there. So in this neoadjuvant setting, nivolumab has received FDA approval along with chemotherapy for patients with resectable non-small cell lung cancer based on the CheckMate 816 trial. So as lung cancer and surgical intervention in lung cancer can be a pro-metastatic setting and it can be highly immunosuppressive, giving neoadjuvant immunotherapy can attack the micrometastasis early and hence mitigate its immunosuppressive effects. Patients has a more intact immune system, like I told you, and in the neoadjuvant setting, importantly, the draining lymph nodes are still there, and there is a good potential for long-lasting immune priming against the micrometastasis. So this CheckMate 816 trial took patients with stage 1B, 2, and 3A patients who had no sensitizing EGFR or ALK mutation, that is extremely important, and were randomized to getting 3 cycles of chemotherapy versus 3 cycles of chemotherapy with nivolumab, then were posted for surgery, and then there was optional adjuvant therapy as well. Now, if you look at it, there were two co-primary endpoints, one of them being the PCR. You can see significant benefit and increase in the PCR from 2% with chemotherapy alone to 24% to a combination of nivolumab with chemotherapy. Also, if you look at the event-free survival at 3 years, it improved from 43% to 57%. Now, both these things came without a decrease in the percentage who underwent surgery. That is extremely important because one of the fears of neoadjuvant therapy is that patients will not be compliant with surgery for various reasons. In this trial, it was very clear that that did not happen. Also, there was no increase in adverse events. If you look at the depth of pathological response, if you look at major pathological response, with chemotherapy alone, it is very small. But when you add immunotherapy, you can see what the huge number of patients who ended up with a major pathological response. If you look at event-free survival by the subgroups, virtually every subgroup benefited from neoadjuvant immunotherapy, and the maximum benefit seems to be with stage 3A patients, with PDL1 being more than 1%, and even better when PDL1 is more than 50%. The 3-year overall survival update is also released, and in the ELCC 2023, when it was presented, there was a 14% difference when you added nivolumab to chemotherapy. What about the recurrence? Immunotherapy not only reduced the locoregional recurrence, it significantly improved the distant recurrence rate from 22% to 10%. And if you look carefully, the maximum benefit seemed to be in the CNS side. So the CNS recurrence significantly improved with the addition of immunotherapy. There are multiple ongoing trials nowadays to not only giving neoadjuvant immunotherapy, but peri-adjuvant studies. So what does that mean? You give immunotherapy with chemotherapy, take the patient up for surgery, and then give adjuvant immunotherapy. One of the main trials which was released this year was the Keynote 671 trial, where they gave patients with stage 2, 3A, and 3B pembrolizumab with chemotherapy versus placebo with chemotherapy. Post-surgery, again, placebo versus pembrolizumab. You can see that there is a significant improvement in the major pathological response from 11% to 30%, and also in the PCR from 4% to 18%. Also significant benefit in terms of event-free survival at 24 months from 40% to 62%. Also, there seems to be divergence in the overall survival curves as the number of months increases. There are two other trials which I will just touch upon. The NeoTorch trial, where they used perioperative toripalimab, just like how they used the pembrolizumab in the previous trial. And you can see that the major pathological response improved from 8% to 48%, and the event-free survival improved from 38 to 64%. Also, the AGN trial, which was again published this year, where they used durvalumab along with chemotherapy, then took up for surgery and continued durvalumab for 12 months. Again, increase in the PCR rate from 4 to 17%, and improvement in the major pathological response from 12% to 33%, and significant benefit in terms of event-free survival. There are two issues which I would like to highlight with neoadjuvant immunotherapy. One is that it can lead to surgical challenges which have been reported because there is significant inflammation and fibrosis, and less invasive surgery may need to be converted to a more open surgery, and there is longer operative times. In addition, there may be a slight increased risk of post-operative pneumonitis. So I would like to end by saying, there is a role of immunotherapy at present, both before surgery, after surgery, and there are trials which have been recently released where it suggests that both before and after surgery is going to be useful. Thank you.
Thank you so much, Dr. Krishna Prasad, for delivering such an enlightening talk. So moving ahead, now I would like to call Dr. Abhishek Raj. He is a senior consultant in Department of Medical Oncology, Hematology, and BMD in Sarvodaya Healthcare. And he's going to speak on um, optimizing treatment for first-line NSCLC. Thank you, and over to you, sir.
Hello, is my voice audible? Thank you, Priyanshi. Okay, so thank you so much, Dr. Prasad, for such an excellent talk. And I was supposed to speak on IM Power 010, but I think I can safely skip it now. So I'll be talking about the role of atezolizumab in the management of lung cancer, and I'll be talking mostly about the key trials that are there in metastatic setting. So these slides have been provided to me by Roche, and it's a Roche sponsored session. So treatment options, we know that for metastatic non-small cell lung cancer patients, particularly those who are target mutation negative, and before the advent of immunotherapy, we used to have a limited options with a median survival of anywhere between 9 to 12 months of overall survival. And with the advent of bevacizumab, it did increase the progression-free survival, but there was no difference in the overall survival. And usually after progression on first-line treatment, majority of the patients, they did not used to be eligible for your second-line chemotherapy, or even if they were, the options were limited in the form of chemotherapy alone. So coming to the approvals for atezolizumab in non-small cell lung cancer, first it came in the second line based on the OAK trial. Then it was in the first line setting in metastatic non-small cell lung cancer based on your IMPAR 150. Then you had IMPAR 130, and then we had IMPAR 110. So coming to the first trial, so these are the three trials I'm going to talk about. One is your IMPAR 110. Discussing the role of atezolizumab monotherapy in PD-L1 high patients. Then IMPAR 130, where atezolizumab is combined with your chemotherapy backbone. And then we have IMPAR 150, which hypothesizes that probably the addition of VEGF inhibitor along with your immunotherapy leads to superior outcome. So coming to the first trial, which is IMPAR 110, it compared atezolizumab monotherapy versus chemotherapy in selected population, which were PD-L1 selected population in the first line treatment. It included chemotherapy naive patients, PD-L1 selected. PD-L1 positivity was defined on the basis of TC123 or IC123, which is your immune cells or based on the tumor cells expression. And if either of the factor were positive, it was defined as more than 1% was defined as the positive. It was the stratification was done based on sex, performance status, histology, and PD-L1 expression. So the one arm was your atezolizumab monotherapy, 1200 mg every 3 weekly, which was continued till there was progressive disease or loss of clinical benefit or untoward side effect. The other arm, the chemo arm, was in the non-squamous, it was carboplatin or cisplatin with pemetrexed, squamous carboplatin or cisplatin with gemcitabine. And they were given maintenance as pemetrexed if it was pemetrexed in the non-squamous arm. In the squamous, it was best supportive care. The primary endpoint was your overall survival in the entire population. And the secondary endpoints for your PFS, overall response rates, and duration of response. As you can see, that the baseline characteristics were well balanced between both the arms, irrespective of the PD-L1 subgroup. And you can see that the non-squamous histology was the most common, which comprised around 70% of the patients, and in the TC3 arm, it was even higher. So coming to the primary endpoint of overall survival in the TC3, which was the PD-L1 high subset, here you can see that the median OS was 20 months as compared to 13 months, with a 7.1 month absolute benefit in the median overall survival in favor of atezolizumab versus chemotherapy, with a 41% reduction in the risk of death. You can see that at the updated analysis, there is continued benefit of clinically meaningful benefit in PFS also with atezo versus chemotherapy, with the median PFS of 8.2 months compared to 5 months, and 12-month PFS was 20% in the. Even the response rates are higher. There is a 12% increased chances of response in patients who have received atezolizumab as compared to chemotherapy, and the median duration of response was also higher. We all know that patients who respond to immunotherapy, they continue to respond for a much longer time. That is what usually drives the benefit in some of the other trials that we have seen. So median duration of response was 40 months versus 8 months in patients who receive chemotherapy. If we talk about, there has always been cross talk about whether the PD-L1 testing that has been utilized for various immunotherapy or the companion diagnostic test, it does matter. So SP142 was what was used here. And there was a post hoc analysis of the patients, irrespective of testing on the 12C3 as well as SP263. And you can see that the benefit was still maintained. There was an early separation of the curves in TPS more than 50%, whether determined by your 22C3 or SP263. So irrespective of the platform that is used, if the PD-L1 is high, atezolizumab does benefit patients in high PD-L1 subgroup. There were no new safety signals identified. Notably, the grade 3-4 adverse events were much lesser in patients who were treated with atezolizumab alone as compared to your patients with chemotherapy, where these grade 3-4 side effects were much higher. So coming to the summary of this study, IMPAR 110, it was a positive study. It demonstrated statistically as well as clinically meaningful difference in survival as well as progression-free survival in favor of atezolizumab in PD-L1 selected metastatic non-small cell lung cancer population, particularly in the TC3 or IC3 population. It showed meaningful improvement in PFS, ORR, and duration of response. The safety was consistent with no interesting signal identified. Now coming to IMPAR 130, which studied the role of atezolizumab in non-squamous non-small cell lung cancer. So it was a phase 3 study. So basically, it included non-squamous non-small cell lung cancer, and these patients were chemo naive, and they were randomized to arm A, which was atezolizumab in combination with nab-paclitaxel and carboplatin. Nab-paclitaxel was used in view of a steroid-sparing agent with maintenance atezolizumab after 4 to 6 cycles of chemotherapy, chemoimmunotherapy, and then it was continued till there was a progressive disease or toxicity. Arm B was your carboplatin with nab-paclitaxel, and if the patient had your adenocarcinoma histology, they were switched to pemetrexed after exposure to carboplatin and paclitaxel, and it was continued till progressive disease. It was best supportive care if the patient had they were all non-squamous patients. So the primary endpoint here was, the co-primary endpoint here was investigator assessed PFS in the intention to treat wild population and OS in intention to treat population. The secondary endpoints were your overall survival in the entire population, irrespective of the PD-L1 status. So coming to the baseline characteristics, again, you can see that they are relatively very well matched between the two arms. I would like to highlight that 15%, around 15 to 13% of the patient had baseline liver metastasis, and 50% of the patient had PD-L1 negative status at baseline. So you can again see, if we talk about the progression-free survival, it was significantly improved with the addition of atezolizumab to the chemotherapy backbone with median PFS of 7 months versus 5.5 months with a hazard ratio of 0.64 with a median follow-up of around 1.5 years. If we talk about the subgroups, almost all of the subgroups have benefited here except the patient who had baseline liver metastasis where the hazard ratio was just 0.93, except that subgroup. Almost in every subgroup, the benefit in PFS was seen in this forest plot. And if we talk about the OS again is there was a significant difference in the overall survival in favor of atezolizumab in the entire population as compared to your chemotherapy. So hazard ratio was 0.79. It was in favor of addition of atezolizumab, which is 18.6 months versus 13.9 months. So if we talk about the subgroups also, the subgroup also, almost all the subgroups except the baseline liver metastasis patient benefited with the addition of atezolizumab. Even in patients who had PD-L1 low, that was PD-L1 negative, here also the hazard ratio was 0.89. If we talk about the overall response rates and duration of response, they were also improved with the addition of atezolizumab to chemotherapy. You can see that the overall response rates was around 50% in patients who were treated with immunochemotherapy versus 32% in patients who received only chemotherapy. The median duration of response was also 8.4 months in favor of atezolizumab versus 6.1 months, which was statistically significant. Safety summary, again, no new safety signals were identified. If we talk about the grade 3 to 4 adverse events, they were relatively similar in both the arms. If we talk about the so coming to the summary, so basically it met the co-primary PFS and OS, and it demonstrated a statistically and clinically meaningful benefit of 4.7 months difference in OS and 1.5 months difference in the PFS. The OS and PFS benefits were observed across all PD-L1 subgroup. Atezo plus chemotherapy had a safety profile which was consistent across all the subgroup. If we talk about the now we are moving on to the IMpower 150 study, which again studied non-squamous non-small cell lung cancer. It was a phase 3 study of atezolizumab plus chemotherapy. It combined bevacizumab in the first line setting. This study is quite interesting in the sense that it randomized patients to 3 arms. So it included patients of non-squamous non-small cell lung cancer, chemotherapy naive, tumor tissue. So they were randomized to 3 arms. The first arm was atezolizumab carboplatin plus paclitaxel, which was given for 4 to 6 cycles, followed by atezo maintenance. Arm B was which combined atezo, bevacizumab, carboplatin paclitaxel, followed by atezo bev maintenance. And arm C included your bevacizumab, that was your standard chemotherapy plus VEGF inhibitor combination for 4 to 6 cycles, followed by bev maintenance. The co-primary endpoints were your PFS and the secondary and overall survival. So here the baseline, the characteristics were well matched again in the 3 arms, but the patient had liver metastasis. So interestingly, this study also included patients who were EGFR mutation positive, or there were some patients of ALK rearrangement positive as well. So patient who did have targetable mutation like your L858R or exon 19 deletion, they were initially treated with your targeted therapy, that is your EGFR inhibitors. And if on progression, they were eligible for randomization in this study. And in ALK rearrangement positive, even patients who were treated previously with ALK inhibitors and no new therapies were available, they were also randomized. They had also included certain patients who did not have targetable EGFR mutation positive. So, and there was approximate 50-50 split between PD-L1 positive and negative patients. So coming to the primary endpoint, there was a significant OS benefit with the addition of atezolizumab in the entire population. 24-month OS rate of 43% versus 34%, with a hazard ratio of 0.80, and this is after a median follow-up of 40 months. So median OS here was 19.5 months versus 14.7 months. So this benefit is of around 4.5 months. You can see that the arm B was the one which combined both bevacizumab as well as atezolizumab. Here, You can see in almost all the subgroup, whether it was the entire population intention to treat PD-L1 high or PD-L1 low, everywhere the maximum response or the duration of response is seen with the arm B as compared to arm C. If we talk about if we talk about the different subgroups, if this is the TC3 or IC3, which is PD-L1 high subgroup, so here the OS benefit was OS benefit here was observed in favor of ABCP versus BCP. BCP is your immunotherapy free arm. So here you can see that the median OS was 30 months as compared to 15 months. This is an excellent number. So the patients who have high PD-L1 positivity, they derive the most number of benefit, although a cross-trial comparison should not be done. But if we remember the first study here, there the median OS was 20 months. Here in the patients who had PD-L1 high subset, there the median OS was around 30 months, which is almost 10 months higher. So even in the PD-L1 negative subset or PD-L1 positive who had more than 1% PD-L1 expression, here also you can see the hazard ratio is 0.73 in favor of ABCP versus BCP. In the PD-L1 negative, that is CC0 or IC0 population, here the difference was not significant. It was not significant, just 2 months difference in survival was seen with a hazard ratio of 0.90. So what about certain subgroups for which this study was designed, and we are often using probably the ABCP combination in patients who are EGFR positive, who have progressed on previous EGFR treatments and they do not have any other relevant targeted therapies available. So this is the subgroup. So they included a total of 160 patients with EGFR or ALK-DNA positive. With EGFR mutation positive were 124. With 91 patients had sensitizing EGFR mutation, that is your A119 and L858R. And out of those, 78 had received some prior TKI therapy with sensitized. So even in this population, you can see that after 6 months, these curves are starting to separate in favor of atezo bev plus carboplatin paclitaxel as compared to bev CP, which with a hazard ratio of 0.6, with a median OS of 9.7 months versus 6.1 months. So this is probably not doing as well as your chemo or bev arm alone. But some of these patients, you can say that these are already treated patients with GFR inhibitors, and we know that from previous studies also that other immunotherapy agents also don't work that well. But still, you can see that the utilization of atezolizumab here, it is leading to improved survival, statistically improved and even clinically meaningful survival difference in favor of atezo-bev chemo combination. If we talk about arm B versus arm C, here also you can see that there was a continued clear suppression of curves and OS benefit with the addition of these two agents in patients who had sensitizing disease. This was for the entire intention for all the EGFR mutation, the previous graph, here for sensitizing disease. While there was no difference in the arm A versus arm C. Arm A was your atezo plus chemo, arm C was your bev plus chemo. So there was no difference. So if you have to treat, you have to you don't have to just utilize atezolizumab. You have to give atezo bev with chemo combination. So the OS benefit was also maintained in patients who have been treated with prior TKI therapy. So it is just a post hoc analysis of different subgroups of EGFR positive patients. If we talk about in patients of EGFR positive disease, the response rates are also higher in favor of arm B as compared to your chemo and bevacizumab arm only. So median duration of response was 11.1 months versus 4.7 months. In patients who have baseline liver metastasis, we know that these patients have bad biology disease. Here also, you can see that the median OS was 8.2 months versus 5.4 months with a hazard ratio of 0.41. So particularly for these subgroups, EGFR positive patients who have been previously treated or baseline liver metastasis, probably a combination of atezolizumab with your VEGF inhibitor, it could benefit such patients. We can see from the control group that these are inherently bad patients with a median survival with chemotherapy of 5 months only. So it is leading to some meaningful benefit in such patients. So the benefit was mostly seen for arm B versus arm C, not in arm A or arm C. So again, in patients, if you have to treat, you have to utilize both atezo as well as bev to have a meaningful benefit. So there was a higher proportion of treatment-related grade 3 to 5 adverse events in arm B. This was expected because there were 4 drugs as compared to the 3. But again, if we are talking about immune-related adverse events, there were no new safety signals. The severe side effects are to the tune of 9 to 15%, and the most common side effects are skin-related or you're related to your hormonal abnormalities. So coming, if I have to summarize, IMPAR 110, it tested atezolizumab monotherapy in high PD-L1 expression. It included both squamous and non-squamous histology, led to meaningful improvement in overall survival as well as progression-free survival. IMPAR 130 included in non-squamous histology, which combined atezolizumab with chemotherapy. It was a potential steroid-sparing regime. If we talk about IMPAR 150, so it has also utilized atezolizumab in combination with VEGF inhibitor in non-squamous histology, PD-L1 all-comers, but it included patients who are treated with TKIs, had baseline liver metastasis and bulky disease. So thank you so much. I was also supposed to cover IMPAR 010 in a resected lung cancer patient, but that has already been covered very well in the previous talk. So thank you so much.
Thank you so much, Dr. Abhishek. One second. Yes. Thank you so much, Dr. Abhishek, for such an instructive talk. Moving ahead to our next speaker, I would like to invite Dr. Vikas Talreja. He is consulting oncologist in Department of Medical Oncology and Hematology from Regency Hospital, Kanpur, and he's going to speak on immune modulators beyond PD-L1. Thank you, and over to you, sir.
Thank you for the kind introduction. I must congratulate the organizers for a very intellectually awakening agenda, and also Dr. Abhishek for engaging immunotherapy talk. We shift our gears to what lies ahead to the immunotherapy. That's the beyond PD-L1 in thoracic tumors, the novel targets, and the combinations. So the objective of my talk will be next slide to highlight some of the emerging immunotherapeutics in lung cancer targeting tumor immune microenvironment, co-immunity receptors, targeted therapy combinations, and a brief word on the bispecific vaccines. Next slide, please. As you could see, which was brilliantly demonstrated, that immunotherapy is a cascade of various events that's going to take place with the cancer immunity cycle, as you could see, which involves priming and activation of these cells, also cancer antigen presentations, release of the cancer cell antigens, the killing of the cancer cells, the recognition of the cancer cells by the T cells, infiltrations of the T cells into the tumor cells, and the trafficking of the T cells to the tumors. Now, the immunotherapy trial landscape, as you could see, has touched the, if you look at the 4-year average annual growth rate, it has just the lung cancer being the most common. And you could look at the number of the approved indications of the CTLA4 and the chemotherapy and the chemoradiotherapy and the VEGF inhibitors for the same. And you could look at the various, next slide, please. Yeah, so look at the various approved indications for the same, and that has changed drastically. And with the advent of more and more immunotherapy targets, more and more resistant mechanisms are going to come up with the checkpoint inhibitions, as you could see from the next slide. The immune desert phenotype, where there is a new antigen loss, there is a defect of the antigen processing machinery, and an abnormal interferon signaling. There is an impact of the microbiome that's also present in the MHC1 with antigen with dedifferentiations of them. There is a differences also of the differential response and a differential resistant mechanism to the checkpoint inhibitions based on the different organ locations by the aberrant genomic signaling pathways, co-inhibitory checkpoints, and the immune suppression pathways. Now, very important is to plan a very rational combinations for it, because when you steer the car, you have to also release the brakes. Next slide, please. And also you have to take the autobahn and the step on the accelerator. So very, very important is you have to combine these immunotherapies with also those vaccine cell therapies and bispecifics, which are going to steer the way to increase the tumor T cell lymphocyte environments, the various vaccines, in situ vaccinations, and adaptive T cell T cell therapies. Also, those which are the inhibitory receptors for it, you need to have those temper releasing breaks. That's PD1, CTLA4, TIGIT, LAG3, NKG, 2A, and TIM3 inhibitors. Now, also very important is you have to look at the microenvironment of it, and that's where the VEGF and the TAM plays a very important tumor microenvironment regulations, the MDCs, the TNF, the TGF betas, the interleukin 1, 8, 6, and also step on the accelerators which act on the activatory receptors agonistically, that is CD137, CD40, ICOS, GTR, IL2, IL12, IL-15. And also you have to look at the various, next slide please, the VEGFR and the TAM RTKs that can lead to an immune suppressive tumor microenvironment and resistant mechanisms. As you could look at the VEGF released by these tumor cells, increased numbers of the multipotent stem cells and the T regulates, which inhibits the maturations and the functions of the dendritic cells. The tumor associated macrophages release the gas 6, binds with the XL, MR, and TIR3, which inhibits the pro-inflammatory cytokines and stimulates the immunosuppressive cytokines. The MERV inhibitors, that's the micro 1 immune stimulating polarizing of the macrophages and induces the immunosuppressions of the M2 polarization, is again a very important part to look forward to. And there comes the Sapphire trial, whose accrual has been completed, where next slide, the Citravinib plus the nivolumab in combination with those who have had a prior benefit from the checkpoint inhibitors were continued in, randomized in terms of the docetaxel versus the Citravinib, which is again uh, if we look at the Sapphire trial response rate, again, you could look at giving nivolumab alone is 5.2 months, the duration of treatment, and the Citravinib is 4.8 months, with the response rate of around 18% and the disease control rate of around 78%. So a lot of stable responses being produced. Now, lenvatinib plus pembrolizumab, the LEAP study had a revolutionary change in terms of the various tumors where it had reached its 10. In lung cancer, the overall response rate of the LEAP study was 33% with a median PFS of around 5.9 months. And we have a LEAP 7 study where the p-value wasn't significant and hazard ratio was crossing 1 when pembro plus len compared with pembro plus placebo, with equal responsive rates were there. Now, Cosmic study, next slide, next 2 slides, was a phase 1 study of cabozantinib with atezolizumab in non-small cell lung cancer patients with prior IO exposures. You could look at the overall response rate of 20%, disease control rate of 80%, and a tumor reduction of around 77% of them, with a median PFS of around 4.5 months, with a median overall survival of around 14 months. Very encouraging contact 1 study for the same. Combining VEGF with the immunotherapy again is a very exciting field, and there comes the remorozumab plus the pembrolizumab. Next slide. And we have an ST2302 in development, and you could see the overall survival rate of hazard ratio of 0.65, meaning a 30% reduced chances of deaths when you give the combination of remorozumab and pembrolizumab versus the standard of care, either docetaxel or remorozumab in the placebo arm, with a pre-treated non-small cell lung cancers patients with a response rate of 30%, duration of response, and the median PFS of 9.7 months. Now, very important was the topic which I discussed was the releasing the brakes, that is targeting those which causes the inhibitory checkpoint inhibitors to fail, and that's where the LAG3, TIM3, and the other inhibitory components be very important. The LAG3 is expressed on the activated T, NK, B dendritic cells, which downregulates the cell proliferation activation, helps the maintain the self-tolerance and T-cell exhaustions, and it has got an approval for the nivolumab plus relatinib in melanomas, which has an improvement in the PFS. Now, the soluble LAG3, 2 slides please, that is eftilagimod alpha was tried in the TACTIC-02 trial, where the data for an immunocheckpoint inhibitors naive patients were taken, where the first line non-small cell lung cancers unselected for a PD-L1 population were selected, and a combination therapy of pembrolizumab every 3 weekly plus the eftilagimod was given, and you could look at the durability of responses. It's 21.6 months in a metastatic non-small cell lung cancers with an overall response rate of around 40% with a 6-month PFS of around 56% of them. A very encouraging efficacy rate. 3 slides ahead. There was a response rate in PD-L1 negative population also with more than 30% when you give the combinations. Also very important is the tumor response rate by the whether it's a squamous or non-squamous histology. It was comparable, and it was a safe drug to give also with no major grade 3, grade 4 adverse events. 3 slides ahead. Now, very important is the TAC2 marker, which is interferon gamma and the CXL, that is cytokines important for the Th1 response, which was significantly elevated when you give immunotherapies at 3 and 6 months compared to baseline. As you can see, it is increased early as compared to the later in the first FT administration, and you could look at the biomarker as a mechanism of response for this. There is a phase 2 randomized study which was published recently in ASCO 2023 and presented, and again showing a very important response rate. Now, the targeting TIM3 is again a very important point. That's pertuzumab in advanced small solid tumors. The dose finding study was between 80 to 400 milligram every 2 weekly or 4 weekly, and the phase 2 study is ongoing in immune checkpoint pre-treated populations. And you could look at the TIM3 expression in these patients and give the TIM3 expressed population that's more than 10% of these, and you could see get a response rate out of it. Also important is the targeting TIGIT. TIGIT again is a tiragolumab. Next 2 slides is a fully human Ig1 kappa anti-TIGIT monoclonal antibody with an intact FC region that blocks the binding of TIGIT to the receptor PVR, and the TIGIT is basically the T cell immunoregulator with the Ig and ITIM domains and inhibitory receptors on the T cells and the NK cells by binding to the PVR. The various TIGIT molecules that are known are the vibostolimab and the tiragolumab, and they have shown efficacy in the phase 1 studies. And does positivity makes a difference in them? You could look at the skyscraper studies. Did not meet the primary endpoint, but overall survival data is awaited. Next 2 slides, vibostolimab plus pembrolizumab combination, again, irrespective of the TPS score, shows a promising results in further relapsed refractory populations post checkpoint inhibitors. Also in the PD-L1 naive population and the PD-L1 pre-treated population, the pembrolizumab plus vibostolimab shows an encouraging good response rates throughout the studies. And there was a press release for the first in PD-L1 more than 50 populations at 4-month PFS. Nivolumab plus zimberelimab or domvanalimab, that is the FC silent anti-TIGIT, and the zimberelimab anti-PD-1 plus intermediate showed a good PFS positivity rate for the same. Next 2 slides. Now, various important targets are the regulatory targets, that CD73, CD39, and A2AR targets, as you could see. And the COAST study, that's the Pacific 9 targeting CD730, 73 oxalizumab, and the NKJ21, that's monalizumab. And you could see the combination of either durvalumab with the oxalizumab or the monalizumab shows an improvement in the progression-free survival with an hazard ratio of 0.4, meaning a 60% reduced chances of progression. So CD73, it breaks down into an adenosine and immunosuppressive microenvironment and inhibitory receptors on the NKT cells. The NeoCo study again is designed in the neoadjuvant situations with the primary endpoint of a major pathological response with less than 10% residual viable tumor cells in the resected tumor specimens, and has shown that the combination produces up to 30% of the major pathological responses in this population. So again, very, very important study design. The NeoCOAST 2 study design also is also on the similar, that's durvalumab plus the molecules, and the keynote 495 again, or the key impact, where it's a basket trial where you select the biomarkers the group 1 includes the T cell JEP and the TMB burden. The group 2 includes the where these are randomized and the biomarker screening is done, and um, based on these biomarker screening, the pembrolizumab plus lenvatinib, pembrolizumab plus covalumab, and the pembrolizumab plus fevlizumab, that's anti-CTLA4 and anti-LAG3 respectively, are given and looking at the same response. So T cell infiltrations by the genome expression profile and the tumor mutation burdens are clinically validated biomarkers to predict the response to the pembrolizumab monotherapy with a modest correlation to each other's. The biomarker subgroups defined by the T cell infiltrations have different biological properties, suggesting a unique targetable mechanisms. And with the whole exome sequencing at our disposal, this 18 gene inflammatory signature do serve a very important biomarker for selecting the molecules as what could be the response and could not be response. And next 3 slides, you could see the PFS 8.2 and the overall survival 21.4 with a very significant decrease in the size of these populations. So T cell gene expression profile, that's non-low and TMB non-high subgroup of pembrolizumab plus lenvatinib was the only subgroup to meet the pre-specified efficacy bar based on the historical first-line pembrolizumab monotherapy response data in advanced non-small cell lung cancers. The overall response rate in the pembrolizumab plus quanilumab and the pembrolizumab plus fevlizumab treatment did not meet the pre-specified efficacy bar in any dual biomarker-based subgroups. The median PFS and overall survival were numerically longer in the T cell GEP known low TMB high subgroup compared with the other biomarker subgroups, and all 3 combinations had a manageable side effects. Prospective evaluation assessment of these are being done. Next 3 slides, again bispecific molecules that's coming along with the T cell engagers, the bispecific antibodies, which works on combinations of the monoclonal antibodies with the anti-CD3 and the anti-CD16 and the anti-TAA, and you create a bridge between them so as to create a dual mechanism of action and lead to the loss of the resistant mechanisms which were causing the efficacy to reduce. So tarlatamab again is a BiTE that's in lung cancer, and you could look at the cytokine release syndrome. 44% of them dose limiting toxicities was grade 5 pneumonitis, grade 3 encephalopathies, but again a very important molecule. As you could see, response rates with the 100 milligram dose being very, very beautiful, around 25% of them, with the duration of response lasting up to 9 months. 2 slides further, there is a concept of dual immunomodulatory bispecific antibodies where there is cross-linking to the PD-L1 on the antigen-presenting cells. The anti-PD-L1 that's is monoclonized with the anti-CD27 surface clonal antigens, and there is a cross-linking to the FC receptors on the myeloid cells. So 2 checkpoint targets to be targeted, either the PDL1 or the CTLA4, and the LAG3 and the TIM3, and agonistic antibodies to the co-stimulatory targets are there. There is vaccines, timings, dosing, combinations, and definitely the routes where we can use these specimens. But again, a lot of encouraging data to come up with the tumor lysate dendritic cells being producing the DNA, RNA, peptide, viral vectors to be produced. The Atlante trial, that's the Tidopi vaccine, non-small cell lung cancer after the failure to the chemo immuno, again shows every 3 weekly subcutaneous injections, and then every 8 weekly up to 1 year the Tidopi vaccine, and that has shown a good overall survival with the hazard ratio of 0.59, meaning a 41% reduced chances of death, and post progression 46%, 54% reduced chances of post progression survival in those patients with the primary immunotherapy resistance to the sequential IOs. Personalized peptide vaccines are way to go in nivolumab pre-treated populations with metastatic lung cancers and urothelial cancers and melanomas, and you could see they are creating a huge buzz out there. And you could have a snapshot of the personalized vaccines that are going to come with the PANDA studies, the pneumovaca studies, all on the there. And a lot of studies, 3 slides ahead, are being done on the oncobiotics, that's the microbiome, where the anti-cancer modalities and the co-medications such as antibiotics affects the integrity of the epithelial barriers and the gut residing microbiota to play a very important in the immunomicrobiological response to it. And that's where the topological Pearson networks have been developed. The top score study where we can measure the microbiome risk and how to intervene, especially the fecal transplants, are being explored in a lot of way. And you could see in those with the SIG1 population, it's creating a great buzz. The KRAS inhibitors may heat the KRAS mutant lung cancers, and that's where the increased CD8 T cell responses in post-aggressive treatment biopsies you could see. So KRAS G12C inhibitors plus PD-L1 inhibitors could be a perfect cocktail. The sotatercept synergizes with the anti-PD-1 to inhibit the tumor cell growth in mice and enhance the CD8 plus T cell infiltrations. So response data, as you could see with adagrasib and the pembrolizumab combinations, there is a 60% in PD-L1 population positive, 48% in PD-L1, 1 to 49% and 30% in PD-L1 less than 1% populations, and confirmed responses in 50% of these patients. The Hudson biomarker directed phase 2 trial again grouped the trial into a biomarker matched and a non-matched population, and you could look at those which were matched with the biomarkers had a significant improvement in the progression-free survival and the overall survival with an hazard ratio significant difference between two. The Pioneer project was the Pioneer umbrella studies where various NKG2 inhibitors like monalizumab, the CD73 inhibitors, that's MEDI9447, the ATR inhibitors, that's AZC 6738, and the STAT3 inhibitors are being used based on the biomarker projected with the umbrella study, and that's where it is important that we look forward to further great plethora of events that are going to explore with further and further testing we do and further molecules in development. That concludes the talk of mine. Looking forward for any questions if there are any. I believe we have.
Thank you very much, Vikas, for excellent talk. And I'm sure everybody has really enjoyed the talk. We are keeping a panel discussion, so we want to raise all questions there. Dr. Aditya Murli was supposed to take the next lecture, but he is stuck in the traffic, so we are starting the panel. And as soon as he joins, he will do his presentation. So I want Vikas, Abhishek also to stay back for the panel. And please introduce the panel.
So our panelists are Dr. Novak Gupta. He's consultant in Department of Medical Oncology, Asian Institute of Medical Sciences, Delhi. Dr. Kanika Bansal. She's associate consultant in Department of Radiation Oncology, Narayana Super Speciality Hospital, Gurugram. Dr. Gaurav Khanna, assistant professor and consultant in Department of Pathology, Amrita Hospital and Amrita School of Medicine, Faridabad. And I would also like to call Dr. Krishna Prasad for the panel and Dr. Anita Ramesh. Thank you, and over to you, Dr. Pandarkar.
Yeah, so see, lung cancer is really extremely important disease for all of us. And my first question, I would really like to ask Dr. Gaurav as to how important is the pathology of lung cancer today? Yes, Dr. Gaurav, please. Hello, can you hear me?
I think Dr. Gaurav is muted.
If Gaurav is muted, is Kanika, are you there?
Yes, sir, I'm there.
Yeah, so let's start from you. Let's have a clinician's perspective on how important is pathology for us.
Well, pathology for lung cancer, it's really important. First of all, we need to see whether it is a non-small cell or a small cell lung cancer. And then once we have we know that it is a non-small cell, then we need IHC for confirmation, whether it is adenocarcinoma or squamous cell carcinoma. And then we need to see the driver mutations as well, as if there are any driver mutations present, EGFR, ALK, so all of this is very important. As it is, our line of management depends on these things.
Yeah. Any other comment from the panel?
Yes, sir. I think.
Yes, Abhishek.
Yes, sir. Dr. Kanika has summarized very nicely that even if it's a localized cancer, now we have upcoming data that was recently shown in other discussions also, that it is important to know what are the biomarkers, particularly the EGFR, even ALK now. We have upcoming data, and PD-L1 testing is also important, particularly in a resource-limited setting like ours, where we have to decide, like even in a resected lung cancer, whether we have to utilize immunotherapy as an adjuvant treatment, or post-CTRT if you want to use durvalumab despite its approval in all-comer patients. And of course, in metastatic setting, we have seen that even the choice of chemotherapy depends on what histology we are treating. Like if we have a squamous histology, generally we don't use pemetrexate. If we have a non-squamous histology, we are using pemetrexate. Bevacizumab usage again is defined whether what is the histology of the patient. And of course, the initial distinction between the small cell and non-small cell. I'm sure Dr. Gaurav can highlight it better, particularly some of the newer biomarkers that are available to us.
So I think Dr. Krishna Prasad is also there, I believe. Dr. Krishna, would you like to add something? Actually, I'm not able to see on the panel who is sitting, to be very frank. And like I'm not seeing Gaurav, he probably appears to be muted. And I don't even see Abhishek sitting. So
I'm there, sir. I'm there.
You are there. Very nice. Very nice. So my next question is, once we have a pathology now with us, how important is doing PD-L1, TMB, for example, to use immunotherapy? Because in majority of the situations, you are allowed to use immunotherapy even without PD-L1 and TMB.
So, sir, I would really like to do immunotherapy, PD-L1 testing, even though for your non-small cell lung cancer patients or even for squamous histology, the approval is there irrespective of the PD-L1 status, particularly for pembrolizumab. But we, as it was highlighted very well in the first talk, or you even said in the introductory remark that only 5% of our patients are able to afford. The magnitude of benefit, whenever you are explaining to the patient, the magnitude of benefit of adding immunotherapy is much higher if the PD-L1 is positive, or particularly if it is high. And based on the Keynote 024 and Keynote 189 study, we know that even in high PD-L1 subset population, you can take a decision of combining chemo and immunotherapy both if you want to attain a bigger response. Because in patients who had high PD-L1 in Keynote 189 study, if you are combining chemo plus immuno, the response rates were as high as 65%. So if we are desiring a response, probably combination of both could be useful. And if we have elderly frail patient, there you can use a single agent immunotherapy in the PD-L1 high subset. Plus, even in the if we talk about the Pacific trial, if you look at the subgroup analysis of Pacific trial, that post CTRT, if you have to utilize immunotherapy, the magnitude of benefit is most in patients who are PD-L1 positive. Although the approval is there for the entire subset, but if you have a patient who cannot afford a drug which is going to cost him around 3 lakh rupees every 2 weekly, so probably PD-L1 is something that you can fall back upon if you want to really impress upon the benefit of addition of immunotherapy in a post-CTRT setting.
So Gaurav has joined us. So I have a question for you, Gaurav. So we are discussing PD-L1.
Right, sir.
So my please see, somebody says use DACO, somebody says use this, somebody says, do you still believe? See, there is an option of me not doing PD-L1 and still using immunotherapy. So with this background of information that I can still use, do you think it is important for me to divide which PD-L1 test I should use? And if yes, why and when?
Sir, first of all, PDL1 definitely there are a lot of pitfalls in assessing the PDL1. Sometimes, specifically non-small cell lung carcinoma, if it is taken, if the tissue has been taken from the lymph nodes, so there will be a lot of anthracotic pigment in the background. So again, that is one of the pitfall. Then there are inflammatory cells histiocytes or macrophages which show false positivity. So definitely the staining pattern has to be assessed very meticulously. It should always be assessed in the tumor cells, which should be linear and membranous positivity. Whatever the intensity may be, it may be dim positive or it may be strong positive, but it has to be membranous in the tumor cells. So it has to be correlated with the HND slides also. So mapping of the tumor cells with the HND slides is very important. And coming to your exact question that whether inflammatory cells, so can you repeat sir your question?
No, what I mean is, I still should fight for what type of test to do, or I can just order it and forget?
Sir, there are three clones available. One is SP263, SP142, and DACO22C3. They all report 22. They all report PDL1 only. The reporting pattern is different. Like if it is being done on FarmDX with a clone of S22C3, then it is CPS. What you have to look for. CPS is combined positive score, which includes the tumor cells as well as the immune cells showing the expression. So even if it is positive, then it has to be considered. Then SP263, which we are doing at in our hospital setup, in SP263 we used to see only the tumor cells. Ventana says that only the tumor cells should be assessed. So whatever the score is, you don't have to judge whether we have to give SP1, SP263 or SP142 or 22C3. Any of the clone can be done, whichever is available with the lab. And all the results, the studies have shown that all the clones show similar results.
I think
Okay,
Dr.
thank
Gaurav.
you. So, Dr. Anita and Vikas, would you like to add something here? I think they are either muted or not there. Kanika,
So,
would you like to
can
add
I ask?
something?
I
Yes,
want to
please.
ask one question. So,
Yeah,
Yes,
I
Dr.
please.
can
Gaurav,
answer. Dr. Dinesh, I'm
Yes,
audible.
yes, please,
Can you hear
Anita,
me?
go ahead.
Yeah.
Yeah, please.
So just answering to your question, saying that, yeah, can you hear me and see me?
Yeah. Please, go ahead.
So just yeah, can you hear and see me?
Yeah, we can.
Yeah. So regarding whether we should do the PDL1 testing or not, if I'm using the drug second my test, that is whether pembrolizumab or pembrolizumab, I don't do the test. Only in first line I will do the PDL test. Whatever drug I'm going to use based on that particular medium. But second line, I've stopped doing for a long.
Thank you. Yes, Kanika, you wanted to say something.
This question, I just wanted to ask Dr. Gaurav. You said that PDL1 testing sometimes is challenging when it is done on a lymph node sample, right? So, I mean, do you really recommend that, if you are sending for PDL1 testing, then preferably we should send it from the primary or from some other site than the lymph node?
See, the most important thing is that the tumor should be there. So, if it is even if it is a metastatic site and showing a good amount of tumor, then PDL1 can be done. But the important thing is it should be differentiated from the histiocytes. The tumor cells should be differentiated from the cells which look like malignant cells. Like histiocytes sometimes may mimic a malignant cell. So it should be corroborated with the HND slides together. So mapping should be done actually on which cells the pathologist should see the PDL1 expression. That is very important.
That is important. Okay, thank you.
Thank you. Yes,
I'd
Abhishek.
adding another point to what Dr. Gaurav said, we have data to suggest that there is a good concordance between 22T3 and SP263. Although the concordance between SP142 and SP263 is not as great, I think it is to the tune of around 75%. But the concordance between the other two has been around 92%. Yes, so if we are using SP263, very good, or even 22C3, which gives a score of 20, CPS. But yes, SP142 it is specifically for, and plus it is I think it is a relatively more complex with that IC1, IC2, IC3. I think they are saying that if it is positive in tumor or immune cells, both are called to be positive, and they have divided it according to IC1, 2, and 3. Am I right, Dr. Gaurav?
Yes, absolutely. The currently what Ventana says that SP263 is preferred over SP142 clone, because SP142 staining is not very robust and its sensitivity is little towards lower side. So they prefer the SP263 over SP142 clone. And SP263 and Farm DX22C3 are comparable. Only scoring criteria is different. In SP263, we look only for tumor cells, and it is given as PPS, tumor proportion score. So percentage of tumor cells divided by total number of viable cells. And in Farm DX, which is clone 22C3, and in that combined proportion score is given. So only the scoring criteria is different. Whether it is being done on Farm DX or Ventana SP263, both give similar results and both have similar implications.
Hi, Dr. Gaurav. I'm Dr. Hi.
Hello, sir. Hello.
कर सकते हैं सर आप. I have a question for you. When a patient is progressing on immunotherapy, first line immunotherapy, will you advise a repeat biopsy from the sample, from the site which is progressing, to check for the PDL1 status?
Actually, I'll have to see it whether in a progressing cancer, whether the PDL1 expression decreases or increases. Yes, definitely. Other markers are definitely show difference in expression and primary site versus a recurrent or metastatic site. But for PDL1, I'll have to look into the literature. I have never come across such scenario so far.
Okay, thank you.
I think it's probably because at the time of progression, we usually don't check for PDL1. We mostly go ahead and use immunotherapy, as Dr. Anita was saying, that the approval for immunotherapy is there irrespective of PDL1 positivity or not. But yes, another question, Dr. Gaurav, sorry, we are troubling you a lot. I
No,
think, is PDL1 testing feasible on a liquid biopsy sample yet? Or is it still investigational?
it's still investigational. In fact, on the tissue samples also, it is difficult to perform because of the availability of the stain and the training as well. So liquid biopsy is not validated at most of the centers, and it is still in the research stages. Yes, on tissue we can do it very well at wherever it is available. And in fact, most of the cases, in fact, most of the places it is available, except for some small centers. In liquid biopsy, yes, definitely it is in research stages and not yet validated at a large scale to perform it routinely.
So I think the discussion is really going on very interesting. Aditya was getting late, so Aditya has come back. So I want Aditya to intervene now, do his presentation, and we will come back to this discussion around 7 o'clock again. One of our speakers, Dr. Guru Kamal Chatta from Roseville Park, had some family emergency and he would not be able to present, so he was supposed to present live. So we'll be using that time to continue this discussion because these are really very important issues. I still don't know which test to order. And if I order one test, another hospital says it's wrong, we should have ordered the other test. So we better resolve this controversy between ourselves. So I would really request Dr. Aditya Murli to come forward and do his presentation. Aditya, are you there? Aditya?
Sir, if he's not there, can we take Dr. Bhavna Sirohi's lecture first?
Yeah, please.
She's ready. Yeah, I'll introduce her.
Yeah.
Okay. So now I would like to invite Dr. Bhavna Sirohi. She is Director and Consultant in Department of Medical Oncology, Balco Medical Center, Raipur, and she's going to speak on immunotherapy in GI colon cancer. Thank you, and over to you. Dr. Bhavna?
Sorry, I'm just trying to get my presentation. Just 1 second.
Yes, ma'am. Sure.
Not able to find it. Found it. Sorry. I am so sorry. Good evening, everyone. Thank you so much, Dr. Dinesh, for inviting me to the meeting. And I am going to be talking to you this evening on immunotherapy in colorectal cancer. So I have no disclosures. I'll talk a little bit about the background and the pathology, how we select immunotherapy in colon cancer, and also a bit about advanced setting and also the neoadjuvant setting. So today, what influences the treatment choices in advanced colorectal cancer? Of course, we look at the patient and the molecular characteristics, the tumor characteristics, the right-sided or the left-sided tumor. But molecularly, we look at RAS, BRAF, MSI, and HER2. And I'll talk to you as to what actually decides how we choose immunotherapy for our patient. And of course, we have to tailor it to individual patient needs based on patient preference, quality of life, toxicity profile, and also financial toxicity and time toxicity, which we sometimes don't talk about. So immunotherapy decisions in colorectal cancer hinge on 3 things. The PD-L1, I think you were talking about this in lung cancer as well, the tumor mutational burden, and the MSI status. I'll go through each of these one by one. So there is variable PD-L1 expression within the tumor, and we've heard about this a lot in lung, melanoma, and breast. There is a lot of spatial and temporal heterogeneity and actually lack of concordance between assays in each tumor type, whether you take it gastric, colon, or so I think we still don't know what are the right cutoffs, what are the right assays to use. Each drug which comes out has a companion diagnostic assay which one has to use if you're going to use that immunotherapy. And a lot of studies, sometimes the CPS score, whether you look at this on the tumor cells or the microenvironment. So we know a lot about this from lung cancer, but I think in colon cancer, at least in GI cancers, there is a lot of heterogeneity and a lot of lack of clarity between various studies. Tumor mutational burden, as you can see, it's very high in melanoma, in lung, and that's why, and bladder. That's where immunotherapy has a major role to play. But it also has a major role to play, as you can see, stomach, esophagus, and colorectal. Esophagus mainly in squamous cell cancers, but colorectal cancer is also up there on the right hand side. So mutational burden, we know, is associated with efficacy, but also if you link it to MMR deficient tumors or MSI high tumors, the response rate is significantly better compared to if you look at MSI stable or MSI MMR proficient tumors. And I mean, of course, we talk about the tumor agnostic, the approval by FDA for TMB more than 10. And that is sometimes taken as an excuse to prescribe immunotherapy. But in colon cancer, it is not actually beneficial to patients, especially if they have MMR proficient or an MSI stable tumor. If we look at the prevalence of MSI, about 15% of colorectal cancers have MMR deficient activity. And this is due to various inactivating agents because of issues with one of the DNA. The major DNA MMR genes is MSH2 and MLH1. And the minor ones are MSH6 and PMS2. Basically, we look at all four of these tumor DNA. Stage 2, the frequency is about 20% based on various studies. Stage 4, it's about 4 to 5%. And this is where actually we are using it more in our clinics. Testing, most of us do it by IHC and with a sensitivity of 91%, but the PCR sensitivity is slightly higher. And the sensitivity is also slightly higher, but it is a bit more expensive. But IHC is something which is available to all of us and easily doable for MSI. All colorectal cancer patients, irrespective of stage, should have MSI testing done, not only to decide upon treatment, but also to look for genetic predisposition in these patients. So these CAP guidelines came out last year. And as you can see on top, by IHC, MSI testing is preferred, also by PCR, but by NGS, yes, it can be done, but you need to validate it either by IHC or by PCR. And we must not use TMB as a surrogate marker for MMR defects or for prescribing immunotherapy in our patients. So PD-L1 blockade in tumors with deficient MMR, as you can see in colorectal cancer, the disease control rate was 92% in this study, and the response rates were 62%. But in non-colorectal cancer patients like GI, like other GI cancers, gynae, prostate, it is not so much so. In 2017, pembrolizumab was granted accelerated approval for second or subsequent lines in MSI high colorectal cancer. And based on this phase 2 study, and as you can see that we are seeing the tail end of the curve in patients who have, it's a small study, phase 2, about 10 patients had MMR deficient tumor and 18 had an MMR proficient tumor. The duration of response at the time of study was not reached. So this was the first hint that this is in patients with advanced colorectal cancer, second line and beyond, that, you know, the results were so promising. In 2020, this was approved for the first line treatment for patients with unresectable or metastatic MSI high or deficient MMR colorectal cancer. And this was as a result of the Keynote 177 study published in NEJM. This study randomized stage 4 MSI high patients, treatment naive with a good performance status, to pembrolizumab 200 milligrams per kilogram for up to 35 cycles, that is 2 years of treatment versus chemotherapy. And as you can see that there was a significantly better progression-free survival in patients who were on pembrolizumab. And the long-term data were published last year in Lancet Oncology. Though there was not a significant overall survival benefit, which was not the primary endpoint, you can see that the hazard ratio is 0.74, and we are seeing a plateau in the curves in both the arms actually. 60% of the patients on chemotherapy arm crossed over to pembrolizumab. So that could be one of the factors that why we are not able to see an overall survival benefit with pembrolizumab, but significant progression-free survival advantage. If we look at early colorectal cancer, the first study to show that immunotherapy works in patients with deficient MMR early colorectal cancer was a niche study, which was an open-label exploratory trial with nivolumab and ipilimumab, which is an anti-CTLA-4 antibody. And 20 patients had deficient MMR status, and there was 100% pathological responses, with 19 out of 20 patients had a major pathologic response and about 60% pathological complete response rate. So this was the first indication study to show activity in early patients with early stage colon cancer. So the pivotal trial, which we talked about a lot last year, was from the Sloan Kettering group, talking about PD-L1 blockade in deficient MMR locally advanced rectal cancer. And in this study, PD-L1 inhibitor dostarlimab was given every 3 weeks for 6 months for newly diagnosed patients with stage 2 and 3 MSI high rectal cancers. They enrolled about 30 patients. And all of these patients underwent MRIs and sigmoidoscopies, and they looked patients who had after 6 months had residual disease went on to the standard arm, but those who had a complete clinical response were followed up with a watch and wait strategy. So the 18 patient data was presented last year, and the whole paper has been published. Basically, 100% complete response rate. And as you can see from this slide I borrowed from Dr. Sarsak. You can see that there are the depth of response is also quite good, with some of the patients going beyond 1.5 to 2 years now, and remaining in complete remission. And all of these patients actually avoided surgery, radiotherapy, and chemotherapy as well. And for a country like ours, I think it is very important, because most of our patients with rectal cancer, especially low rectal cancer, do not wish to have a stoma. So because a lot of issues related to that, not being able to go to a temple, not being a lot of stigmatization is there, not just here but in the West as well. So I think this study is very important for those patients, but again, cost is a major issue for that. This is something we need to work on to see whether we can get away with lower doses of immunotherapy drugs. So this is an example where a patient with a tumor after 5 months, as you can see, the tumor has completely disappeared. This is one of the patients on Dr. Sarsak's study. And as you can see that the third assessment done at 8 months, the patient remains in complete clinical response. I think it's very important to make sure that the photographs are compared to the previous one when the sigmoidoscopy is done for these patients. And the key for us today is to see whether we can actually make the cold tumors or the microsatellite stable tumors or the microsatellite proficient tumors deficient, so that make the non-inflamed or the cold tumors hot, so that we can do that by various means. And there are a lot of studies going on to see whether one can increase the tumor infiltrating lymphocytes, increase PD-L1 expression or CD8 positive T cells, to see whether then immunotherapy can work if we make the tumors inflamed. And a lot of work is going on in this, because it is quite an exciting field. As you can see that chemotherapy, these studies have shown that chemotherapy combinations with immunotherapy in colorectal cancer, by giving these patients targeted treatment or chemotherapy, one can upregulate CD8 or PDL1, which may actually make the tumor amenable for immunotherapy. This is something which we did in neuroendocrine tumors by giving interferon to upregulate the somatostatin receptor. So this is very, very synonymous like that. So I think immunotherapy decisions in colorectal cancer, we should not be guided by PDL1 expression or tumor mutational burden, given the data the way it stands today. But MSI high, yes, should guide our decision making. And it has made its way into the guidelines with in first line setting for patients with advanced colorectal cancers. Checkpoint inhibitors should be considered for those who have MSI high or deficient MMR tumors. Key is all patients should be tested for MSI. We need to understand why some patients do not respond to immunotherapy. Is it whether they don't have a pre-existing immunity or inability to induce immunity, and also whether we need to see whether there are any barriers in the microenvironment. Duration of immunotherapy, none of us is very clear about it, but I think the general consensus is that if a patient remains in complete remission for 2 years, one can stop that. The depth of response, I think, is very important, what we should be aiming for, especially in some of the other tumors where the stable disease is good enough. And do we always need to achieve a CR and look at strategies? I think, yes, we need to, at least in rectal cancer, drive for this. And whether we can, space out the treatments from 4 weekly to 6 weekly or 8 weekly once a patient has completed treatment. I think these are the key questions which we all want to get an answer for. Thank you.
Thank you so much, ma'am, for the instructive talk. So I would like to invite our next speaker, Dr. Aditya Murli. He is consultant in Department of Medical Oncology and Hematology in Apollo Cancer Center, Bangalore, and he's going to speak on how I treat ES-SCLC with durvalumab real-world experience. Thank you, and over to you, sir.
Hi, am I audible?
Yes, sir.
And my screen is visible.
Yes, sir, your screen is visible.
I like to thank organizers, especially DP sir, for calling me, and I really do apologize for my tardiness. Bangalore traffic does not allow any one of us to keep time. Nevertheless, thank you so much for having me on board. Let me try and go on to full screen mode. Am I on full screen mode now?
Yes, sir.
Okay, great. So over the next 10 to 15 minutes, let me try and talk about what the real life clinical experience in the management of extensive stage small cell lung cancer is. So see, small cell lung cancer, I would like to say, is a uniquely Indian disease because our rates of smoking, especially the pattern of tobacco usage, are very different from the West. The numbers of small cell lung cancer that we see are phenomenal. In today's clinical practice, I am quite certain the number of small cell lung cancers that we see far outnumber what our colleagues in the Western Hemisphere do see. So, although we have seen many more cases than our colleagues in the West, the problem is our access to drugs and our usage of these drugs and how they fare amongst the Indian population. So, to start off, we know how NCCN guidelines say. As per NCCN guidelines, if we have a patient of small cell lung cancer, we definitely want to do the routine investigations. PET scan is almost ubiquitous these days, and we do a PET CT scan for all of our patients if they have small cell lung cancer. Along with this, in a diagnosed small cell lung cancer, we compulsorily also want to do MRI of the brain to detect asymptomatic brain metastasis. I mean, this is just some slides which I was talking about, which I've put up to see that there is nothing much that we have seen beyond etoposide, cisplatin, or etocarbo. Okay, so all of us know what to do in first line small cell lung cancer. All of us would want to use either EP or a EC regimen. But what do we do when the patients progress? Is there any other chemo molecule? So irinotecan is something which has been tried previously. Not very great results, but there might be some PFS benefit. So prior to 2018, essentially, we did not have any chemotherapy trial, which showed the superiority over the standard combination of EP or EC. However, post 2018, we got two new IO molecules in our therapeutic armamentarium. Durvalumab was one of them. The pivotal phase 3 trial for durvalumab was the Caspian trial. And then we had data from atezolizumab, which is the IMpower 133 trial. So I will not be biased. Let me talk about both the IO drugs. I'll try and put a comparison of both the IO drugs to see which one we can probably tailor make into which clinical situation. So if we want to do like a head-to-head comparison of cross-trial comparisons are never good. That's a big disclaimer. But if you want to try and compare how durvalumab is faring and how atezolizumab is faring, the median overall survival in the phase 3 Caspian trial of durvalumab was 12.9 months, and here the hazard ratio was 0.75. In the IMpower 133, which is the atezolizumab trial, the median overall survival was 12.3 months. Hazard was 0.76. So there is very little to choose in terms of the endpoint efficacy of either durvalumab or atezolizumab, and we know both of them have received approval in first line in combination with cisplatin and etoposide. So when we look at the latest NCCN guidelines, patients who have an extensive stage small cell lung cancer, 4 cycles of therapy are recommended, but some patients may receive up to 6 cycles based on the response and tolerability after 4 cycles. The preferred regimens include carboplatin, etoposide, and atezolizumab, ATI given at a dose of 1200 milligram per day. If we are using carboplatin along with etoposide and durvalumab, the durvalumab dose is given at a dose of 1500 milligram once in 21 days for 4 cycles, followed by maintenance durva. The chemotherapy partner is cisplatin. In that case, again, the dose will remain the same of durvalumab. It is cisplatin at a dose of 75 to 80 milligram per meter square with atezolizumab, with etoposide and durvalumab at a dose of 1500 milligram on day 1 of a 21-day cycle. The thing that I want all of us to note here is that be it ATI or be it Durva, with the IO chemo combination, we have something which we never had before for our patients with small cell lung cancer, a maintenance therapy, because we know that 4 cycles is half the times 4 cycles of delivering 4 cycles of chemo itself is a difficult task for patients with small cell lung cancer, but beyond 6 cycles it's almost impossible to push it. So there is no therapy that we have which we can sort of use as a maintenance to keep the disease under control. And we know from the disease biology that in extensive stage small cell lung cancer, if the disease comes back, it comes back very quickly and the performance status drops very rapidly. So if we have a molecule which we can use as a maintenance therapy, that does add a significant value for our patients with extensive stage small cell lung cancer. So the preferred regimens for primary therapy of extensive stage small cell lung cancer are carboplatin etoposide with durvalumab, or cisplatin etoposide with durvalumab, or carbo-eto with atezolizumab. So what do we use when we go back to our clinics on Monday morning? What are the criteria that we can consider while choosing whether Durva or ATI? So if we compare the two trials, the IMpower 133 and the Caspian trial, let me start with something that DP sir referred to in the previous panel discussion, the PDL1. So in a small cell lung cancer, PDL1 does not matter. So as per the trial, there was no biomarker selection and all comers were included both in IMpower 133 and in the Caspian trial. However, patients who had untreated brain metastasis were not included in the IMpower 133. PCI was allowed in the control arm for both patients. In the experimental arm of Caspian, where the arm wherein patients got durvalumab, they were not allowed prophylactic irradiation. Now that actually is a significant problem for our own patients with extensive stage small cell lung cancer. Brain is very frequently the site of first progression for patients with extensive small cell lung cancer. Caspian allowed up to 6 cycles of chemotherapy. So the inclusion criteria of Caspian was reasonably reflective of a real-world clinical practice, and it allowed either cisplatin or carboplatin, and up to 6 cycles of chemotherapy were allowed. When we look at the latest data that we have, Caspian has reported 3-year overall survival data and phenomenal. I mean, in India, so our group from Adyar itself had published some data that was about 7-8 years back. About 8 years back, our data of extensive stage small cell lung cancer, the overall survival was around about 9 months. The PFS was about 4 to 5 months. The OS was about 8 to 9 months. From there, if you look at the actual Caspian data, the durvalumab had a 1-year overall survival about 52%, which is quite phenomenal. And when we looked at the 3-year overall survival, that was 17.6 months. So we do not have patients who live up till 3 years if they go on chemotherapy alone, if a patient has small cell lung cancer extensive stage. So although we are not able to identify the biomarker yet in extensive stage small cell lung cancer, it is important to know that at least a small proportion of them do end up living. About 15% of them do end up crossing the 3-year mark also in terms of overall survival. So once we have reached this stage in extensive stage small cell lung cancer in a real world, we will definitely want to do a prophylactic cranial irradiation. So if you look at the ESMO guidelines, it is quite clear cut for any patient with ECOG PS 0 or 1 and no contraindication for immunotherapy molecules. The standard of care is 4 cycles of chemotherapy. That could be carboplatin, etoposide, or any other platin or cisplatin, along with atezolizumab or durvalumab, and then followed by maintenance durvalumab or atezolizumab. What if our patients have asymptomatic brain metastasis versus symptomatic brain metastasis? So if our patient presents to us with a symptomatic brain metastasis, what do? We can straightforward give cranial irradiation before systemic therapy, and that is not too much of a discussion. So it's a no-brainer. Give radiation to the brain and then start off with the systemic therapy. However, if our patient has asymptomatic brain metastasis, would we be harming their chances of getting the durvalumab if we give pre-CI? No, that is not the case. Even if we do find an asymptomatic brain metastasis in patients with extensive stage small cell lung cancer, we would definitely want to give cranial irradiation first, followed by chemo plus IO. If our patients in the Caspian study, durvalumab plus EP consistently improved the overall survival versus EP, regardless of the presence of brain metastasis. So here is our data. Brain metastasis should not change our treatment plan. For patients who had brain metastasis at presentation, the median overall survival of durvalumab plus cisplatin etoposide was nearly 12 months, and here the hazard ratio was 0.69. If the patient did not have brain mets at presentation, obviously the OS was better, and the median OS here was 13 months. When we looked at the subgroup analysis, whatever happens in the IM power 133, unfortunately, if the patient has brain metastasis, then maybe atezolizumab may not be the best IO partner. So in the real world, if we have a patient who's got brain metastasis at presentation with small cell lung cancer, there we might want to use durvalumab over atezolizumab. This is the burning question today. We do not have a proper biomarker to check for use of immunotherapy in small cell lung cancer. We also know that in small cell lung cancer, the TMB is quite high. The PD-L1 may not be very significant, but is TMB alone a reasonable reason? Now, TMB itself is not very predictive. In a small study of 62 patients of small cell lung cancer, it was shown that higher TMB was associated with a better prognosis, but you should note the TMB cutoff in this study was 21. This was published in 2019, I mean, in today's day and age, TMB cutoffs is itself a very hotly debated topic. When we look at the data from the IM power 133 trial, if we look at the TMB data, Patients who had a higher TMB obviously fared better with immunotherapy. Patients who had a higher PDL1 status, maybe PDL1 of less than 1% or more than 1%, it did not matter. They did better with immunotherapy. So this is another data which study which looks at the role of PDL1. So preliminary data from this study suggests that the predictive biomarkers of immune checkpoint inhibitor efficacy might be disease specific. So ICIs are specific to small cell lung cancer, and the findings validated in the non-small cell lung cancer subset cannot be translated to small cell lung cancers. I was trying to go through some data which has been published for the use of durvalumab plus chemotherapy in extended stage small cell lung cancer. This data was presented at last year's ASCO. This is a Chilean experience. Very small study, 15 patients were published, but they had a median overall survival of nearly 11.43 months. That's so Caspian had about 12.3 or 12.8 months and 11.43 months. So not too much data. So this real world data did mirror Caspian's data also. In this study, the grade 3 adverse events were 20%. So now comes the biggest question. In a small cell lung cancer, when we want to give somebody a maintenance therapy, how bad is the adverse event profile and how do we look at this? So there was this particular trial called the Luminance trial. This was a phase 3B study. The findings were discussed just recently in the ELCC, European Lung Cancer Consortium, ELCC conference which happened recently. In this, the Luminance study enrolled patients who were treatment naive and who had a life expectancy of at least 12 weeks. The patients could receive Durva plus chemo of 4 to 6 cycles, and patients could have asymptomatic or treated and stable brain metastasis were also allowed. In this study, prophylactic renal irradiation was permitted at any point during the trial. So which means that we should not be worried of trying to say, okay, IO may or may not be given, because there is no data to sort of give IO in the setting of a patient who received prophylactic irradiation. The primary endpoint of the Luminance study was basically safety and tolerability. So in a real world, what is most important along with efficacy is whether the drug is safe and tolerable or not. As per this, again, very small trial, about a quarter of patients, which is 27.5% of patients, did experience some kind of serious adverse events. However, only about 15.7% of patients had adverse events which led to treatment discontinuation. So a majority, about 85% of the patients on this trial were able to took the drug without any issues in terms of discontinuance. So to summarize my talk, first line durvalumab plus EP has shown sustained improvement in overall survival compared with a robust control arm. It is reflective of a real-world practice as it allows up to 6 cycles of cisplatin etoposide and provides flexibility of choosing cisplatin and carboplatin along with the etoposide. The benefit with durvalumab plus EP was observed across all subgroups, including brain metastasis. Survival tripled at 3 years with the use of durvalumab plus EP versus EP alone. Durvalumab offers convenient once monthly dosing regimen in the maintenance phase, which is again very, very important for us in the real world setting. Safety findings are consistent. Thank you so much for a patient listening. I would be happy to take questions now.
Thank you very much, Dr. Aditya, for making it. I know the Bangalore traffic is tough.
I'm sorry, sir, again.
But you are still surviving, so that's good. So I think we'll be taking questions. We'll have again panel. We're going late, so we'd like to go to the next session. But thank you very much, Aditya, for making it. So our next presenter is Dr. Vineet Govind Gupta, a senior consultant, Department of Medical Oncology at Fortis Hospital, Gurgaon. So Dr. Vineet, please go ahead. And you know that our second speaker, who was from Russell Park, unfortunately, he's not able to make it up. So you can add if any other additional information you want. Please. Thank you very much.
Thank you, sir. So I'm just going to share my screen. 1 second. Okay. So my topic is the evolution of switch maintenance in the advanced bladder cancer setting. So I think now we have the Javelin data for some time, and all of us have a lot of experience also with this kind of protocol. And I think we have seen the results. So we'll just discuss the evolution of the maintenance approach in bladder cancer. So in most of the randomized trial, so mostly the frontline therapy for platinum eligible patient is the combination of platinum and either gemcitabine or MVAC. Number of other regimens are also available. And a majority of patients actually have disease control with this therapy. If you combine the CR or PR and stable disease, almost 80% of patients do respond to a frontline therapy. Unfortunately, the problem is that majority of these patients will actually recur. And so number of strategies have been looked into to extend the frontline remission and try to improve the long-term outcome of these patients. So the major issue is that many of the patients who undergo the frontline therapy, they are unlikely to undergo the second-line therapy. So a number of studies have shown that when you give the frontline therapy, you will get a response and you will get the disease remission. But out of the patients who get the frontline, many of the patients will recur, and they will recur in an aggressive phase where they will never be able to get the second-line therapy. And this drops them the chance to get the second remission and a long-term outcome. So number of attempts have been made over time to improve the outcome. And the most recent is the avelumab, which is the PD-L1 blocker. And it has shown the efficacy in the maintenance setting. So when somebody gets the front-end platinum-based chemo, we can have one of these three options. We can give wait and watch. We can do some kind of continuation maintenance, that is continuous of one of the induction therapies. Or we can do some kind of switch maintenance, that is change one of the induction drugs and try to maintain with a non-induction drug which does not have cumulative toxicity. So for example, wait and watch, you can give the first line chemo, give some observation period and initiate a second line therapy, which has the classical problem that many patients will never get the second line therapy. You can have the continuation maintenance where you can start with chemo-immuno, continue the immuno, and then at progression give the second line therapy. Or switch maintenance where you give chemo alone, switch to immuno maintenance, and then give the second line therapy. So, like I discussed, wait and watch approach has its limitation because many patients will never get the effective second line therapy. So continuation maintenance, there have been a number of approaches. We have did Danube study, the Keynote 361 and IMvigor 130 study. So actually none of these other studies met a survival endpoint. And even the LEAP 011 study, which used Pembro plus TKI, which was which is kind of chemotherapy free based approach, even this did not meet the PFS or OS endpoint, thereby indicating that these studies don't lead to a sufficiently robust long-term improvement in the outcome. So the Javelin Bladder 100 study used immunotherapy maintenance after the end of chemotherapy, and this study has demonstrated a significant survival benefit and represents the current standard of care. So the rationale for using maintenance immunotherapy is that there is adequate tumor burden reduction with chemotherapy, which leads to a better immunogenic environment, which lead to probably the immunotherapy being able to control the tumor better. Further, a reduced disease burden might lead to an improved efficacy of immunotherapy. So in the Javelin Bladder 100 study, patient with locally advanced or unresectable bladder cancer received frontline chemotherapy with gem-carbo or gem-cis, and after a treatment-free interval of 4 to 10 weeks, patient who had got complete, partial or stable disease, they were randomized 1:1 to avelumab every 2 weeks till progression versus best supportive care alone till progression, with the primary endpoint being survival and various safety and efficacy endpoints as secondary endpoint. And on average, patients were median 68 years old, majority were male. They were all ECOG PS 0 or 1. And first line chemotherapy, around half got gem-cis, around 42% got gem-carbo, and the rest got both. So if you look at the primary endpoint, the long-term result continue to demonstrate that there is a significant survival benefit to patient who get avelumab maintenance, and the hazard ratio is 0.76, so 24% lower risk of death among patients who got avelumab. And similarly, the PFS endpoint also showed significant improvement with avelumab maintenance. Although you can see that in the beginning, there is a steep fall off for both the arms, but long term, at 2 year and 3 year, there is a significant separation of the curves, and the hazard ratio is 0.54. So the significantly lower risk of progression or death in these patients. And if you look at the median survival from the start of frontline chemotherapy in the avelumab arm is actually almost 30 months, which is a kind of a very large improvement and not something which has been replicated by a lot of studies. So compared to 20 months in the standard of care arm, where patient who progressed, patient are put on observation after achievement of CR/PR or stable disease. So if you compare actually to the historical result in the Javelin 100 study, the 2-year survival is almost 50%. So importantly, even the control arm has improved. So you can see that 2-year OS is 20% versus 38.4%, probably with the advent of newer drugs in the second and third line. But it represents the kind of outcome improvement which these patients have had over the last 30 years. And if you look at this subgroup analysis, almost all the subgroups benefited, including the PD-L1 negative population, which still benefited, but the PD-L1 positive population actually benefited the most with the maintenance avelumab. And there was also an improvement of patient quality of life with avelumab therapy. So even in the Asian cohort, there was a significant improvement in both in terms of PFS and OS. And the median OS in Asian population was 28.7 months, which is similar to the overall population. So a lot of, I think as people gain more experience, a lot of practice changes have happened, even for me. And so first question is, how many cycles should we probably be giving? So some people like to give 6 cycles before going for maintenance. Some people like to give 4 cycles before going for maintenance. So now there is some data also. If you look at the study, among patients who got 4 versus 6 cycles, the survival probability was almost the same between the two arms. And if you look at even in the cisplatin, carboplatin specific population, you can see there's a separation between cisplatin and carboplatin, but within cisplatin and within carboplatin, there is no difference in the long-term survival probability. And we know that cisplatin is more effective than carboplatin in bladder cancer. So it would be expected that there would be a difference based on the kind of platinum drug. But within the drug population, there is no difference in 4 versus 6 cycles. And in bladder cancer, actually, majority of the benefit is achieved by 4 cycles. And based on this interesting analysis, actually what was demonstrated is that majority of the responses, they are achieved by 4 cycles. And when you take it to 6 cycles, it is actually only very few patients which actually achieve a deeper response, and majority of them will either have stable disease or some might even have progression. So personally, actually, I am using 4 cycles, but as per the study and as per the data, it is also fine to use 6 cycles for those who prefer 6 cycles. And you can see that both in patient who got 4 and 6 cycles, the OS benefit was there in both populations. So it is fine to use 4 or 6 cycles. So what about cisplatin versus the carboplatin? So there was a OS benefit in both cisplatin and carboplatin. But like I discussed earlier, cisplatin does better in bladder cancer, whether you use avelumab or not. You can see both the BSC and avelumab arm had better survival if you use cisplatin. So I think the preferred agent should be cisplatin for cisplatin eligible patient. What about a treatment-free interval? In the study, 4 to 10 weeks of treatment-free interval was allowed. But practically, I think we should not be delaying too much. Reason being that some patients might progress in this short period of time, and that might make them ineligible to receive the next line of therapy. So it might be better to give the therapy as soon as possible. What about the kind of response? So in patient who achieved CR, PR as well as stable disease, there was a difference in terms of OS for avelumab versus best supportive care. So it's not relevant, but definitely, of course, as you would expect, patient who achieved a CR will obviously do better than patient who don't achieve a CR. So if you look at the real world evidence of this study, where they have used avelumab maintenance, the data seem to be similar to the data seen in the Javelin 100 trial, and 12-year OS seem to be roughly in the range of 60 to 70%. So what about the next line of therapy? So many people say that we should reserve the drug for the next line. So some people say that why to use a front line, why not hold it for next line? The real reason is that some patient will never be able to get the second line. So that is why you should try to use your effective drugs as soon as possible. So what is the choice of second line therapy in these patients? So we have got a number of options. At least in our country, we have the option of using second line. If we have used chemotherapy, gem platinum chemotherapy and avelumab, at least we have the option of using various chemotherapy drug. Most commonly, I think it is the taxanes. We can also give platinum re-challenge in either with the same doublet or different doublet. And we have got number of other options like ifosfamide, doxorubicin, gemcitabine, etc. So at least these options are there. Erdafitinib is not available, but ideally, if you have the drug availability, you can use a FGFR inhibitor if the tumor is FGFR mutant. And of course, we have the option of new ADCs, which are currently not available, but hopefully they might become available to our patients soon, like enfortumab and sacituzumab govitecan. So in this study, patients were randomized to avelumab. Most of the patients out of the total, around the patients who discontinued avelumab and best supportive care. Among the patients who are 185, where the second-line treatment was reported, 75 received re-challenge with platinum-based therapy. A small proportion got PD-1 or PD-L1 inhibitor, and most of the other patients got some kind of chemotherapy. But you can see that there is erdafitinib, pemigatinib, and enfortumab also in the list. So yes, if these drugs are available, we have that option. And the patients did respond well to the second-line therapy. You can see that for erdafitinib, enfortumab, and sacituzumab, patients who have received prior immunotherapy also, they have a reasonable response rate and long-term outcome. So the guideline have also accepted the data from the study, and NCCN guideline recommended patient who got cisplatin eligible get GemCis, cisplatin eligible get GemCarbo, and platinum ineligible can get immunotherapy drugs or non-platinum therapy drugs, and patient who have got cisplatin or carboplatin should receive avelumab maintenance. So just to conclude, avelumab maintenance offers 30 months of OS as per the current data, and there is an improvement in 2-year OS as well as 2-year PFS. And patients who received subsequent immunotherapy, even though 74% of patients receive subsequent immunotherapy, still there is a OS benefit with avelumab. And patients who are PD-L1 negative or positive both benefited, and long-term safety as well as efficacy of this drug is established. Therefore, it is a good option for our patients. So I'll end with that. Thank you.
Thank you so much, Dr. Vinny, for delivering such a good talk. So moving ahead, I would like to welcome Dr. Shyam Agrawal. He is Senior Consultant in Department of Medical Oncology in Sir Gangaram Hospital, New Delhi, and he is going to speak on biomarkers in immunotherapy. Thank you, and over to you, sir.
So thank you very much for this opportunity. Thank you, Dinesh, for inviting me. So I think the slides are with the technical team. So I'm going to cover biomarkers and immune checkpoint inhibitors. So I think we've done a lot of work also, which we'll show you in the end in this regard. Next slide. So I think you've been hearing about a lot of, so we have to move the slides because there are a lot of slides. Next slide. So, you can divide these tumors into 3: inflamed tumor, immunogenic tumor, and host environment. So I'm going to cover all these factors as to how they help us in figuring out whether the immune checkpoint inhibitor is working or not working, or given or should not be given. Next slide. Next. So when it comes to inflamed cancer, so we're talking about PD-L1 as a biomarker. And as you can see, patients who are negative for the PD-L1, there is no response. However, the degree of response for PD-L1 positive is high, for patients who have PD-L1 high. So the lack of PD-L1 expression was correlated with lack of response to PD-1. Next. Next. So I think you can see these slides from various studies, Keynote 001 and 010, where you can clearly see that the patients who had TPS expression of the PD-L1, these patients, more than 50% have a curve, which is so much better than as compared to PD-L1 more than 1. Next. Next slide, please. Okay. So I think, again, not only the tumor cells, but also the immune cells have, become important in terms of looking at the PD-L1. And as you see here, so if the, IC, which is the immune cell, population is stained heavily, well, then you have a higher chance of response than as compared to patients where the responding population is lower. Next. So, the problem is that patients, for example, of RCC, irrespective of the PD-L1 expression, respond, whether it is less than 1% or more than 1%, so you can see. So therefore, what has emerged over the years is that PD-L1 absent cannot exclude a patient from getting immune checkpoint inhibitor, although the chances of response would be lower. Next slide. Next. So these are the limitations because, when you're looking at a biopsy, you're looking at a cross section which may be harboring cells which are negative, and you look at another section which could be positive, but you can't sometimes, do the staining for all the entire tumor, and that is one limitation of assessing the PD-L1. Next. So these are again the spatial heterogeneity, cell scoring, and methods of PD-L1 assessment. So I think this requires more work, but at the moment, PD-L1 is not an absolute marker for deciding on the use of immune checkpoint inhibitors. Next. So I think this is the same to show you various platforms which are available for determining the PD-L1 expression. You can see the antibodies, which you are all aware of. Next. So this is another, gene signature, which is used in IMpower 150 study design to look at patients whether, if they have T effector high and T effector low, which is based on the PD-L1, CXL9, interferon gamma expression. So, 87% were high, 13% were low. Next slide. So it did, kind of tell us that there is some difference if you do the, high T effector gene study, because these are the results for that. So, but I think the problem is that these are expensive tests, and they're still not applicable to a large number of tumors. But I think there is a science there. So if we can refine this further, you may be able to come out with some kind of a test which we can use to decide whether the drugs, immune checkpoint inhibitors, will work better or not. Next. So next slide. I think we'll go through these slides. Next, please. Next. So I think this is another, if you go to the previous slide, which I'll come to later on, that the expression of CD3, CD8, and interferon can also predict. Next slide. Okay, so now coming to the immunogenic tumors. So we have these 4 markers: TMB, neoantigen load, MSI, and neoantigen clonality. So I think some of these we are using, for example, MSI or TMB. Next. So I think we all understand the science behind the TMB, that the higher the tumor mutation burden, therefore you will have the high neoantigen load, and this will lead to the CD8 cells or T cells to become active, and but then the PD-L1 expression or the interaction between PD-L1 and PD-1 does not allow these CD8s to kill the tumor cell. But I think suffice it to say that patients who have a high response to neoantigens from the lymphocytes, well, they will qualify for high TMB. Next. So I think one can determine the total the tumor mutation burden not only by the tissue next generation sequencing, but also by ctDNA, where you need small amount of blood, and that we need to analyze the NGS from the patient. Next, on the blood itself. So I think there is sufficient data to support the use of TMB. Next slide. And you can clearly see this is the neoantigen load, where you can see the TMB and the response to pembrolizumab. So if you have a high non-synonymous neoantigens as compared to non-synonymous antigens which are low, the responses will be different. So actually, you need neoantigens which are non-synonymous and therefore they will induce a much more robust immune response, and therefore you have high tumor mutation burden, which is non-synonymous, which means that the changes in the antigen lead to a different Can I go to the next slide, please? Hello. Yeah. So I think TMB and MSI high tumors are another important area. Next slide. So this has been used for a variety of cancers. So as you can see, there is an improved clinical responses to pembrolizumab in MSI high colorectal cancer. So as was being described before by the previous speakers, so you can see these responses or the deep responses and the longevity of responses if the patients exhibit mismatch repair deficiency. Next. Okay, so this can be determined by whole gene exome sequencing or by a large, NGS, which should incorporate at least 300 plus genes to determine the TMB. Yes, of course, as was being said before. Next slide. The cutoff for TMB is not, clearly decided at this point in time. But this is again another slide to show the response rates. They go up as the tumor mutation burden goes from 20, 30, 40, 50. And as you can see, response rates are touching 50% and beyond. Next slide. So these are other studies to show the blood TMB. So now there's ample data which we've discussed on the tissue TMB, but from the blood also we can do the next generation sequencing, but that's not clearly established at this point in time. Next. Yeah, so you can see the blood TMB, and the cutoff taken there was 16 in this particular study, and the response rates were 35 versus 5.5%. So this still needs to be, I believe, validated. Next slide. So, these are various studies where, foundation one says 10 mutations per megabase by and large. And the other one, for example, MSK impact says 7 mutations, and some say 20. So I think there is lack of consensus on the blood TMB cutoff value. Next slide. Next slide. So it is dependent on the sequencing depth and the mutations. So this is another slide to show the clonal, neoantigens versus subclonal neoantigens. So the blue ones are clonal. So if the duration clinical benefit is seen with clonal neoantigen benefit, then as compared to subclonal. Next slide. So these are all areas of research, which one needs to carry on. This is another, factor, the HLA genetic diversity. Next slide. So this again demonstrates the more diverse the HLA alleles, the better is the response to the IO drugs. So heterozygous at all loci, then as compared to heterozygous in one loci, will give you a differential response to the immune checkpoint inhibitor. Next. Next. So this is an interesting area of gut microbiome and circulating immune and genomic biomarkers. Next slide. So the ctDNA studies can look at the TCR sequencing, and that can be, looked at by the non-invasive molecular platform or dynamic assays, and that can also help predict the responses. Next. So this is one slide to show you that patients, if you look at the VAF for the TCR dynamic, during the immune checkpoint blockade, so you can see if the VAF for the TCR repertoire is high, then you have a good response. But as the VAF goes down, the tumor starts reappearing. So the TCR repertoire sequencing by ctDNA can also be used to predict the response to immune checkpoint inhibitors. Next slide. Next slide. So I think this is the same thing. Next. Yeah, I think we'll skip this. Next. Okay, so this is another predictor, which is interleukin-2. it tends to sort of, the levels increased upon progression in non-responders. So one can use interleukin-8 also in the serum for looking at responders versus non-responders, because non-responders will have high levels of interleukin-8. Next. So this is microbiome, and this is another very fascinating area if somebody wants to take up for research. Next, and we have some data on that. So I think this is a sort of a summary slide to say that the gut microbiome may improve anti-tumor responses to the immune checkpoint inhibitors. So these are the name of various bacteria which give you a good response. So I will not read these names, but you can see various drugs like ipilimumab or a combination of PD-1 or PD-1. So these bacteria are associated with improved response with the IO. Next. So these are melanoma patients. Again, you can see that the patients with certain human microbiome may augment responses. And I'll give you, and this is basically higher gut microbiota. And therefore, use of antibiotics during IO should be to the least, because the gut microbiota will come down if you use a lot of antibiotics. Next. So these are again these are established, that these are the bacteria like Bifidobacterium or genus Bacteroides or phyla, Firmicutes. These are, typical names, so which are shown to be beneficial, and these are detrimental. For example, various, as mentioned here. So I think one needs to sort of look into these at the research level, and one can augment the gut microbiome by doing the fecal transplants, by putting in these bacteria and feeding these patients who are getting IO and figuring out the response. So this is an active area of research. Next slide. So I think this is a busy slide, so I won't go through this. But again, these are names of bacteria which are associated with best clinical response and progression-free survival greater than 3 months in patients with non-small cell lung cancer. Next. So next slide. Okay, so this is something we've been doing for the last 3 years in our hospital, multiomics and immune phenotyping of cancer patients undergoing checkpoint inhibitor therapy. Next slide. So I'll just show you the summary slide here. So you see we had almost 60 patients of mostly lung cancer, but also oral and other cancers. And you see the patients who were responding. So they had, post immune checkpoint inhibitor, they had increase in the CD4, CD8, dendritic cells, activated T cells. The T cell proliferation index Ki67 went up, monocytes, NK cells, granzyme B expression, and even the baseline CD8, as was shown earlier in one of the studies, was shown to be high. The cytokine expression, as you see, interleukin-2, interleukin-3, and we saw interleukin-8 and even PD-L1. The protein expression, for example, the PD-L1 and Desmin. Then the genomic signatures, we found TMB, especially P53 and FGFR4 gene. We also did the metabolomic signatures. We found increased urea and arachidonic acid pathway. And in the gut microbiome, we found Bifidobacterium and these other, bacteria. And we also did the lysine biosynthesis pathway. So these are some of the, key results which we got, which are in the process of being published. Next slide. So to conclude, I think the most important thing which came out was the PD-1 positive CD8 with high Ki67 post immune checkpoint and the granzyme B response. So I think there is a need to identify more biomarkers so as to give the drug to suitable patients who are going to benefit because of the cost and the side effects of these agents. Next slide. So I think the biomarkers are still elusive for taking a call, especially on the negative selection at this point in time, and therefore it remains a very, very active area of research. And also, for example, with the gut microbiome, one can try and augment the response by doing the fecal transplants for patients who are getting immune checkpoint inhibitors. So I think with this, I thank the organizers and Dinesh for inviting us to be here together. Thank you very much.
Thank you so much, Dr. Shyam Agrawal, for your informative session. So, okay, so moving ahead, I would like to invite Dr. Jyoti Wadhwa for our next topic. She's the Vice Chairperson and Head in the Department of Medical Oncology and Hematology from Paras Hospitals, Gurugram. And she's going to speak on evolving role of CGP test in advanced stage cancer patients. Thank you, and over to you, ma'am.
Thank you. Good evening, everyone, and I'll share my slides here. Okay, so we all know that comprehensive genomic profiling has made the practice of precision medicine and precision oncology possible. We now do this for multiple types of tumors, but I'll restrict my talk today to its role in three key indications, namely metastatic non-small cell lung cancer, metastatic colorectal cancer, and the biliary tract cancers. So let's begin with the non-small cell lung cancer. We now know that there are a number of actionable biomarkers identified for metastatic NSCLC, and the biomarkers number has more than doubled over the last 5 years itself. So the journey, as it started in 2003 with the identification of significance of EGFR mutations, we moved on to get to know the influence of a few other biomarkers, namely ALK, ROS1, and in the past 5 years itself, we have been able to identify at least 8 new biomarkers. And all these biomarker identifications have helped in better decision-making and have improved the outcome. So much so that there was the study which looked at the decision-making based on the CGP, the report being available prior to the institution of first-line treatment for metastatic non-small cell lung cancer. And this study reported that when the decision-making was based on the results of CGP being available before instituting first-line treatment, the overall survival improved to greater than 4 times the other way around when the decision-making was made without the CGP results. So it's important. Tissue remains an issue, even though we may want in lung cancer to always get big chunks of tissues, but in reality, we often end up getting smaller bits, and sometimes it may not be possible at all to procure the tissue for further analysis. And herein comes the role of liquid biopsy or sampling of blood to enable comprehensive genomic profiling. There was this study which was published in 2019, the PEN2 study, a large study which included 323 patients with metastatic non-small cell lung cancer. And it demonstrated that tissue genotyping alone may not deliver timely results before first-line treatment. So if you notice here, out of these 323 patients with metastatic NSCLC, 94 patients underwent this Guardant 360 test only because this is what they preferred. They refused tissue biopsy. 101 patients underwent the Guardant 360 only because tissue CGP was not possible, either because the DNA quantity or quality or both were not sufficient, or in another smaller subset of 22 patients, the tissue biopsy was technically not possible. Another third subset was of 128 patients in which both were done, both complementary, the liquid and the tissue CGP was done. And if you notice here, it was found that out of this subset of 229 patients of 101 and 128 patients in which the tissue biopsy was done, in fact, in 44% of these patients with tissue attempted, we were unable to still get the tissue CGP results. So this again underlines the significance of a liquid biopsy. Now, presenting to you an interesting case that I've been treating recently, a 56-year-old man who had earlier been treated for carcinoma of buccal mucosa was diagnosed with second malignancy, namely adenocarcinoma lung, in August 2021. The tissue NGS was reportedly negative for all targetable alterations. However, PDL1 could not be done due to paucity of tissues. He was treated elsewhere with chemotherapy, the standard chemotherapy, went on to receive pemetrexed maintenance and did well till June of last year, when he had progression of disease. And at this time, he was given 6 cycles of pembrolizumab. In April this year, he again progressed both clinically and on imaging, and the biopsy of left lung subpleural nodule was performed at this time. Guardant 360 tissue and liquid tests were ordered, and this is the result of the liquid biopsy. It identified MET exon skipping mutation, therefore suggesting treatment with these 2 FDA-approved treatments. In addition, on this liquid biopsy, the MSI was stable and TMB was 7. Interestingly, on the simultaneously ordered tissue biopsy, this alteration was not identified. However, on pathologic review, the sample had H&E tumor content near the limit of detection for this assay, which could have adversely impacted the analytic sensitivity of the tissue test. However, some signals were definitely identified even on tissue biopsy. So based on this liquid biopsy report of MET exon skipping mutation, the patient is on tepotinib for the past 10 weeks, and he's already clinically better. Now, coming back to the non-small cell lung cancer and the liquid biopsy, there was this study called COMPLETE study, which compared the matched plasma versus tissue samples in almost 7,000 non-small cell lung cancer patients with stage 4 disease. And you would notice here that the positive predictive value of the liquid biopsy was to the tune of 98 to 100% for all these biomarkers listed here, namely EGFR mutations, the KRAS mutations, BRAF mutations, and the MET exon skipping mutations. And also for the AL-CROS1 fusions, the positive predictive value was as high as 92%, increasing our confidence in the liquid biopsy. This is another study, the NILE study, which aimed to evaluate the real-world impact of ctDNA genotyping and patients' outcome on physicians' first-line treatment choice in treatment-naive patients with metastatic non-small cell lung cancer. So 307 patients enrolled, 282 met the inclusion criteria, and out of these, 89 patients tested positive for a biomarker by tissue and or ctDNA. So making it almost 32% positivity by any of these 2 methodologies. So if you notice here, out of these 89 patients, there were 48 patients who tested positive by both tissue and the liquid biopsy. So tissue biopsy, total 60 positive results, making it a positivity rate of 21%. And by ctDNA test, 77 patients were positive, leading to a 27% positivity rate. However, if you notice further, there were 12 patients who could be identified solely on the basis of tissue analysis. And there were 29 patients who could be solely identified based on the liquid or circulating tumor DNA analysis. And therefore, if you notice here, proportion of all alterations detected by tissue was to the tune of 67%, whereas the detection rate was much higher to the tune of 87% when we analyze the cell-free DNA. Therefore, now the IASLC has also come out with a consensus statement wherein we know and we appreciate that there could be 3 approaches, namely the sequential approach, tissue biopsy followed by liquid biopsy, or a complementary approach wherein you order both of these together and simultaneously, or there could also be a scenario wherein you would order only plasma first approach. And in the current NCCN guidelines, for the first time, these guidelines also recommend the concurrent liquid and tissue testing approach or the complementary approach. Coming to the second very common indication, the metastatic colorectal cancer. To start with an interesting case, this was a 46-year-old man who was treated for locally advanced adenocarcinoma rectosigmoid T3N2M0, was treated at another center, and this was in August 2021. And at that center, biomarker testing was performed for this patient using PCR-based hotspot testing, and it was reportedly negative for codon 12 and 13 of KRAS and BRAF V600 mutation. Patient received adjuvant chemotherapy and was on follow-up. And in July 2022, he developed liver metastasis. And the metastases were confirmed on biopsy. And again, now a complementary tissue and liquid biopsy was done. Herein, on the liquid biopsy, KRAS Q61H mutation was found, indicating that these anti-EGFR therapies would not work. There was no other significant finding. Again, on the tissue, though, it was still reportedly negative. And the patient was treated based on this result and did well. Now, if you compare the liquid CGP with the hotspot testing, it is well known that 25% of all samples with resistance mutation could be detected outside the RAS exon 2-3 hotspot, which could have occurred, or the tumor also could have evolved over time. Now, the addition of ctDNA genotyping to clinical practice has the potential to improve, in fact, the care of these patients with metastatic colorectal cancer, as was documented in this study, which prospectively enrolled patients with untreated metastatic CRC patients. And these patients underwent the sampling, the standard of care tissue sampling, as well as the ctDNA NGS was performed. So if you notice here, the biomarker discovery rate was lower in the tissue standard of care tissue analysis. It was higher with the ctDNA analysis, and the patients who could still be tested only on tissue was to the tune of 10%, and it was to the tune of 16% detected solely on the basis of ctDNA. However, there was a big chunk of 73% of patients who tested positive both for tissue as well as liquid. So the sequence, depending on case scenario based on this test could vary from doing liquid first, followed by tissue in case it's negative, which is likely to help another additional 10% of patients, or the other way around, wherein you do the tissue first, followed by the liquid later, wherein it could add additional 16% of the patients. We are also aware of this Kronos trial, interesting trial, wherein circulating tumor DNA was used to guide a re-challenge with anti-EGFR therapy, namely panitumumab, in patients with metastatic colorectal cancer. So the patients initially, as the first line, received chemo with anti-EGFR therapy, responded, but then progressed. There was anti-EGFR free intervening interval. And on the subsequent progression, the patients were again tested, and based on the liquid biopsy-driven report, they were re-challenged with the anti-EGFR antibody panitumumab. And interestingly, it was when this approach was followed, it was found that the response rates to the tune of 30% could be reported, with disease control rates as high as 63%. So this is another interesting data. Coming to the third and the last indication, the biliary tract cancers, the role of liquid CGP. This was a 60-year-old lady who was diagnosed with metastatic gallbladder cancer and was initially treated with the standard first-line chemotherapy, namely GemCis. However, after some time, after 6 months, the PET scan reported disease progression. At this time, the comprehensive genomic, the tissue biopsy was done. However, the quantity was not sufficient, and hence a liquid biopsy by Guardant 360 was done. And this was able to report FGFR2 alteration, and the patient was offered the specific targeted therapy. In fact, in this largest study and the most comprehensive study of almost 1,600 biliary tract cancer patients, the study highlighted the utility of cell-free DNA analysis in the current management because this test could detect some targetable genetic alteration in 44% of patients, which is a huge number. In fact, if we think of it, if the patient could afford, they could benefit from a specific targeted therapy. So again, emphasizing that there is a definite role for doing comprehensive genomic profiling for many advanced cancers, including rare tumors, and definitely for metastatic non-small cell lung cancer, colorectal cancer, and now it's very much emerging role in the biliary tract cancers as well, besides various other tumor indications. So I would end my talk here, and thank you for the opportunity. Thank you.
Thank you very much, Jyoti.
Thank you, sir.
Thank you very much for this presentation. As we are short of time, I would like to immediately move to the panel discussion, but please be with us. Dr. Rajakumar is our moderator for the next session, and the topic is biomarkers in immunotherapy. Dr. Rajkumar, please take.
Sir. Thank you, sir. Thank you for giving this opportunity to moderate a session. A very interesting topic on biomarkers in immunotherapy. I have all the panelists with me.
So I would like to invite Dr. Gauhar Shafi. He is Chief Scientific Officer in Department of Clinical Genomics and Bioinformatics, One Cell Diagnostic, Mumbai, and Dr. Arun Kumar. He's HOD and consultant in Department of Radiation Oncology, Subharti Institute of Cancer Management, Meerut. So yes, we have both the panelists with us.
Thank you.
I would also like to call Dr. Jyoti Vadva and Dr. Shyam sir if they are available for the panel discussion.
Let me share the slides. You can see my slides?
Yes, sir.
Yeah, thank you. I'm Dr. Rajkumar, consultant medical oncologist from Velamal Specialty Hospitals in Madurai. Today's topic is on biomarkers in immunotherapy. We have listened to various speakers talking on the role of immunotherapy. The immunotherapy has made a paradigm shift in the management of the cancers, as we all know that. And immunotherapy as a monotherapy, unfortunately, has made only 30% response rate in various cancers in an unselected population. That's the reason why we need a good biomarkers to choose which are the subset of the patients who are going to benefit with the immunotherapies. So personalization are more targetables, are more focused patient population, and you need a good biomarker to assay which are the subset of the patients who are going to respond to an immunotherapy. As such, immunotherapy as a monotherapy has produced only less than 30% response rates in various cancers, in various settings. So let's go to the first question.
Sorry to interrupt, sir. Can you do your slides on slideshow mode?
Yeah, that's fine. Okay, Dr. Shafi, are you there?
Yes.
How do you define a biomarker in the context of immunotherapy? Since the biomarkers can be of various, it may be of tissue in origin, can be blood in origin, it may involve the various markers of the immune cells, can be T cells mediated, can be a different variety of the TMEs, the immunosuppressive TMEs. So how do you define a biomarker in the context of immunotherapy?
Yeah, it's a very interesting question. With respect to immunotherapy, particularly cancer immunotherapy, biomarkers, immune biomarker is which can provide us insight about individual patient, how the patient is immunologically active or inactive. That means, see, we need to understand if patient immune system is hot or inflamed, that could lead to the easy activation of immune system. Therefore, the patient could benefit with immune therapy. And there are various ways to measure this immune biomarker. like mostly we look for PD-L1 based on protein expression. Then we look at genetic level, like earlier speakers, Dr. Sham Agrawal has very well explained, tumor mutation burden, microsatellite instability, and even at cytokine level, cytokines, chemokines, all these play an important role in terms of identifying if patient's immune system is immunologically active.
Does the presence of a biomarker in a tissue or a blood, does it mean these patients are going to respond to an immunotherapy per se?
Yeah, if we look at the literature, we have seen it. There are a lot of patients when we see the PD-L1 is positive and patients have benefited. But at the same time, we have seen there are a lot of patients who are even PD-L1 positive but have not responded. And that explains that, that's not the complete case. And, it's not just one biomarker. It could be possibly combinations of multiple biomarkers, which could give us a much better picture. And more importantly, which I would like to highlight here, we are looking for the biomarkers for sensitivity of a therapy, but we often ignore the biomarkers which could lead to resistance of the same therapy. Here we talk about, oh, I have a PD-L1 high and let me start with immunotherapy, but I don't look at, is there any biomarker which could lead to resistance to that therapy? So therefore, we have to look the other side of the coin as well.
So you have biomarkers pertaining to a response assessment, biomarkers pertaining to a resistance, identifying which are the tumors which are going to be resistant, and biomarkers pertaining to a hyperprogressions or various other things. Dr. Arun? Dr. Arun, is there?
Yes, sir. Yeah, please.
These biomarkers, is being a radiation oncologist, these biomarkers will be in a position to help you to identify a subset of the patients who will benefit with the combination of radiation as well as immunotherapy. Does it help you?
Yeah. There are studies which shows that the immunotherapy and combination of especially high dose radiation therapy is able to break the whatsoever the equilibrium is happening between the tumor and the immune system, and they able to generate enough cytokines that help in giving a synergistic effect post radiation therapy in the same tumor as well as in the micro tumor environment, in micrometastasis, that you can call abscopal effect. That is also that is more reported in the literature. But yes, the combination of high dose radiation therapy and immunotherapy is helpful, especially in the metastatic cases.
Okay, thank you. Dr. Shafi, what kind of biomarker can be used? In the upfront setting, in a metastatic setting, following a response assessment, or what is the clinical scenario where you like to use the biomarker?
See, when we talk about immunotherapy being a very most expensive treatment, and now we know that we are even talking about first line immunotherapy like non-small cell lung cancer. So it is important that we need to understand complete picture of that patient using these biomarkers. Possibly go with comprehensive genomic profiling to understand the complete mechanism of which can explain whether the patient has a high tumor mutation burden or high neoantigen load or microsatellite instability. At the same time, the protein expression of PD-L1 is high, as well as at the same time we should know that if there is any biomarker which could lead to resistance to that immunotherapy. So immunotherapy is an expensive. We often call these kind of testing is financial toxicity. We talk about they are very expensive, but we forget that if I have started with this high expensive therapy over the period of 3 months, then I come to know that patient is progressing, not responding, showing resistance to that. So that's why we need this biomarker.
Also, sorry to interrupt you. So you do these biomarkers upfront, the de novo case, whether you are planning for an immunotherapy upfront or maybe using the immunotherapy down the line.
Yeah, it is. See, we need to if we try to understand, see what is happening here, even upfront setting, or even down the line, later on, we have to understand the patients better, and we have to treat a cancer patient at the speed of cancer. So we often say, let's wait and watch, I may use it later time point, but it's important now. That's what we have seen, it how immunotherapy has moved to first line. And second thing is, it's not even if I have started now immunotherapy, I use the same biomarkers, particularly, circulating tumor DNA as a biomarker to measure the response of immunotherapy. I can wait for a PET scan 3-4 months, but I can immediately use these ctDNA based biomarkers to see whether immunotherapy is working, which is a non-invasive way. And at the same time, one of the biggest challenge we have with the current imaging based technique like pseudo progression with immunotherapy. So we may better assess that, whether it's a true progression or pseudo progression.
Fine. Dr. Safi, as we have seen, as you are also talking about, the biomarkers can be used in the response, in evaluating the response, in evaluating the resistance, either upfront or down the line, evaluating the toxicity of the IOs, and to find out who are the hyperprogressors and who, as I told, 30% of the patients may have a response rate with monotherapies and immunotherapy, but some 5 to 10% may have maybe in a hyperprogressor, they may be progressing while on treatment. So these are the various settings where which the biomarkers can be used to identify the subset of the patients who are going to respond, subset of the patients who are going to develop resistance for the tumor, subset of the patients who may have a higher toxicity, and subset of the patients who may have a hyperprogression while on treatment. So, Dr. Shafi, how these biomarkers are measured? Whether with the help of tissue, or you like to prefer with the help of a blood, which is non-invasive, or you like rely on the tissue, which may be a small biopsy or surgical specimen biopsies. There may be discordance between a small biopsy and surgical specimen biopsies, which is the most preferred one, how it is measured.
Yeah, I think this is very important question. What should we, use as a specimen? Often, most of us we prefer tissue, but we should not have a bias. That tissue is the preferred way, but it has to be individualized in every case. We know in certain situations tissue may not be available, or we also know that even tissue is available, but it's an issue. There are a lot of issues with tissue. And therefore, we have to individualize each and every patient. So where we don't have a tissue available, and we have now well-validated assays, liquid biopsy-based assays where we can do the genomics, we can do the transcriptomics. Even we have now, though it's not well established, even we can do the PD-L1 expression on circulating tumor cells, which may give some kind of information. Though you may not get the score as you get in tissue. So what I feel is, maybe tissue first approach can give us an example. But if you remember, the previous speaker was talking about combinatorial approaches much better, where we have more information. And two things I feel is, which is very important, we should understand. Tumor is heterogeneous, and if we are taking tissue biopsy, it's not going to be the representative of the entire tumor heterogeneity. And second thing is, tumor is evolving, and therefore, if we have a tissue biopsy which may be older than 3 or 4 months, may not be the exactly representative of what you are looking at, in terms of measuring these biomarkers, particularly when we talk about this next generation sequencing technology.
But Shafi, Dr. Shafi, whether these liquid biopsies are reached a prime time, where the liquid biopsy for a biomarker in the immunotherapy context we are talking about, whether these liquid biopsies stand alone is as equally good as a tissue, as well as, because many of them prefer to take both the tissue as well as the liquid, both the things, and they to compare it, or whether the liquid alone, standalone, has reached a prime time, so you can forego the tissues.
I think, if we do a liquid biopsy and we found what we are looking at, then that should be sufficient. However, if a liquid biopsy is negative, then it is highly recommended that it has to be done. It has to be repeated on tissue biopsy.
That's fine. So an ideal, these are the various parameters by which you can make it as an ideal biomarker. It should be preferably a non-invasive, so that you can do a temporal sequencing of that. Temporal heterogeneity can be identified. It should be rapid in turnaround times. If you do it in a ctDNA, it may be more rapid in time sensitivity, multifactorial, comprehensive. If it gives the whole genome profile of a tumor, that is more comprehensive thing, therapy specific. It should be have a predictive factor, not only a prognostic one, it should be a predictive one. And it can assess the resistance to toxicity. This may be an idle silver bullet, but we do have any biomarkers satisfying all these criteria, Dr. Shafi?
Yeah, I think, see, this is what is happening here. Most of us, when we talk about these biomarkers or next generation sequencing, we restrict ourselves with the small gene panel or hotspot panels. You have just heard the previous speaker was talking about that colorectal case where, KRAS hotspot was negative by, hotspot testing, and when NGS was done and then KRAS, a different mutation was identified. So, there are these biomarkers. We know now liquid biopsy is a non-invasive. It saves the time. We know that the turnaround time of these tests are within 10 days. Now, a lot of places we know that we get it quick. And comprehensive, plays an important role. There are people calling about 52 gene panel as a comprehensive. I won't agree with that. It doesn't give the comprehensive nature. Now we know the cancer is so complex, and we need to, know more and more. We have to go comprehensive. We should NGS assay should give us all type of genomic alterations which are important in cancer. Beta, small, SNVs are indels, amplifications, TMB, microsatellite instability, loss of heterozygosity, or HRD. These become very important, and most importantly now, what we have to look into, not just how can I identify which therapy will work. I should also know how can I identify which therapy may not work, which can lead resistance, and I should also know how I can find a biomarkers which are prognostic, which can tell me, this patient is going to relapse, it is going to recur, and resistance. At the same time, I should also know if there is a possibility of higher toxicity, dosage can be adjusted, and these biomarkers are available, and now we should start adopting them in actual practice.
Fine, Dr. Safi. Thank you for that elaborate answer. That is going to be discordance between liquid and tissue. Will you go ahead with the liquid?
Yeah, there is a discordance. It's well established discordance between liquid and tissue. And there are, as previous speakers also highlighted, something you may miss in tissue, you may capture in the liquid. Similarly, you may miss something in liquid, you may capture in the tissue. That's why the combinatorial approach is better. However, there has been found more, liquid is more informative. It gives more information compared to tissue alone.
Fine. So we have various biomarkers from the tissues like PD-L1, TMBs, and your CD8 plus and Tregs and all. And from the blood, we have the NLR, ANC, ALCs, NLR, LDH, ERPs. This is really relevant to Dr. Shafi, these ANCs, NLCs, NLRs, ALCs. These are all very cost-effective way to assess the immunogenicity of a tumor. Does it really helpful to find out the NLRs?
See, a lot of research need to be done, and a lot of work has to be done to see how they are well correlated with actual finding and how we can use it. Of course, sometimes if I don't find anything, what we know right now, other than that, maybe this could be helpful. But definitely, this is research.
Research company setting like us, these may be a cost-effective way to look into the immunogenicity of the tumor. And we have other ctDNAs, exomes, and cytokines. We have the CD8 and the microbiome. That's what the Dr. Sham Agarwal is talking about, the various microbiomes and how it modulates the immunomodulatory effect of the microbiomes of the initiation and progression of the tumor, as well as the response to immunotherapy or modulation of the immunotherapeutic response to the microbiome plays a very important role. We are only slowly unraveling the role of the microbiomes nowadays. So as you can see, is of all these various biomarkers, which is the most preferable one, Dr. Shafi? PD-L1, TMBs, are they all robust one?
I think, PD-L1 is the lot of data supporting that, PD-L1 in terms of defining the, whether we should go with immunotherapy followed by, MMR or MSI. And TMB, as you heard it in previous speakers, it's also very good biomarker. But the problem with this, we don't have a consensus. What is the actual cutoff where I can call it high so that patient is eligible for immunotherapy?
Sorry to interrupt you, Dr. Safi. PD-L1, a lot of pitfalls are there, various interpretations of the IHG is based one, which is based on the visual cue. So a lot of inter-observer variability, a lot of pitfalls are being reported, and tumors do respond to immunotherapy, even with the less than 1% of some of the tumors. The percentage may be differ between 1% to of 50%, more than 50%, but the less than 1% tumor also do respond to immunotherapy. What comments on that?
Yeah, exactly. See, what I see, there are those limitations. It could be, as we know, the tumor is heterogeneous, and if I have taken a sample and that sample could not be representative of the entire tumor, and it shows me PD-L1 actually less than 1%, but it could have been more. That's one way of, explaining. Second thing is PD-L1 is not the only biomarker to define that, this patient's tumor is highly immunogenic and it will respond to it. That's the reason we need other biomarkers. And the combination of, if I have PD-L1 and TMB, we have seen you will have more patients who could benefit with that. And if you combine with now PD-L1, TMB, and MSI, then definitely it gives more powerful biomarker that, how it will help you to identify patients who could benefit with, with immunotherapy.
Then we have other markers like TIL, JEPAS. Dr. Shafi was talking of combinatorial approach will be far better than choosing only one assays, which may have many pitfalls. And now we have the immune PET also using various traces for the PET CT imaging, which can show which are the patients who are going to have a good response. Hyperprogressors can be identified with the help of various novel traces using the PET CT, pro-inflammatory cytokines, IF and gamma, and various biomarkers. The biomarkers is now becoming very crowded. And as you can see, what is this immunoscore, Dr. Shafi, which seems to be a little better biomarker when compared to the PD-L1 MSI on the left-hand side, PD-L1 MSI, TMB. They say the immunoscores, the immunoscore is which is a better biomarker when compared to the PD-L1. Is it true?
Yeah, so see, the way immunoscore is being calculated is going to be calculated if it is combining all of these parameters, like PD-L1, then immune cells, TILs, tumor infiltrating cells, whether CD8 positivity, then other factors. That gives a score which could be possibly, a strong score which can help us to differentiate between the patients who could benefit with immunotherapy or not. And these things are coming up, particularly nowadays. In fact, the AI is playing an important role. This kind of score can be drawn from simple histopathology imaging, and all this immune score can be given, and from that, which is cost effective, and you get all of the information from that using AI, and you'll be able to decide who will benefit from immunotherapy and who may not.
The distance between the CD8 and PD-L1, which can be contemplated with the help of an AI, as Dr. Shafi was talking about the digital pathology, and the right-hand side picture is showing the digital pathology, and help of AI, we can do a better scoring when compared to the visual cues on the left-hand side. So the response evaluations, various biomarkers, who is going to be the lead? Who is going to be the winner? Is there any guess? Or is going to be combinatorial, as you always keep on saying, this is a combinatorial, not a one single one. Am I correct?
See, nowadays, what has come about the response evaluation based on liquid biopsy is just ctDNA presence or absence is best way to actually measure the response, particularly with immunotherapy. That's the new ways is coming up.
These PD-L1 can have a various pitfalls in the PD-L1, various slides which we can show that the PD-L1 expression is found to be The keynote 001 has shown that the PD-L1 expressors do respond to your immunotherapy better than the PD-L1 non-expressors. The various cutoffs has been evolved over the period from 2016-15 when it was started. The immunotherapy era began. Now in the cutoff, the more than 50%, which for various monotherapies and combination therapies where more than 1% became the cutoff. And this is a various keynote trials which have shown that the expressors are going to have a better response rate when compared to non-expressors of PD-L1. The thresholds keep changing, and various tumors showing the PD-L1 expressions. Once again showing, and when you are using an unselected population when compared to a selected population, so the expression are showing more than 40% or an average of 45% when compared to a PD-L1 negative. But don't think that PD-L1 negatives are not responding. They do respond with around 20%. So that's where the dilemmas comes in, and see RCC and melanoma showing higher positivity when compared to the RC pancreatic cancers and gastric cancers. It has got a limitations. Good responder to the non-responder. Even if the patient with 0% PD-L1 IHC positivity can be a good responder, as Shafi was talking about, because of the heterogeneity of the tumors. Heterogeneity of PD-L1 IHC staining limits assessment of the smaller biopsies. Is being a visual cue, AI and digital pathology helps you. But in being a visual Q1, that may be intra-observer and intra-observer variability. The validations is when the clones are very different. Clones are there. Many various companion tests has been assigned along with the different immunotherapy markers, many cutoffs, and is still the assessing the immune cells, total immune cells, what you call the combined positive score, is really controversial. You keep counting all the immune cells. Is it the right way to do, Dr. Shafi, or you take only the tumor cells which express which one is the most robust one?
Rajkumar, I'm sorry to interrupt. I'm Dr. Pendarkar. We have probably another 3 minutes we can discuss because we are overshooting the time. Thank you. Thank you very much. Sorry to interrupt.
Thank you. Let me finish off. Okay, sir?
Please go ahead.
Okay. These PD-L1 IHCs is because of the heterogeneity. As you can see that they may have heterogeneities, and the difference between biopsy specimen and surgical specimen, intra-observer variability, and PD-L1 expression all comers. So the discordance between the TMBs and the PD-L1, high TMBs and high PD-L1, and high TMBs and low PD-L1. These are various discordance between TMBs and PD-L1s. Optimal sample specifications. Any sample of the abdominal tumor less than 100 tumors is considered as inadequate, so it should be more than 100 tumors. Formalin fixed blocks are good. TMBs is a synchronous mutation load which is being assessed. More than 10 or 13 different trials do have different threshold. More than 10, some of the trials, more than 13, some of the trials. So, unresectable metastatic TMB high, more than 10 mutation parameters for the tumors, as FDA has approved this tested TMBs. These gives you the new antigen loads. As you can see, the high TMBs do respond to immunotherapy very well when compared to low or medium TMBs. As you can see, there's the high TMBs. So the cutoff values are differ between different. One melanoma, you have high cutoffs, and compared to NSCS, 13 MB per base pair, and MSI high, the DMMR status. These are useful in colorectal cancers and the gastric cancers and the endometrial cancers. As you can see, assessment of the MMR deficiency, which are for ML1, PMSL2, MSH2, and MSH6. And TCR, reportory variability. This is once again one another biomarkers which helpful in assessing the tumor response. The immunoscore, which we are talking about, the percentage of the immunoscores. The immunoscores is the gives you a better validity when compared to the PD-L1 and all. So resistance, STK11 mutations found to be a resistance biomarker, and toxicity, TCR. Once again, TCR, we may assess the toxicity. Higher the TCR, higher the toxicities. Hyperprogressors, MDM2 amplification, EGFR, and Microbiome, various, this is Dr. Shyam Agarwal has talked about various microbiomes, innate immunities, SNPs, TCR inhibitors. So combinatorial and various biomarkers are coming up in a different way. The combination of therapies requires a combination of biomarkers, and it is very crowded now. It's not a very simple like in the earlier part of the usage of immunotherapy. Now is very highly more and more biomarkers in the pipeline, and optimization, evolving landscape for optimal way to assess is yet to be there are going to be a silver bullet. Thank you. Thank you,
Thank you
sir.
very much, both of you, and really thank you for a nice presentation. Unfortunately, we are short of time, but this was a very important discussion. And I would like to move on to the next topic. We have a presentation by Dr. Shipra Gandhi from Roosevelt Park Cancer Center. So Roosevelt Park is our partner in educational activities. They are really helping us with many things. Fortunately, a few of their experts had to drop down because Dr. Guru Kamal has some family issues, and Dr. Edwin and Dr. Grace, they actually committed to join, but because of the time schedule, we had to change some time. It was a fault on our part, and because of this time lag, they are not able to join. But we're grateful to Dr. Edwin and Dr. Gaze for agreeing. I'm sure in our next meetings, they would be helping us. So I would really now would like to give time to Dr. Shipra Gandhi, who is a breast cancer expert and a big way involved in clinical trials of immunotherapy in breast cancer from Roosevelt Park. Go ahead, please.
Hello, everyone. I'm Shipra Gandhi. I'm an assistant professor of oncology here at Roosevelt Park Comprehensive Cancer Center, specializing in treating breast cancer. And today I'll be providing updates in immunotherapy in breast cancer from ASCO 2023. So as we are all aware of the Keynote 522 trial, this was a randomized phase 3 trial that enrolled patients with high-risk triple-negative breast cancer stage 2 to 3 and randomized them to a chemo backbone of carboplatin, paclitaxel, doxorubicin, cyclophosphamide with and without pembrolizumab, followed by surgery, and then these patients either continued pembrolizumab or they were on placebo. And the study showed a PAT-CR improvement with the addition of pembrolizumab. And therefore, based on this, FDA approved pembrolizumab and chemotherapy for high-risk triple-negative breast cancer patients. However, we have to remember that the addition of pembrolizumab in the neoadjuvant setting is associated with a lot of immune-related adverse events. So the grade 3 to 5 immune-related adverse events on the Keynote 522 trial were 15%, and these could be life-threatening like cardiomyositis, encephalitis, hepatitis, and therefore we have to very judiciously decide who are the patients who would benefit from the addition of neoadjuvant pembrolizumab, especially for these high-risk triple-negative breast cancer patients. And this is because if we see 30 to 50% of these patients will attain a PCR just to chemotherapy alone. So it's the additional 10 to 15% patients who are actually deriving the benefit from the addition of neoadjuvant immunotherapy. And it is important that we identify these patients. So at this time, there is an unmet need for biomarkers of response to neoadjuvant immune checkpoint inhibitors in early stage triple-negative breast cancer. And this was a very interesting study presented at ASCO this year, which looked at the biomarker analysis of the NeoPact trial. And the study tried to identify if there was a biomarker subgroup that we could identify who would selectively benefit from the addition of neoadjuvant chemoimmunotherapy. So as we are all aware, if the tumor is immunologically enriched, that means that if the tumor has high proportion of stromal tumor infiltrating lymphocytes, there is a higher probability to have PCR both with neoadjuvant chemotherapy and with neoadjuvant chemoimmunotherapy. But what are the predictors of response in the immune non-enriched tumors are not well studied. And the aim of this study was to investigate predictors of response to neoadjuvant chemoimmunotherapy and chemotherapy in stromal TIL enriched and stromal TIL low triple negative breast cancer. So this is the design of the NEOPAC trial. This was a single-arm phase 2 study that enrolled patients with stage 1, 2, 3 triple-negative breast cancer with tumor more than 1 centimeter in size or lymph node positive disease. And all these patients received a chemo backbone of carboplatin and docetaxel. So of note, there's no anthracycline in the chemo backbone. And in addition to pembrolizumab, and this was given for 6 cycles. Then these patients were taken to surgery. The primary endpoint was PAT-CR. And following surgery, there was no adjuvant pembrolizumab that was given on the study. So the authors asked the question that can gene expression analysis identify predictors of PCR in tumors where the TILs are either low or they're completely absent? Because we know if the stromal TILs are high, then those patients would likely have PCR both to neoadjuvant chemotherapy as well as to neoadjuvant chemoimmunotherapy. So there were many immune gene signatures available, such as the proliferation signature, T cells, B cells. The authors decided to use the IMSIC proliferation signature as their biomarker because this was the only signature that reflected an intrinsic cellular process rather than a feature of the tumor microenvironment. So this was selected for further analysis. And when the authors looked at the predictive ability of this proliferation signature, so higher proliferation signature was associated with the higher probability of PCR. But when this was segregated in the stromal TIL enriched and in the stromal TIL low tumors, we find that the proliferation signature only predicts for PCR in the stromal TIL low population, but not so much in the stromal TIL enriched population. So now the authors wanted to see how this proliferation signature compares to Ki67, which is another biomarker for proliferation in the tumor. And on the left here, we see that if the proliferation signature was high, both in the stromal TIL enriched tumors as well as in the stromal TIL low tumors, there's a higher probability of PCR compared to if the proliferation signature was low. But this difference is more statistically significant in the stromal TIL low group. Now, when we look at the group with Ki67, we find that high Ki67 was associated with a higher probability of PCR, both in the stromal TIL enriched and in the stromal TIL low group. But this difference was not statistically significant, showing that probably proliferation signature is a better biomarker for proliferation than Ki67. Then, interestingly, the authors compared the results of NEOPACT, which is the current study under discussion with carboplatin, docetaxel, pembrolizumab, with NEOSTOP study that only had chemo arm and did not have any immunotherapy. So they compared these signatures in the two arms to see what was the predictive benefit of immunotherapy. And interestingly, they found that in the stromal TIL enriched as well as in the stromal TIL low groups, if the proliferation signature is high, then there is higher PCR attained with the immunotherapy group as opposed to the chemotherapy group. But then when we look at the when the proliferation signature is low, we do not see this apparent difference, showing us that when the proliferation signature is high, giving immunotherapy to our patients is more beneficial than chemotherapy alone. So based on this, the authors concluded that immune enrichment was associated with PCR with chemoimmunotherapy. And importantly, they found proliferation signature as a biomarker that has the potential to predict benefit from chemoimmunotherapy, particularly in triple-negative breast cancers where stromal TILs are either low or completely absent. So we have to remember that this is just one study looking at this signature. And in order to have this signature be useful for clinical utility, it needs to be validated in other chemoimmunotherapy neoadjuvant trials. Now moving gears to Keynote 355. This is a clinical trial in the metastatic setting that enrolled patients with advanced or metastatic triple-negative breast cancer, irrespective of PD-L1 expression, and randomized them to get pembrolizumab with chemotherapy or chemotherapy alone. And we are all aware of the findings of the study, showing that the addition of pembrolizumab resulted in a progression-free survival as well as overall survival improvement, but this was limited to metastatic TNBC patients with PD-L1 CPS score more than equal to 10. So we have to remember that it's only 40% of our metastatic triple-negative breast cancers that are actually PD-L1 positive, where currently pembrolizumab is approved. There's 60% metastatic TNBC patients where we still do not have approval for immunotherapy. So that brings us to the Torchlight study. This was a randomized double-blind phase 3 trial of toripalimab, which is a PD-1 inhibitor, in combination with nab-paclitaxel in patients with metastatic or recurrent triple-negative breast cancer. This was presented as a rapid abstract session at ASCO this year. So toripalimab is a humanized IgG4K monoclonal antibody that specifically targets the PD-1, and it has shown very promising anti-tumor activity just as a monotherapy in advanced triple-negative breast cancer. So the purpose of the study was to compare the efficacy and safety of toripalimab and placebo in combination with nab-paclitaxel for patients with metastatic or recurrent triple-negative breast cancer. So this is the design of the Torchlight study. It was a randomized phase 3 trial that enrolled patients with histologically confirmed metastatic triple-negative breast cancer and randomized them in a 2-to-1 ratio to toripalimab and nab-paclitaxel or nab-paclitaxel alone. And the treatment continued until disease progression. The primary endpoint was looking at progression-free survival, both in the PD-L1 positive subgroup and in the ITT population. So this is the baseline characteristics, both in the PD-L1 positive group and in the ITT. And we see that most of these characteristics were very well balanced in the two groups of toripalimab, nab-paclitaxel, and nab-paclitaxel alone. Of note, this trial defined CPS positive as being CPS more than equal to 1. So we can see most of the patients, the median age was around 50 years. They had good performance score, ECOG 0 around, mostly in like 40 to 50% patients. Almost 80% patients had not received prior taxane treatment, and 20% of the patients presented with liver mets, showing that this was an aggressive group of patients in the study. So this was the primary endpoint, looking at progression-free survival in the PD-L1 positive group. And the study did show that toripalimab with nab-paclitaxel resulted in a PFS of 8.4 months versus 5.6 months, which was statistically significant. Next, when we look at the forest plot, we see that this benefit in PFS is observed in all the groups, irrespective of age, performance score, prior chemotherapy, line of treatment, or the metastatic site. So the results hold good in all subgroups. And then the authors looked at progression-free survival in the ITT population, which also included the PD-L1 negative patients, and showed that the combination did result in a PFS improvement, though this is more of an interim analysis and will need to be investigated further. In terms of overall survival analysis, again, these are some early results showing that both in the PD-L1 positive group as well as in the ITT population, the combination arm had higher overall survival compared to the placebo arm. Again, these results will need to be verified on longer follow-up, as these are some early results. Then the authors looked at overall survival and split them in the PD-L1 subgroups, that is PD-L1 between 1 to 10 and 10 and higher, and again showed a consistent overall survival benefit with the combination of toripalimab, nab-paclitaxel compared to nab-paclitaxel alone. In terms of immune-related adverse events, as expected, the addition of checkpoint inhibition resulted in higher immune-related adverse events compared to chemotherapy. These were hypothyroidism, rash, hyperthyroidism, LFT abnormalities, pneumonitis, neutropenia, pruritus, and so forth. So these were very much expected with the addition of checkpoint inhibition. So interestingly, the study showed that toripalimab in combination with nab-paclitaxel provided a statistically significant and clinically meaningful improvement in PFS for the PD-L1 positive metastatic or recurrent triple-negative breast cancer, defined as CPS more than equal to 1. It also showed a trend towards improved overall survival, both in the PD-L1 positive subgroup as well as in the ITT population. Now, we have to remember that currently, based on Keynote 355, the approval of immunotherapy is for CPS more than equal to 10. And this trial is showing that the benefit was actually seen even in those with CPS more than equal to 1. So again, these are some early results, and we'll have to wait for the forthcoming final analysis to test the PFS specifically in the ITT population, as well as overall survival in the PD-L1 positive and ITT population in a hierarchical manner in the final analysis. So next, coming to hormone receptor positive breast cancer. So we know this is considered to be the coldest, considered to have the coldest tumor microenvironment in breast cancer, because hormone receptor positive breast cancer has very low level of tumor infiltrating lymphocytes. And this is probably one of the reasons we do not have approval of immunotherapy for this subgroup of patients. However, if we have to make this group of patients immune responsive, we have to use some strategies so that we can inflame the tumor microenvironment and convert it from a cold to a hot tumor microenvironment, which would further be desensitized to action of immunotherapy. And that was the BRACELET-1 study that was presented at ASCO this year, that looked at metastatic hormone receptor positive HER2 negative breast cancer patients. So the study looked at inducing an inflammatory phenotype using an oncolytic reovirus called PalliaRep in combination with paclitaxel and avelumab. So as we are all aware, hormone receptor positive HER2 negative breast cancer is the most common phenotype of breast cancer in the early and metastatic setting. And the mainstay of treatment here are hormonal therapy that consist of agents like CDK4/6 inhibitors, mTOR inhibitors, and PI3K inhibitors. And only when the tumor progresses on this hormonal therapy do we use chemotherapy. The tumor mutation burden is low for hormone receptor positive breast cancer, and that's why it has an indolent course. And that is probably one of the reasons that immune checkpoint inhibitors do not work for this subtype of breast cancer. So here the authors looked at PalliaRep, which is an oncolytic reovirus that can invade and lyse the tumor cells, and therefore it promotes an inflammatory tumor microenvironment and activates both the innate as well as the adaptive immune response. So in preclinical studies in vitro, it was observed that PalliaRep can potentially be combined with taxane, and this combination has synergistic anti-tumor activity. So this was taken forth in a phase 2 clinical trial where the combination of PalliaRep with paclitaxel was investigated against paclitaxel alone, and it showed an overall survival improvement of 17.4 months versus 10.4 months. Interestingly, in the breast cancer cell lines in vitro, they also observed that paclitaxel and PalliaRep cause tumor upregulation of PD-L1. So the natural next thought was that if they are upregulating PD-L1, could we add an anti-PD-L1 therapy and further improve the response rate to paclitaxel and PalliaRep therapy? So the hypothesis of the study was that PalliaRep would induce an inflammatory tumor microenvironment and enhance the efficacy of paclitaxel in patients with hormone receptor positive HER2 negative metastatic breast cancer. And then the further addition of avelumab will be synergistic and improve efficacy. So the authors designed this BRACELET-1 study, taking patients with advanced metastatic hormone receptor positive HER2 negative breast cancer. 3 patients had a run-in with a combination of paclitaxel, PalliaRep, and avelumab, and then they were randomized to the 3 cohorts: paclitaxel alone, dual treatment with paclitaxel, PalliaRep, or triplet treatment with paclitaxel, PalliaRep, and avelumab. And there were a total of 48 patients who were enrolled on the study, 15 patients in each arm, and included patients with metastatic hormone receptor positive HER2 negative breast cancer who had not received prior chemotherapy for metastatic disease. So total of 48 patients were enrolled between June 2020 and June 2022. These are the baseline characteristics with median age of 50 to 60 years, predominantly white population, non-Hispanic, 50 to 80% were postmenopausal with a good performance status. And as we can see here, a huge proportion, 80% had visceral disease, and around 20% had received neoadjuvant or adjuvant taxane therapy. So interestingly, we see here that the overall response rate was actually higher in the dual arm and than in the triplet arm. And the disease control rate, however, was pretty much similar in the dual as well as in the triplet combination arm. Progression-free survival was actually better in the paclitaxel paliorep arm, not so much in the triplet arm. And the median PFS was again higher, 9.6 months in the dual paclitaxel paliorep arm. In terms of toxicities, as expected, very few grade 3 or high toxicities in paclitaxel arm and more of them in the combination arm, especially diarrhea, LFT abnormalities, neuropathy, and neutropenia. As expected, paliorep was associated with more viral-like symptoms, such as chills, pyrexia, and influenza-like illness. Now, the question is, why are we seeing these improved responses in the dual arm and not so much in the triplet arm? So when we looked at the peripheral T cell clones in the paclitaxel arm, there was no difference, but in the dual arm, the addition of paliorep to paclitaxel resulted in an expansion of the peripheral T cell clone, but this was again not observed in the triplet arm and could be one of the reasons why the dual arm did so much better compared to the triplet arm. So the authors concluded that addition of paliorep to paclitaxel is definitely worthy of further study, and paliorep does alter the T cell subsets, and avelumab actually blunts this increase, and therefore further biomarker analysis are underway to understand these differences that we have observed. So the take-home messages from these abstracts are that neoadjuvant chemoimmunotherapy currently remains the treatment of choice in stage 2 to 3 triple-negative breast cancer tumors more than equal to 2 centimeters or with lymph node positive disease based on Keynote 522. And we have to understand that there are only 10 to 15% early stage TNBC patients who actually benefit from the addition of chemoimmunotherapy. But currently, there are no biomarkers yet in clinical practice to identify these patients, and therefore we end up treating all our stage 2 to 3 triple-negative breast cancer tumors with immunotherapy at this point, and we definitely need more studies in this area. Chemoimmunotherapy is currently the recommended treatment for metastatic triple-negative breast cancer with CPS score more than equal to 10. We presented studies from Torchlight. However, we have to remember that these findings are early, and we will need final analysis in order to see that the overall survival actually holds up in that study. And immunotherapy in hormone receptor positive breast cancer continues to be a work in progress, and we need more and more strategies in order to turn these cold tumors into hot tumors to further potentiate the activity of immunotherapy. So thank you so much for giving me the opportunity to present these abstracts from ASCO, and I look forward to hearing any questions you may have. Thank you.
Dr. Shipra, thank you very much. Thank you very much for really doing this great presentation and bringing us close to ASCO. And I'm sure this was very insightful and very helpful for all of us, especially for those who did not attend ASCO. And as you know, only very few people attend ASCO physically. We are extremely grateful, but I'm sure your association with us would continue and you will help us in future meetings as well. Thank you very much again. Our next presenter today is Dr. Neeti Raizada. She would be speaking on immune checkpoint inhibitors. She would be speaking on immune checkpoint inhibitors in early stage triple-negative breast cancer. Dr. Neeti, please.
Thanks so much, sir, for inviting me today. It has been a lovely session. And actually, quite a few of my slides have been taken up already by Dr. Shipra. I'll try to present only the ASCO updated guidelines and restrict myself to the current approved guidelines. So we know that 10 to 15% of all cancers are breast cancer and triple-negative breast cancer, and about 2 lakh cases are diagnosed each year. We know that the predominant population is less than 40 years, and there's a 2-fold increase triple-negative in less than 40 than over 50 years. There has been a Lehman classification which has bearing on immune checkpoint inhibitors as well. And the classification includes basal-like, immunomodulatory, mesenchymal, mesenchymal stem cell, and luminal AR type. And what we have to understand is that based on this subtype, we also have the signaling pathway, and the immune modulatory type is the pathway in which immune cell signaling works and immune checkpoint inhibitors can be used. This constitutes about 20 to 30% in early stage breast cancer, triple negative. PARP inhibitors are useful in basal-like. mTOR pathways, MET pathway, and FGFR pathway are useful in mesenchymal type. And of course, PIK3 pathway in the androgen receptor type. Pathological CR, as we all know, has been known to improve outcomes in this triple negative setting, both in terms of event-free survival and overall survival. Most recently, we have residual disease burden, which is again implicated in long-term results, and RCB0 and RCB1, which is minimal residual disease, has favorable outcome versus RCB2, RCB3, which has unfavorable scores noted and long-term results not being very reassuring. This is a very nice summary given in the ASCO updated guidelines, in which less than 1.5 centimeter, we would initially go with surgery and then consider adjuvant chemotherapy with possibly non-anthracycline, which could be TC-based regimen. When the tumor size is between 1.5 and 2, which is not considered as high risk early triple negative, we would consider the standard neoadjuvant therapy, that is dose dense AC followed by weekly paclitaxel for 12 weeks. If there's pathological CR, no systemic therapy is recommended. If there's a germline BRCA positive, then with a residual disease, then 1 year of olaparib adjuvant is recommended. Based on the CREATEX trial, if there's a residual disease and germline BRCA is negative, we would give 6 to 8 cycles of capecitabine. In stage 2 and stage 3 disease, which is our focus here, neoadjuvant taxanes, which is weekly paclitaxel along with carboplatin, is recommended, and followed by 4 cycles of dose-dense AC. It could be 4 cycles of dose-dense EC as well, along with pembrolizumab. If anthracycline is contraindicated, then only TC regimen, that is taxanes along with carboplatin, is given in the neoadjuvant setting along with pembro. Again, there are 3 arms in this setting. When there's a pathological CR, well, this is a gray zone, but still at this juncture, pembro as an adjuvant is recommended as well. When there's a residual disease without germline BRCA, we can give pembro along with capecitabine in the adjuvant setting. If there is a residual disease with germline BRCA, we could give olaparib for 1 year along with pembrolizumab in the adjuvant setting. So what we know as the standard at this juncture, well, anthracycline and taxanes, as we say, remains the standard. With ECOG 1199 study, we know that weekly paclitaxel, which is 80 milligram per meter square, has improved disease-free survival with positive hazard ratio, which is significant. However, OR also was in favor of weekly arm versus 3 weekly arm. Dose-dense AC again remains the standard of care and has been known to reduce the risk of recurrence and the risk of death compared with conventional doses, that is 3 weekly AC. Now, what are the studies which we have which establish the role of platinum in the neoadjuvant setting in triple negative breast cancer? And the landmark studies are JPAR 6.2, which is actually a phase 2 trial in which neoadjuvant carboplatin was given in stage 2 and stage 3 triple negative breast cancer. The pathological CR, but this also included HER2 positive subset, which we all, TCHP regimen is also very common in HER2 where we use carboplatin. So in this, carboplatin was used in the neoadjuvant setting. And when both of these subsets were put together, the pathological CR was 54% with carboplatin, which was 37% without carboplatin. And so this established the role of carboplatin in the neoadjuvant setting. Now, brightness trial was another very interesting study in which paclitaxel was used in one arm, and in the other arm, paclitaxel was combined with carboplatin, and one more arm which had paclitaxel carboplatin with veliparib. Now, both of these platinum arms had BRCA positive and BRCA negative subset. But what we interestingly found out was that both the arms with platinum, that is pacli plus carboplatin, had improved pathological response rate, whether with or without veliparib. Actually, the arm with veliparib had a slightly inferior outcome. So again, JPAR 6.2 and brightness trial were the two trials in which platinum was established in the neoadjuvant setting with or without BRCA positivity. There's again a very interesting Indian study from Tata Memorial with 720 triple negative breast cancer, early stage. This was a randomized phase 3 trial and the only trial which also had overall survival as the endpoint. So there was an addition of carboplatin that with an AUC 2 weekly along with paclitaxel. Here, paclitaxel dose was slightly higher, but given only for 8 weeks. So 100 milligram per meter square per week of paclitaxel along with carboplatin was given, followed by AC. It was stratified based on the menopausal status. So premenopausal versus postmenopausal with an age cutoff of 50 years was given. And there was no significant improvement in pathological CR, event-free survival and overall survival in the older than 50 subset. However, all the three improved in the less than 50 subset. The exact rationale, what exactly were the interactions remain unclear, but younger age group, premenopausal and addition of carboplatin remains the gold standard based on this study as well. What is the rationale of immunotherapy? Well, Dr. Gandhi mentioned quite interestingly all the studies which were presented in this ASCO, but there's significant infiltration of tumor-infiltrating lymphocytes in triple-negative subsets. Almost 20 to 30% will have high PD-L1 expression, which is associated with infiltrating lymphocytes and also correlates with higher tumor grade. Higher PD-L1 mRNA expressions are again noted in triple negative versus non-triple negative. And we need to know that there's a loss of P10, which leads to upregulation of PD-L1 in such subsets. And according to various studies, the percentage of TNBC, which presents with hot tumor, are 25%. Now, there's also a thought process that addition of chemotherapy makes a cold tumor a hot tumor, and therefore addition of chemotherapeutic agents kills tumor cell and leads to pathway of immunogenic cell death, and therefore promotes the activity of the immunotherapy or immune checkpoint inhibitors by reducing the immunosuppressive effect of Tregs and MDSCs. These were the trials, and with which keynote 522 with Dr. Shipra Gandhi specifically mentioned, led to the establishment of pembrolizumab by the US FDA in 2021 in the neoadjuvant setting. Phase 2 I-SPY2 trial also demonstrated that adding pembro with taxane followed by 4 cycles of AC significantly improved the pathological CR, which was 60% in the chemo plus ICI arm versus 22% alone. So there was a 3 times increase of pathological CR. And this is the study design of Keynote 522 trial, in which Cabo along with Pacli was given weekly, followed by dose-dense AC, along with Pembro, which was about 1 to 8 cycles of Pembro in the neoadjuvant setting, and 1 to 9 cycles of Pembro in the adjuvant setting. This was compared with placebo. And what were the trial results? Pathological CR was 65%, which is remarkable in the chemo plus IO arm versus 50% in the chemotherapy alone arm. The event-free survival was again significantly in favor of the combination arm. The event-free survival in the Pembro arm was 94.4%, which was 92% in the placebo arm. So at this juncture, Pembro remains the only checkpoint inhibitor which has been approved in the neoadjuvant setting in the early stage, high risk, that is stage 2 and stage 3 triple negative breast cancer. However, there are several other studies, including durvalumab, cemiplimab, and atezolizumab in a similar combination. This is the atezolizumab study in which the results are still awaited, which is Impassion 031, which had atezo with nab-paclitaxel. Interestingly, there is omitting of platinum in this study, and so we need to wait and watch and see where we are going. The JEPAR-NIVO trial uses durvalumab in the neoadjuvant setting, and it has already shown in the phase 2 study that the 3-year invasive disease-free survival, along with distant disease-free survival and OS, has shown improvement in trend. One critical factor, as I said, in the Keynote 522 versus Impassion 031 and JEPAR-NIVO was the addition of carboplatin in the Keynote 522 trial, which I previously mentioned has shown significant benefit in other trials as well. Talking about NeoTrip trial. These are NeoTrip and NeoPact studies have tried not using anthracycline in combination, and the results have not been so remarkable. So what can we do in terms of patients who have received a good neoadjuvant combination in the adjuvant setting? So as we know, there are three scenarios in which there's a complete pathological response, where at this juncture, Pembro is approved. However, we need more data to substantiate the same. We have a situation in which pathological responses are not complete. And CREATE-X trial has established the role of capecitabine in doses of 1,250 milligram twice a day for day 1 to day 14 in 6 to 8 cycles, along with Pembro, which improves overall survival. PARP inhibitors have been tried in only phase 2 studies, and there's no phase 3 study at this juncture. But Olympia trial was used olaparib in BRCA positive patients in a dose of 300 milligram twice a day for a period of 1 year. And the second interim analysis did show overall survival advantage. And therefore, last year in March, olaparib was approved by FDA in adjuvant high-risk settings, in triple-negative settings, to be given in BRCA1 and BRCA2 mutation carriers. We need to carefully review the data of Keynote 522 and look for reasons for responders and non-responders. And one of the things which Dr. Chipra also mentioned were looking for biomarkers. Event-free survival did favor Pembro arm, but the risk-benefit ratio of adjuvant therapy with pembrolizumab should be carefully considered in scenario in which pathological CR is already established because of the known toxicities of ICIs, that is immune checkpoint inhibitors. We know that a significant population will have cutaneous toxicity, GI, pulmonary, neurological toxicity, and of course endocrinopathies. And a typical schema of management includes discontinuation of the immune checkpoint inhibitors temporarily, while we give steroids in low dose, that is 0.5 to 1 milligram per kg body weight, but escalate to 2 milligram per kg body weight if the toxicity is not resolving. The second step would be to add biologics, which could be infliximab, which could be rituximab or tocilizumab in the similar setting. And in certain cases, when there is refractory toxicity is not resolving, we could use azathioprine, cyclophosphamide, interleukin, IVIG, and cyclosporin as well. Talking about biomarker, an interesting biomarker which has been widely studied is multi-feature MRI or diffusion coefficient in diffusion-weighted MRIs to predict the pathological CR rates. ctDNA and CTC is something we all have been talking about. And of course, longitudinal monitoring of ctDNA at baseline and just prior to surgery to look for responses prior to see what is the correlation with the pathological responses. I-SPY2 trial indicates that the patients with triple negative are more likely to have positive ctDNA than other subtypes. Now, there has been, based on these biomarkers, there have been talks about tailoring of adjuvant therapy. Optimized RD is addition of sacituzumab along with in one arm versus capecitabine and Pembro in the other arm, to find out whether addition of sacituzumab will help when there's a residual disease. Tropion Breast 03 is a study of Dato-DXd with or without durvalumab versus investigator choice. There are ongoing studies with immune checkpoint therapies, targeted therapies, and vaccine trials in triple negative with residual tumor. So at this juncture, the take-home message is, yes, wherever feasible, assess the risk and benefit. Try to add immune checkpoint and inhibitors when the risk or the benefit of ICI is higher. There are several unanswered clinical questions, which include optimal Pembro partner, which includes continuation after pathological CR, sequencing of capecitabine and PARP inhibitors. So over to Dr. Nesh. Thanks so much for inviting me today.
Thank you very much, Dr. Neeti, for a nice presentation. This was actually so many new things are coming up in triple negative breast cancer that we have to be updated. Thank you very much for enlightening us. And we'll move to the next topic by Dr. Sarbajit Mukherjee. He is again an attending professor at Roswell Park Comprehensive Cancer Center. Extensively involved in clinical trials related to immunology, especially in gastroesophageal cancer and other GI cancers. So welcome, Dr. Sarbajit, and please go ahead with your speech. Thank you very much.
Hello, everyone. My name is Sharbajit Mukherjee. I'm a gastrointestinal medical oncologist at Roswell Park Comprehensive Cancer Center in Buffalo, New York. Today, we're going to talk about immunotherapy in gastroesophageal cancers, and we are specifically going to discuss some recent updates as were presented at the ASCO 2023 annual meeting. So these are my disclosures. As you all know that in recent years, we have seen a tremendous momentum for the immunotherapy drugs in upper GI cancers. In the metastatic setting, landmark trials such as CheckMate 648, CheckMate 649, Keynote 590, and Keynote 811 led to approval of different agents. And also in the resectable setting, CheckMate 577 led to approval of nivolumab in the adjuvant setting in resectable esophageal cancers. While all these approvals are significantly meaningful in terms of improving either progression-free survival or overall survival or disease-free survival, it is still a minority of patients who truly benefit from immune checkpoint inhibitors. As for example, let's talk about CheckMate 649 study. It is a global randomized open label phase 3 study. It included patients with previously untreated or unresectable metastatic gastric, esophageal, and GE junction adenocarcinoma. Patients did not have any positive HER2 status. Then they were randomized to receive nivolumab with either ipilimumab or chemotherapy, or received chemotherapy alone. And the study had dual primary endpoints, overall survival or progression-free survival in those who had a PD-L1 combined positive score of 5 or greater. The secondary endpoints included overall survival and objective response rate and progression-free survival in all comers. Now, as you can see here, there was a benefit in both PFS and OS in all comers. However, as you got more selective by using or looking at patients who had a PD-L1 CPS score higher, then you could see that the difference was even more marked. As for example, the top row actually shows those patients who had a PD-L1 CPS score of 5 or greater. And as you can see here, there was a significant difference, which were both clinically and statistically significant in terms of PFS and overall survival. So, although FDA approved this treatment for patients regardless of their PD-L1 CPS status, if you look at some of the guidelines, you will see that category 1 recommendation is only for those patients who have a PD-L1 CPS score of 5 or greater. So, keeping that in mind, we will discuss some recent updates from ASCO. At ASCO, we learned about some updated data from the Keynote 859 study. So in terms of design, it was similar to CheckMate 649 study. So patients that were included in the study had either unresectable gastric or gastroesophageal junction adenocarcinoma. This was again at a frontline setting. The PD-L1 status had to be known, and patients could not have a positive HER2 status. Now, instead of using nivolumab in the previous study, this study used pembrolizumab as their checkpoint inhibitor. Also, this study did not include esophageal adenocarcinoma. As you all know, pembrolizumab is already approved in esophageal cancer in the frontline metastatic setting. So again, patients were randomized to receive chemotherapy with placebo versus pembrolizumab. The primary endpoint was overall survival, and the secondary endpoints were progression-free survival, overall response rate, duration of response, and safety. As you can see here, there was an improvement in overall survival in all comers, but as you become more selective with their PD-L1 CPS score, you see that the hazard ratio narrows down significantly, especially, if you look at a PD-L1 CPS score of greater than or equal to 10, the hazard ratio is 0.65 and the curves separate well, telling you that this is the subgroup that benefits most from the addition of immune checkpoint inhibitors. Now, there are still some open questions. So when we had Checkmate 649 study, that study showed that there was a benefit in all comers, but at the same time, we did not learn about how those patients do who have a CPS score of between 1 to 4. So there was actually a great study published at Journal of Clinical Oncology a couple of years back. The investigators actually did a reconstruction of the Kaplan-Meier curve of the Checkmate 649 study and showed that those who have a CPS score of 1 to 4 did not really benefit from addition of nivolumab to chemotherapy. But we were somewhat lucky in our Keynote 859 study here. They did subgroup analysis of patients with a CPS score between 1 to 9. And as you can see here, there was still a benefit in those patients, and the confidence interval of the hazard ratio didn't cross 1. However, the benefit was clearly more among those who had a CPS score of 10 or greater. So what that tells us that we need to find better biomarkers other than CPS scores to find out which patients are going to benefit most from the addition of checkpoint inhibitors. Having said that, a CPS score is the best that we have. However, there are some debates about which antibody should be used. Different tests or different studies have used different antibodies, and there's some discrepancy among how they are scored, whether we should just stick with CPS or we should also consider a different methods of assessment like TPS, as was used in some of the checkmate studies. So again, PDL1 staining is not the perfect biomarker, and we probably need to find additional biomarkers to find patients who benefit most from checkpoint inhibitors. Now, shifting gears to the resectable setting, we are going to discuss some of the studies that were presented at the ASCO annual meeting this year. However, before doing that, let's briefly discuss the standard of care. So we are going to divide resectable gastroesophageal cancers into 3 types. First, squamous esophageal cancer, which is the predominant type in Asia. And as you know, that we typically see this in the upper and middle third of the esophagus. In the Western world, we sometimes treat them as per cross study. So patients receive neoadjuvant chemoradiation followed by surgery. But again, how much extra or additional benefit surgery adds is unknown. So sometimes these patients are treated with definitive chemoradiation. When we're talking about gastroesophageal junction adenocarcinoma, and again, this is predominantly the type we see in the Western world, patients can be treated with either neoadjuvant chemoradiation followed by surgery or perioperative chemotherapy. Sometimes in Asia, they can get upfront resection followed by adjuvant chemo. So either of those approaches would be considered standard of care, depending on where the patient presents. In gastric adenocarcinoma, we typically treat patients with perioperative chemotherapy in the Western world. However, in Asia, patients sometimes get upfront resection followed by adjuvant chemotherapy. Regardless of what the treatment modality is, you can all see that the survival, unfortunately, is not great. Patients often recur, and they recur distally, making them uncurable, incurable, and in Asian patients, we sometimes see that some patients have long-term benefits. However, the biology of the disease tend to be very different than what we see in the Western world. So there is definitely a room for improvement, and that's where immune checkpoint inhibitors play a role. As you all know, that Checkmate 577 was a randomized study that changed the treatment landscape of resectable esophageal cancers, and that also created a debate whether these checkpoint inhibitors should be used earlier, like in the neoadjuvant settings, and each have some advantages and disadvantages. If you use checkpoint inhibitors in the neoadjuvant setting, then you have the advantages of treating the micrometastasis early. Patients typically have better tolerability and compliance. You have the tumor intact, which gives you a better immune profiling. You can assess the sensitivity of immune checkpoint inhibitors. How, last but not the least, when you are designing such trials, if you use immune checkpoint inhibitors in the neoadjuvant settings, then you can go for a short-term surrogate endpoint like PAT-CR, and that shortens the duration of your clinical trial. However, the disadvantages are with immune-related adverse events, there could be a potential delay in surgery. We have some attrition of patients during neoadjuvant therapy, depending on how long the neoadjuvant therapy is going to be. There's a potential risk of increased surgical complications. If you use these agents in the adjuvant setting, then you eliminate some of these concerns, like there is no surgical delay, potentially less surgical complications. However, there is also less compliance and tolerability. Patients often become weak, they have surgical complications, and they're not able to tolerate these agents. Besides, there is a hypothetical risk of potential immune suppression from surgical stress and those complications. And when you are designing an adjuvant study, you have to go for longer endpoints like disease-free survival or overall survival, which makes designing some of the studies very challenging. Having said that, many newer studies are using the immune checkpoint inhibitors in the adjuvant setting as well as in the neoadjuvant setting. One of such studies were discussed at the ASCO annual meeting this year. It was an Asian study that included patients with T3 or higher or node positive gastric or G-junction adenocarcinoma, and patients were randomized to receive either chemotherapy or chemotherapy and toripalimab, which is an anti-PD-1 checkpoint inhibitor. The primary endpoint was TRG01, or rate of pathological complete response or near complete response. And as you can see here, the study made its primary endpoint. The PATH-CR or near PATH-CR was improved from 20% to 44% with the addition of toripalimab. In terms of side effects, they were very similar. So overall, this regimen was considered to be not only effective, but also tolerable. And these results were concordant with another study that was presented at ASCO last year, and that was Dante study that used atezolizumab, and we saw an improvement in PATH-CR. And there are several ongoing studies, which we will discuss later, that are taking this approach and are combining immune checkpoint inhibitors with perioperative chemotherapy. Now, shifting gears to adjuvant setting, as we discussed that in Asia, it's often a practice to do an upfront D2 resection and then give patients adjuvant chemotherapy. So this study, or Attraction 5 study, was a phase 3 double-blind placebo-controlled study of Asian patients who had gastric or G junction cancer, had stage 3 disease, and had a D2 gastrectomy, were randomized to receive either nivolumab and chemotherapy or placebo or chemotherapy. The primary endpoint of the study was a recurrence-free survival by independent central review. And as you can see here, it was a large study, so 755 patients were randomized. And if you look at the baseline characteristics, they were well balanced between these two groups. It was all Asian studies, so patients were enrolled from Japan, Korea, Taiwan, and China. And chemotherapy regimens included S1 or KPOX, which are again standard regimens in Asia. Unfortunately, the study failed to meet its primary endpoint. So as you can see here, the recurrence-free survival was not different between these two groups. So when analyzing these two studies, we saw there was one positive study and then there was one negative study from Asia. So what could have possibly gone wrong with the Attraction 5 study? One, it could be that the timing was wrong. As we know, that with neoadjuvant therapy, we get to treat patients earlier as opposed to adjuvant therapy when we are starting it a few weeks after the surgery. So could that have made a difference? Possible. Now, the second issue is that with neoadjuvant therapy, you have the intact tumor that leads to better immune profiling. Whether in adjuvant therapy, the primary tumor is already resected. So that could have also contributed to the failure of this adjuvant study. Compliance to treatment. When we use agents in the neoadjuvant setting, usually there's greater than 90% compliance with the pre-op treatment, as we saw in the study here, versus just 60% completion of post-op treatment. Sometimes it's even less than that. So that would have contributed to the failure of Attraction 5 as well. But last but not the least, we have to see if the changes in PATH-CR ultimately leads to better outcome or survival. So we have to wait for the long-term results from these studies of the Dante trial. And this is something we will learn about in the coming few years. However, we are also going to learn about the results of Keynote 585 as well as Matterhorn study. Both were very similar in design. Patients receive perioperative chemo with or without an immune checkpoint inhibitor. And hopefully we'll learn about the survival data from these studies within the next 1 or 2 years. And if positive, they could be practice changing. So in conclusion, chemoimmunotherapy is a potential new first-line treatment options for patients with unresectable or metastatic esophagogastric cancer. And again, immunotherapy will likely become more important in the neoadjuvant setting or in the perioperative setting in combination with either chemo or chemoradiation. And future clinical trials will need to assess novel combinations beyond PD-1 or PD-L1 inhibitors and anti-CTLA inhibitors, along with standard treatment like chemotherapy and radiation. Finally, I would like to thank my colleagues and Dr. Elizabeth Smith and Dr. Alba Tran for letting me use their slides. And most importantly, the patient and their families who participated in the clinical trials and therefore allowed us to advance science. Thank you for listening.
Thank you very much. Thank you very much, Dr. Sarvajit. And it was really a nice presentation and really a new insight, because GE junction, as you know, is a big problem for many parts of India. And we do face a problem treating this disease. Lot of surgical challenges, a lot of medical challenges. Thank you very much for enlightening us on this particular topic. And we are sure you will help us with our next meetings. Definitely we'll try to see that we suit to your time. Thank you very much once again. Now, our next presentation would be by Dr. Ankur Varshne, who is an associate consultant at Medanta. Dr. Ankur, please.
Good evening, sir.
Dr. Vithala, please see where are the slides.
Dr. Ankur. Dr. Ankur. Priyanshi, can you please assist Dr. Ankur?
I have to share the slides.
Dr. Ankur, do you want us to share the slides? I'm sharing.
Okay, sir.
Thank you, sir. Now, is it visible?
No, yes, sir. Yes, sir, it is visible.
And the important questions, are they moving now?
Yes, sir.
Okay.
So you can
Request
do
you
on
to kindly
slideshow
run the
mode.
slideshow.
Yes.
So, thank you all, and good evening, Pandar sir. Thank you for giving me this opportunity. And I'm going to speak on managing stage 3 NSALC in real life scene.
So sorry to interrupt, but can you do on slideshow mode?
Is it okay?
No, sir. Down there is a button. Yeah, click on that and
Okay, can I start?
sir, it is not on slideshow mode, but okay, you can start. No issues. So you can start.
Okay.
It's okay.
So I start my presentation with a simple case which we used to see in our day-to-day practice. It's a 52-year-old male presented to us with a chief complaint of persistent weight loss and dry cough. There were no associated comorbidities, and a chest X-ray which was done as a preliminary investigation showed evidence of radiopacity in the left upper and middle lobe of left lung, with perilesional haziness and mild bilateral apical thickening was seen. When we go for a CCT chest, it showed a large heterogeneous enhancing lesion with necrotic component involving the apico-posterior segment of left upper lobe, suggestive of a neoplastic lesion, and there were a few subcentrometic and enlarged mediastinal nodes which were considered as a part of metastatic disease. So we go for a PET-CT scan, and this clearly showed us a large 7 into 8 centimeter mass lesion in left upper lobe, which was abutting the costal and mediastinal pleura in the apical segment, making it T4 in the staging system. And the mass was abutting the arch of aorta and encasing the upper lobe bronchus, with mediastinal present lymph nodes present to the left and the right side equally. Thus, the upgrading the stage to the N3 node And the clinical staging of this patient was stage 3C. CT-guided biopsy from the left lung lesion shows a poorly differentiated adenocarcinoma. And when ISC was performed, it was TT1 positive, CK7 positive, and P63 was occasionally positive. So the complete diagnosis arrived was adenocarcinoma left lung, the clinical staging T4N3M0, stage 3C. So now just to have a major idea, what are the different divisions of stage 3 as per AJCC 8 classification? Now stage 3A includes either T1, T2 lesions with involvement of N2 lymph nodes, which includes ipsilateral mediastinal lymph nodes, or T3, T4 lesion with either N1 involvement or a single T4 lesion without any lymph node involvement. Now stage 3B, it includes a T3, T4 lesion or N2 involvement, or a T1, T2 lesion with an N3 involvement. Now stage 3C is particularly advanced, which includes either N3 with any T lesions, with any T3 or T4 lesions. Are they moving clearly now? It is already clicked. Are they visible now?
Well, let's go.
Okay. So we now why was this staging classification was needed? And we see this staging classification was needed because different stages have a different 5-year-old survival. If it was a stage 1A, the 5-year-old survival close is around 90%. While when it progresses to stage 3, the survival diminishes from stage 3A to 3C. In stage 3A, 5-year overall survival is around 30 to 40%, while in stage 3B, it goes into 26% around. While in stage 3, it is less than 20% 5-year survival, and stage 4A has a minimum 5-year survival as 10% only. So coming to how do we stage lung cancer, we usually do with either non-invasive staging or invasive staging. In the non-invasive staging, we include CT scan, PET CT scan, and brain MRI is included now in every patient of lung cancer as a part of a staging protocol. While in invasive staging, we include either a surgical technique like mediastinoscopy or anterior mediastinoscopy or VETs. While in non-surgical technique, it includes invasive procedures such as endoscopic ultrasound or endoscopy guided bronchoscopy. Now, PET CT scan is widely used these days, and many studies and comparison trial has showed that PET CT scan has greater sensitivity in detection of mediastinal lymph node involvement. The study shows, which incorporated 4,000 patients, showed that PET CT scan had a sensitivity of 80% in detecting mediastinal lymph node involvement in patients with lung cancer, and it has a specificity of 88% in detection of these lymph nodes. When coming to the invasive procedures, mainly all these procedures have a great sensitivity and high specificity, but they include the complication of being an invasive procedure. Then coming to the overview of treatment, in stage 1, it is usually a surgical treatment, and radiation can be considered if patient is considered inoperable or the region is unresectable. In stage 2, surgery is usually followed by adjuvant chemotherapy. In stage 3, we usually classify these patients whether the patient can undergo neoadjuvant chemotherapy followed by surgery, or the definitive, it is a concurrent chemoradiation followed by consolidation immunotherapy, which we will study in the next slides. In stage 4 or patients with recurrent disease, the treatment is either a combination of immunotherapy plus chemotherapy or targeted therapy, or if patient is having a poor performance status, we go with supportive care. Now, in patients with unresectable stage 3, who are not candidates of surgical therapy, the goal of the therapy is to achieve both locoregional control as well as systemic control. The high risk should be considered for the brain, which is the sensory sites or mets, and brain involvement is quite common with patient presenting to us with asymptomatic brain involvement. Now, this patient, as we initially diagnosed adenocarcinoma left lung, having a T4 and 3 disease, and the issue is question which came to our mind is what would be the next logical step for this patient. It's either a opinion for surgeon or plan for surgery, which is highly not advisable in this case, as both the contralateral lymph nodes are involved, and there is involvement of both coastal pleura and mediastinal pleura. Now, the other option is neoadjuvant chemotherapy, which can be done with restaging, or upfront we go with definitive concurrent chemoradiation. Coming to this patient, we started this patient on chemotherapy alone as a part of induction chemotherapy protocol. The patient was given injection paclitaxel 100 milligram per meter square on day 1, 8, 15, along with injection carboplatin with AC5 on day 21 alone. During the treatment, patient had a hypersensitivity to paclitaxel and it was changed to nab-paclitaxel. Post 3 cycles, patient was assessed via PET CT scan and it showed a partial response to therapy. Now, the question is, what is the role of induction immunotherapy in patients undergoing CRT, and whether these patients are eligible for further immunotherapy or not? Now, the Pacific trial, which established durvalumab as a part of consolidation therapy in patients undergoing CCRT, in this trial, when we go to the subgroup analysis, around 26% of patients have undergone induction chemotherapy with the chemotherapy arm in both the durvalumab arm and in the placebo arm. Thus, we show that induction chemotherapy done by definitive chemotherapy improves the outcome in this patient cohort. So after this patient induction therapy with 3 cycles were completed, he received a total dose of 66 gray in 33 fractions by RGRT technique, along with weekly injection paclitaxel and carboplatin. He tolerated this treatment well, and as per the issue, the question now raised is whether the treatment should be definitive chemotherapy, which includes either concurrent chemoradiation or sequential chemoradiation. Now, various studies have shown that concurrent chemoradiation has improved outcome, the sequential chemoradiation. And there is a Kindle study which has the real world data of 3,000 patients of stage 3 lung cancer. Definitely, the maximum OS benefit was in the arm who undergo surgery followed by adjuvant chemotherapy. But these were 3A stage patients. And in the later arms, in the later stage 3 patients, either RT or sequential chemotherapy followed by RT or a chemotherapy alone, the outcomes were most favorable in the patient population who have undergone concurrent chemoradiation. Now, assessing what are the scientific literature shared about the role of consolidation therapy in patients with unresectable NSCLC, and what was the previous existing literature. Now, previously, many studies have evaluated the effect of consolidated radiation chemotherapy, which includes either docetaxel with cisplatin, or pemetrexed after the definitive chemotherapy, concurrent chemoradiations. There was also a study showing use of targeted therapy such as geftinib and consolidation with cetuximab. But all these studies, as we see, in none of these the hazard ratio is significant and p-value is not significant. Thus, either in all the studies failed to show any PFS or OS advantage. Now we coming to this case. After 4 weeks of treatment, the patient had developed radiation pneumonitis and was started on steroids. After 4 weeks of treatment, the patient has resolution of symptoms and the steroids were tapered. Now, there was a caution whether to give this patient on immunotherapy or not. And now we will study what was the study that led to introduction of consolidation immunotherapy in this patient cohort. So the study was specific studies which include patients with stage 3 locally advanced unresectable non-small cell lung cancer patients who have not progressed following a definitive platinum-based concurrent chemoradiation. Progress among them, either the patient have a stable disease or had a partial response. The patients were includes 18 years or older as every clinical trial, and have a preserved performance status score of 0 or 1. The estimated life expectancy of these patients was greater than 12 weeks. Now, these patients, within a span of 42 days, were randomized in the ratio of 2:1 to either receive durvalumab 10 milligram per kg IV every 2 weekly up to 12 months, or to receive placebo treatment. The endpoints were PFS and OS, and secondary endpoints were overall response rate, duration of response, safety and tolerability of this drug. Now, after all the patients received, as I told you earlier, that in around 26% of patients in this patient cohort received induction chemotherapy prior to the start of this study, prior to the start of concurrent chemoradiation. And when we see the results of this study, then durvalumab showed a significant overall survival benefit. At the end of 5 years, the patient population in the durvalumab arm, 42%, the survival was 42%, while in the placebo arm, it was only 33%. Thus, it was the immunotherapy to demonstrate a significant OS benefit at 42% at the 5-year interval. When we saw a PFS advantage, this PFS advantage was again retained, and in the at the 5 years, 33% patient in the durvalumab arm had the PFS benefit as compared to 19% patient population in the placebo control arm. Median OS in the durvalumab arm was 16.9 months as compared to the placebo, which was only 5.6 months. Thus, the only durvalumab became the only immunotherapy to show a sustained and durable progression-free survival of 33% benefit at 5 years. If we see the divisions and the subgroup analysis of this study, then we see that this benefit was present irrespective of the tumor histological subtype. So the difference, the benefit was more in the adenocarcinoma arm. The difference was benefit was maintained in the squamous cell cancer arm. And when we go to the PD-L1 status, definitely is immunotherapy, the difference was more pronounced in patient population who have PD-L1 status greater than 25%. But the benefit was also shown in the patient population who were a lower PD-L1 expression and in those who have an unknown PD-L1 expression. The only arm which does not show a significant benefit was EGFR inhibitor arm, which showed a lesser advantage of this drug. Now, if we see the updated OS and PFS in this and in the subgroup, we see that OS and PFS difference was benefited in all the subgroups, whether it's the presence of smoking status, exact disease status, tumor histology subtype, prior chemotherapy use, and definitely the difference was good in the patients who have achieved complete response to therapy, but the difference was maintained in the partial response and stable response also. So now the questions arise in our mind that what is the appropriate time after which we should assess the patient at the end of concurrent chemoradiation, and what parameters would like to assess during the first assessment, and what is the best time to start this therapy after completion of concurrent chemoradiation. Now, coming to this patient, in this patient, the patient was planned for immunotherapy and the patient was admitted after the completion of 82 days of concurrent chemoradiation because the patient developed radiation-induced pneumonitis and steroids were used, and steroids are avoided to be used with the immunotherapy. So after 3 months of immunotherapy, we assessed the patient, and the patient was showed significant reduction in the size and FDG avidity of the lesion seen, and denoting a good therapeutic response to immunotherapy. So the first real life data of durvalumab after concomitant chemoradiotherapy was published. This includes the analysis of 591 patients from France. The inclusion criteria in this study was unresectable stage CLC, and there was no disease progression after 2 or more prior cycles of platinum-based chemotherapy with total radiation of 60 gray. Patient were with preserved performance status of either 0 or 1, and durvalumab was initiated within 42 days of end of radiation. So we see that the disease control rate was present in the 74% of the patient population, which is highly significant as compared to the other treatments CR was seen in the 10% of population, partial response was seen in 20% of the population, stable disease was more prevalent seen in 43% of patients, and only 21% patients shows up progressive disease. If we compare both durvalumab and placebo control arms, we see that either all the responses were significant, and durvalumab showed a significant or complete objective response as compared to the placebo. There's the 40% of the patients who were initiated in durvalumab after 42 days post concurrent chemoradiation, and the responses were similar to what was observed in the Pacific study, despite the patients have delayed initiation of durvalumab in this cohort. So we see that it is advisable to start durvalumab early, but if due to some reasons initiation is delayed, we can start it later after. And we followed this case. After 51 weeks of immunotherapy, the response were...
Ankur.
Yes, sir.
Can we go slightly faster?
Okay. We continued that the responses were maintained, and there is the status is with the use of this immunotherapy, a 5-year-old survival benefit is initiated, and now all the expert guidelines, either NCCN or ESMO, includes the use of durvalumab as a consolidation immunotherapy. And now, concluding my presentation, the key takeaway is that concurrent chemoradiation gives better outcomes than RT alone or chemotherapy alone. Consolidation chemotherapy doesn't have any outcomes. However, the use of immunotherapy had a significant OS and PFS benefit, and durvalumab should be considered as a treatment option in unresectable stage 3 patients who have not progressed on CTRT, irrespective of the PD-L1 status. Thank you.
Thank you very much for presentation and agreeing to present here, and really extremely grateful. So our next speaker is Dr. Vishnu from Sarvodaya Hospital. Dr. Vishnu is a DM Oncology from Trivandrum, and has worked at many places. He's working with Sarvodaya now. Dr. Vishnu, please go ahead.
Hello, am I audible?
Yes, sir.
Good evening, sir. Good evening, all. Today, I'll be presenting the topic role of immunotherapy in triple-negative breast cancer. It is a Roche-sponsored topic, so I'll be mainly focusing on atezolizumab in metastatic triple-negative breast cancer. Triple-negative breast cancer, as we all know, is a diagnosis of exclusion based on negativity of receptor status. It constitutes around 15% of all breast cancer cases. It is a highly heterogeneous group of cancer. Metastatic triple-negative breast cancer has got a poor prognosis and higher mortality rate compared to other breast cancers. Median overall survival associated with metastatic triple-negative breast cancer is 17.5 months with conventional chemotherapeutic agents. Around 20% of the metastatic triple-negative breast cancers are associated with a mutation in the BRCA genes. So our increased molecular understanding of triple-negative breast cancer is reshaping the treatment approaches of TNBC. The unique molecular features of triple-negative breast cancer include a defective DNA repair due to BRCA gene mutation, increased immune signature expressions, expression like high expression of PD-L1 and PD-1 molecules, and some TNBCs may be associated with androgen signature expression and abnormalities in kinase pathways like PIK3CA, AKT, and PTEN pathways. Around 90% of triple-negative breast cancers are associated with expression of unique antigens like TROP2, which is a target for the new antibody drug conjugate sacituzumab govitecan. Historically, metastatic triple-negative breast cancer has been treated with single agent or combination chemotherapeutic agents. The most commonly used first-line chemotherapeutic agents are anthracycline-based chemotherapy, a taxane-based chemotherapy, or platinum combination. In some countries, taxane plus bevacizumab are also approved for this indication. In second-line setting, the most commonly used chemotherapeutic agents are capecitabine, platinum combination, and eribulin. So now there is a shifting paradigm in the treatment of metastatic triple-negative breast cancer. Chemoimmunotherapy is a suitable treatment approach for metastatic TNBC and is now considered as the standard of care for metastatic TNBC, which have a high expression of PD-L1. It is because of the presence of increased presence of mutations, high expression of PD-L1 in TNBCs, and because of the presence of high number of tumor-infiltrating lymphocytes in metastatic TNBCs. The targeted approaches to metastatic TNBC treatment include PARP inhibitors in case of BRCA mutation, targeting the PI3 AKT pathways, combination chemoimmunotherapy or targeted agents, and additional drugs like antibody drug conjugates, sacituzumab govitecan, AR inhibition, and histone deacetylase inhibitors. So now the treatment guidelines for metastatic TNBC include, in case of germline BRCA mutation, the first line of treatment is PARP inhibition. In PD-L1 positive metastatic triple-negative breast cancer, chemotherapy plus immunotherapy is considered as the standard of care. Both atezolizumab and pembrolizumab are approved for an indication. In some countries, bevacizumab plus paclitaxel is also considered as a first-line treatment for metastatic triple-negative breast cancer. While in second-line treatment, the most commonly used drugs are sacituzumab govitecan or single or a combination combination chemotherapeutic regimens. And in later lines, treatment is mainly consisting of single-agent chemotherapeutic agents. So coming to the recent advances in chemoimmunotherapy treatment of metastatic triple-negative breast cancer, atezolizumab is a highly selective PD-L1 inhibitor. It prevents PD-L1 binding to PD-1, which causes inhibition of the active T cell in the tumor microenvironment. In the lymph nodes, in addition to PD-L1 PD-1 interaction blockade, it also blocks PD-L1 interaction with B7.1 or CD80, which is a co-stimulatory molecule in the T cell, thus priming the activation of T cell in the lymph nodes. In normal tissues, it is a highly selective PD-L1 inhibitor, and thus preventing PD-L2 PD-1 attachment, and thus reducing the incidence of autoimmune manifestations. So atezolizumab is approved for this indication based on the IMpassion 130 study, which is a landmark phase 3 randomized control study in which around 902 patients were included. The inclusion criteria were histologically documented metastatic or inoperable locally advanced triple-negative breast cancer. No prior therapy for advanced triple-negative breast cancers were included. Prior chemotherapy in the adjuvant or neoadjuvant setting were included with a DFI of more than or equal to 12 months. The stratification factors were liver metastasis, prior taxane exposure, and PD-L1 status. PD-L1 status is PD-L1 positivity is considered as more than 1% staining of immune cells in the tumor area using SP142 Ventana assay. So the patients were randomly assayed in a 1:1 ratio into atezolizumab paclitaxel arm versus placebo nab-paclitaxel arm, and they were treated until disease progression or until unacceptable toxicity. The co-primary endpoints were PFS and OS, and secondary endpoints were overall response rate, duration of response, and patient-reported quality of life outcomes. So this was the randomization plan. Around 40% of the patients were PD-L1 positive. The baseline characteristics were well matched. Approximately half of the patients in both arms were previously treated with a taxane-containing regimen in the neoadjuvant or adjuvant setting. The rationale for combining Tecentriq and nab-paclitaxel were This combination was found to be highly effective and synergistic in the preclinical mouse models with a durable anti-tumor response. This combination has been associated with an increased number of tumor-infiltrating CD8 plus T cells and increased expression of neoadjuvant, which improves the response to atezolizumab. So, in the final PFS analysis, there was a significant improvement in the PFS in the intention to treat population and in the PD-L1 positive arm with a significant p-value. The median PFS in the PD-L1 positive arm was 7.5 versus 5 months in the placebo arm with a hazard ratio of 0.62. In the first overall survival analysis, there was a meaningful improvement in the overall survival in the PD-L1 positive subgroup. In the intention to treat population, the difference was not statistically significant. So they did not formally tested the survival advantage in the PD-L1 positive group, but still there was a meaningful benefit of approximately 9.5 months in the PD-L1 positive subgroup. And this survival benefit was sustained in the second and in the final and third analysis. In the final analysis, the median overall survival in the PD-L1 positive group was 25 months versus 18 months in the placebo arm, with a 3-year overall survival rate of 36% in the PD-L1 positive group, in the atezolizumab group, and 22% in the placebo group. And this overall survival effect was consistent across most of the subgroups. And the safety data were also consistent between two groups. There were no new safety signals were observed with the addition of atezolizumab group. Atezolizumab did not compromise the delivery of nab-paclitaxel. The mean dose intensity was 87.7% in the atezolizumab and 90% in the placebo arm. There were no differences in the grade 5 treatment-related adverse events between both arms. As expected, the immune-related side effects were higher in the atezolizumab arm, but there were no increased incidence of grade 3 or 4 adverse events. So it was the safety profile was considered. It was considered as a tolerable regimen. And most of the common side effect adverse events in both groups were comparable. And in the quality of life analysis, there was no clinically meaningful deterioration in the quality of life between both groups. So in summary, IM-PASSION 130 was the first study to demonstrate a benefit with first-line chemoimmunotherapy in metastatic triple-negative breast cancer. Tecentriq plus nab-paclitaxel was the first therapy to cross 2-year landmark overall survival benefit in PD-L1 positive first-line metastatic triple-negative breast cancer. The overall response rate was 59% in the Tecentriq arm versus 43% in the placebo arm. Consistent overall survival results were observed between the first, second, and the final analysis, with the benefit ranging from 20 to 30% benefit in the atezolizumab arm. In the final OS analysis, the overall survival difference in the intention to treat population did not cross the boundary for statistical significance. However, the magnitude of overall survival benefit in the PD-L1 positive population was approximately 7.5 months. There were no new safety signals were identified as part of updated safety assessment at the final OS analysis. Patient-related outcome data indicated that patients in both arms maintained baseline quality of life and functioning for similar duration. Based on this data, it is atezolizumab or pembrolizumab in combination with chemotherapy is considered as the first-line treatment in metastatic triple-negative breast cancer with a PD-L1 positivity. It is approved in the German group by the ESMO and by the NICE guidelines. Thank you.
Thank you very much. Thank you very much, to Vishnu, for nice presentation. So today, the whole meeting was focused on immunotherapy. So this topic of mine, we will be taking in the next session because we have really overshooted our time. So we would like to thank all the participants who attended, who listened to us, all the students who agreed to present virtually and who did a great job by reviewing immunotherapy. Immunotherapy is definitely a very, very important topic. Immunotherapy is extremely important for all of us today, despite us not being able to prescribe it with the frequency which we would like. There are many controversial issues. Which is best in which situation? Hello. Hello.
Yes, sir.
Hello, can you hear me?
Yes, sir, we can hear you now. So Dr. Edwin is
Okay,
there.
so thank you very much.
Sir,
And
Dr.
I'm
Edwin.
grateful for really giving us time. I'm very grateful to the faculty and the attendees. I'm sure all of us must have learned a lot of things from today. And we would thank my ideas for conducting the program in a day.
Dr. Dinesh sir, sorry to interrupt you here. Dr. Edwin has joined the meeting.
You invite and start, please.
Dr. Edwin, very good morning to you. It's our pleasure to have you on the meeting. And unfortunately, Dr. Dinesh sir's network
Hello.
is a challenge.
Can you hear me?
No, sir, your voice is breaking. Vitlaji, please continue.
Very good morning, Dr. Edwin. Dr. Edwin is Associate Professor of Oncology, Department of Medical Oncology and Cancer Genetics and Genomics. He is from Roswell Park Comprehensive Cancer Center, USA. So we are very thankful to you, Dr. Edwin, to make up to this meeting, and we really appreciate your Saturday morning time with us. So over to you, Dr. Edwin.
Hi, can you see me and hear me?
Yes, we can see you and hear you, doctor.
I hope I didn't mess up the time.
No.
It's all right. It's okay. We are really grateful.
So I think I'm sharing on ASCO updates for neoadjuvant treatment. Can you see my screen?
We can see your screen, sir.
All right, so a pleasure to be here. I'm Edwin Yao. I've been at Roswell for 6 years, and so
It's okay.
But this the neoadjuvant and adjuvant landscape for immunotherapy in non-small cell lung cancer has changed quite a bit in a couple of years, and it's about to get more complicated with the updates from this year. But basically, in 2021, we had the results of the Empower 010 with adjuvant atezolizumab following chemotherapy in non-small cell lung cancer. with benefit in the 2-year event-free survival. And then last year we had the results from neoadjuvant chemo and immunotherapy in Checkmate 816. And with a good 3-year event-free survival and a trend towards overall survival benefit. So these are both standard of care now. And then earlier this year we had the approval of adjuvant pembrolizumab as well in the adjuvant setting with the results of the Pearl study, which has been a bit more controversial. And so, neoadjuvant versus adjuvant therapy, we've been trying to figure out whether immunotherapy would be better before or after. In the chemotherapy age, didn't seem like it made much of a difference with the same overall survival benefit, whether we gave chemo neoadjuvantly or adjuvantly. So far, the trend, it seems like the neoadjuvant neoadjuvant immunotherapy may give you some more benefits in breast cancer preclinical mouse models when we give immunotherapy before or after surgical resection. The results are pretty better when we give immunotherapy neoadjuvantly in the preclinical models. And of course, we have melanoma data from the SWOG 1801 study suggesting that neoadjuvant immunotherapy gives some benefits. The hypothesized benefits of neoadjuvant treatment are that you have the full repertoire of tumor antigens available. You have intact lymph node drainage. You have perhaps an increased pool of TILs of tumor infiltrating lymphocytes, and perhaps early elimination of micrometastasis might be the greatest benefit. And the 3-year update of Checkmate 816 maybe gives us a hint that might be true, with the nivolumab arm at 3 years having 13% of patients with distant Mets versus almost 40% of patients on the chemo arm. Adjuvant therapy still has some benefits though, less delay to a curative surgery, especially for earlier stage. And definitely getting to the most important, the biggest treatment, which should be surgery in an early stage. So the trend has been to switch to more of a neoadjuvant approach when there's node positive disease, and so this is where we were before ASCO and AACR this year. This year has given us the readout of some of our perioperative studies where we gave chemo and immunotherapy before surgery, followed by a year of immunotherapy afterwards. And we're presenting today basically AEGEAN, which was interim analysis, was presented at AACR this year. NeoTorch, which is a Chinese phase 3 study, presented with an update at ASCO, and then the biggest study that will most likely be the most practice changing with the New England Journal article out, or the study published already, is Keynote 671. And these are all the phase 3 perioperative immunotherapy trials. We're still awaiting results from Checkmate 7070 and Empower 030. So just briefly, AEGEAN, this was presented by Dr. Haymock at AACR. This was treatment naive, good performance status, respectable. Stage 2 to 3B. And so this is a difference from Checkmate 816. Checkmate 816 included up to stage 3A. This 3B in AEGEAN and in Keynote 671 includes N2 disease with size only T4. They still excluded any N3 patients. So we added basically T4 N2 disease to the patient population. Again, no EGFR ALK mutants. And the AEGEAN study also did not allow planned pneumonectomies on study. And it is a randomized study, 800 patients, around 800 patients randomized to either Durva plus 4 cycles of chemo, platinum-based chemo versus placebo, followed by surgery, followed by a year of Durva. in the durvalumab arm. The platinum chemo in this case could include carbo or cis, and primary endpoints were pathologic complete response by central lab and event-free survival by blinded independent review. And this study was stratified by stage and by PD-L1 status. And so briefly, just some baseline characteristics compared to Keynote 671, Aegean had slightly more stage 3B patients. Also note that most patients got carbo, so 70% of patients got carboplatin compared to a third that got cisplatin. PD-L1 expression was sort of well balanced with our real world expectations. Compared to Checkmate 816, 816 had a higher percentage of PD-L1 negative patients. And similar to all the other studies, about 20% of patients undergo surgery and most get an R0 resection, with perhaps a trend towards more R0 resections in the immunotherapy arm. And the pathologic complete response rate was 17.2% compared to 4%. That 4% matches our historical controls with chemo. In comparison, Checkmate 816 had a 24% pathologic complete response compared to a 2% in the chemo arm. Given, that Checkmate 816 and all these perioperative had the same chemo immuno beforehand, I think we'll see the past CR rates for the other studies, but they're all in this 20% range. And they presented the 2-year event-free survival with 63% of patients event-free in the Durva arm compared to 52% with a hazard ratio of 0.68. Note this is shorter overall follow-up than either Keynote 671 or Checkmate 816. As far as a subgroup analysis, benefit was seen in all subgroups. And the pathologic CR rate definitely kind of as expected was higher in current smokers and in those with higher PD-L1 status. They also noted benefit in both cisplatin and carboplatin arms. And toxicities are as expected with the known agents. Going on to NeoTorch, this was a Chinese phase 3 randomized study that included stage 2 to 3 non-small cell lung cancer without EGFR ALK. This study was slightly different, so it was a Chinese-only study, and they did 3 cycles of the PD-1 inhibitor toripalimab with chemo for 3 cycles, followed by surgery, followed by 1 more cycle of chemo with immunotherapy, then the immune therapy for a year. They stratified by stage and by surgery, by histology, and by PD-L1. And they presented the interim EFS data for stage 3. So this was their data for only their stage 3 patients. And this study definitely had a high percentage of squamous cells. So this is different than the other studies with a very high percentage of squamous histology. Otherwise, similar to other studies, mostly 3A on this study as well. And similarly, about 20% underwent surgery. More people got to surgery in the immunotherapy arm compared to the control arm, with also a trend towards more R0 resections in the immunotherapy arm, and with a 9% pneumonectomy rate. This was the EFS data with a hazard ratio of 0.40 and a 2-year event-free survival in the immunotherapy arm of 66.7 compared to 46.1 in the chemo arm. So a pretty big difference. When we look at the subgroups, again, the higher the PD-L1 expression, the better the hazard ratio, and the more improvement with the immunotherapy, and squamous cells seem to have a much better EFS And again, this study, perhaps the improvement in hazard ratios because of the enrichment in the squamous subgroups. The pass CR rate, similar, about 24%. Perhaps it's a little bit higher than Aegean and Keynote 671. And then interesting, when we look at the path CR, of course, we know that patients who get a path CR all do much better. But here it does seem like those patients who did not get a path CR in the bottom curves, here, there does seem to be a good separation here. And we'll talk about this at the Keynote 671, but perhaps the year of immunotherapy may be trending towards an improvement in those who don't get a path CR. And so this was the biggest study, also published in the England Journal of Medicine with the presentation. This is Keynote 671. This is the one that will be most likely to be approved in the near future. So it's a global phase 3 randomized double-blind placebo-controlled study. This, just like Aegean, included stage 3B, meaning T4 by size, and N2, excluding N3. So basically, what we're talking about for all these perioperative studies is stage 2 to any N2 disease with the T4 by size included as resectable. This study is a little different. They didn't exclude EGFR or ALK patients, although as we'll see, the absolute numbers of those patients are very small. Also, just a subtle note of difference, Keynote 671 also excluded pan-coast tumors. Checkmate 816 did not exclude pan-coast tumors. And so about 786 patients randomized 1-to-1 to Pembro plus, and the chemo here was only cisplatin and restricted to these two regimens, so cisgem for squamous cells and cispem for adenos. Followed by surgery, followed by a year of Pembro, dual primary endpoints of EFS and OS, and the stratification factors you can see. So again, slightly less 3B patients than Aegean, mostly stage 3A patients, mostly N2 patients, balanced between squamous and non-squamous, and the PD-L1 stratification is about a third for each of the subgroups, which is what we usually see in our populations. And again, very, very small, limited amount of patients with EGFR and ALK mutations. And again, similar about the more patients went to surgery on Keynote 671 than the Pembro arm, compared to 40% in the placebo arm. A hazard ratio of 0.58, which is a bit better than the same time point at Checkmate 816, although the control arm here did a little bit worse if we're cross-trial comparing with the Checkmate 816. The 62.4% is similar to the 24% EFS in Checkmate 816. And again, the subgroup analysis kind of benefited all subgroups with seeming more benefit with smoking status and with higher PD-L1 status. Again, not enough patients with EGFR and ALK mutations to really make much of a conclusion. The one patient with the EGFR mutation didn't really have benefit to immunotherapy. The interim overall survival analysis, we can see the beginnings of a separation of the curve here with a hazard ratio of 0.73. And the pathologic CR rate is similar to Aegean, 18.1% compared to 4% in the placebo arm. And similar to the NeoTorch study, when we look at the patients who get path CR versus those who don't, the path CR patients all do well, regardless of whether you get immunotherapy or not. But here again, we see a separation in those without a path CR with a benefit in the hazard ratio of 0.69. Just for comparison, this is Keynote 671 on the left with the analysis by path CR. And this is Checkmate 816, which only included 3 cycles of neoadjuvant chemo plus nivolumab before surgery with no adjuvant immunotherapy. And you can see the curves in those who did not get a path CR don't seem as don't seem to separate as well. So that this may speak to perhaps some benefit to the year of immunotherapy post, but we await longer follow-up to look at the EFS and OS comparing. Again, no surprising adverse events with the one death on the pembro arm being from pneumonitis. And so this was adapted from Dr. Awad's presentation comparing, but when we look at the interim analysis of overall survival of the adjuvant studies, we don't see much separation in the curves yet in the adjuvant studies, but in the neoadjuvant studies, we see a separation in most of the studies presented. Perhaps again speaking to the benefits of neoadjuvant and perioperative approaches in immunotherapy. And then recently published, actually a couple days ago, Nadim-2, this was a phase 2 study looking at only 3A and 3B, looking at a carbotaxol-nivo regimen, followed by surgery, followed by 6 months instead of a year of adjuvant nivolumab. And Nadim, these studies have had a very high pass CR rates with 37% here. Nadim-1 had almost 60% pass CR rates. Again, with a carboplatin only arm and with the EFS curves that look very good. So the question on whether we can shorten that adjuvant immunotherapy from a year to 6 months remains to be seen as we await longer follow-up. So that's all I have. And I don't know if I'm happy to take any questions for if there's time.
Thank you, Dr. Edwin, for an excellent talk. In fact, your talk has really helped the audience and doctors in India today and across the other part of the country who have joined this meeting. It complemented the entire presentation on pre-op and post-op management of NSCLC patients. And your
Dr. Vitala,
complemented.
Dr. Edwin, thank you very much for really joining today and speaking. It was really great, and thank you to all your department. Special thanks to Dr. Sai who connected us with you, and we are really grateful for the team of Roswell who really helped us in today's meeting. Thank you very much once again. Thank you. Out the time on Saturday evening to come here. I am grateful to all the participants who came forward and helped us, for all the technical and people from industry and technology who helped us organizing this meeting. The event was organized basically to generate a new data, new information on immunology and immunotherapy. And I'm sure today's deliberations would have helped all of us in better understanding of immuno-oncology. Thank you very much. Thank you, everybody. And we assure you that we will be more regular with these meetings now because we really have a good bank of speakers, bank of faculty who is willing to assist us in really learning insights into oncology. Thank you very much. Special thanks to team of Mice Ideas for conducting this meeting. Thank you very much.